We still have drugs which were developed centuries ago for things like an anti-snake venom. We only have a polyvalent anti-snake venom, despite the fact there are more than 30,000 people dying every year due to snake bite. So what happens is, even though we have these capacities, applications are already there, the drug discovery is also, it is being, pushed by how much money you will make out of the molecule. There is no money to be made out of antibiotics, because everyone knows the bacteria are far more intelligent than human beings. They'll become resistant to it. So no antibiotic is going to last for more than 7-8 years, because we all use it badly, and therefore the bug will become resistant. So no company is interested in looking to manufacture an antibiotic, even though we have a huge number of resistant organisms. Yeah. So it is also being used for something known as precision medicine, because we want to know the genetic makeup, what is happening to the enzymes and so on. So there is a huge amount of work which is happening in precision medicines. We do large amounts of data analysis, biological data analysis. We can now go through so many systems and find out what is the DNA, what is the DNA makeup, what are the genetic problems, and so on and so forth. It is used for speeding up processes. Of course, it is used for speeding up a lot of processes. We do a lot of data storage. And of course, what is well known among surgeons is surgical robotics, rehabilitation, wellness. And almost a large chunk of healthcare management is already being done by AI. So whether we like it or not, it is all there. The applications are there. So the question is, how do we train ourselves as medical educators and also our students to use AI in an ethical, judicious, and responsible manner? That's the catch. Certainly they are going to use it. Certainly we are already using it. But how do we train them? So we need to train ourselves. We need to learn. And we also need to be able to tell them, use it, but use it ethically. Use it judiciously, use it appropriately. This is where the challenge lies. So I am very fond of Arthur C. Clarke because I was a great fan of his books. And in 1970, he wrote this: any teacher that can be replaced by a machine should be. So all the teachers got very angry. Everyone said, how dare he say that? And we bring so much of life into the subject and things like that. But actually he was quoted out of context. What he meant was, you need to free teachers of mundane tasks so that they can actually focus on teaching. So when you go and start teaching, it is not just about teaching, it's about making timetable, making sure another teacher is coming for your class. It is about making sure your exams are there, the marks are there, whole lot of other tasks. So he said, if this can be taken over by machines, let the teachers focus on teaching. That was what he was trying to say. And that was in 1970, okay? So what are the tasks medical educators can assign to AI? One is, of course, grading and assessment. I think it is time that we went and said that all grading and assessment should be by AI. If you see the way in some of the AI programs can interact, certainly they'll be able to read answers. So if you allowed the students to type the answers, and of course some can even read print, there will be nothing like that. So that should be, grading and assessment should be in a way. Of course, if it is MCQ or something like that, there's no problem with that. Administrative tasks, when to pay the fees, has somebody paid the fees, how much attendance, is somebody cutting the line for attendance, all this stuff should be given to AI. We should have admin chatbots in every head of the department should be able to have one. Data analysis and personalized learning paths. There are these huge universities. If you ask me how I would look at the teaching learning of the students at Geetham, I won't know. So we should be looking at that. How are they learning? What are their learning paths? Where are they falling short of learning? What more can we do to help them? These kind of things, and also personalized learning paths. There are students with difficulties. Some learn slower, some learn faster, so we can easily personalize their learning paths. Students themselves should be able to do it. Content creation. Hereafter, there is no need for us to be sitting with, opening 20 books and then, making our PowerPoints, or creating content for a handout, in a class, or creating content for anything. Content creation should be given to AI because they really do it well. And that is why it is very important that we also look at a little bit of quality. Because I was sitting, just last week I was at METAMORPHOSIS at JIPMER, and there was one session where they were saying how you make your entire content using Google Slides. So you don't actually need to put in that hard work anymore for content creation. Of course, I don't like Google. I don't like the slides Google makes. Let's put it that way. Virtual patient simulations. So they make these programs can easily make those cases, where you have these virtual patients and students can interact with them. Diagnostic assistance. We are already using it. We need to learn to assign that more so that you are not sitting there looking at X-rays or CT scans. That can be done. Your final screening, maybe you should take a look. But otherwise, all these things are easily done by them. Literature review and research. This is one of my pet peeves. I love teaching people how to do research. I've done it for a very long time. But I think it's being done better by some of the simple AI programs. And therefore, more and more of review of literature or even doing research as such, from identifying a problem to writing up a proposal, is being done by these programs. Okay? So we need to learn how to delegate our responsibilities to that. At the same time, you need to keep a grip, because otherwise you will just become like a technician. What are you doing? If everything is being done for you, where is your intellectual capacity being stimulated? So this is what I did. I am not a tech-savvy person, but because I had to come and give this talk last week when I was sitting in Pondicherry, I opened ChatGPT and I gave it a task. If you read it, I said, hi. So this is the prompt I gave it. I need one multiple choice question on surgical prophylaxis for final year medical students. It should be case-based with 4 detractors. This is the prompt I gave it, and within 4 seconds, I got this answer. It said, certainly, here's a multiple choice question on surgical prophylaxis for final medical year students. Case scenario, 65-year-old male with a history of hypertension, type 2 diabetes is scheduled for elective colorectal surgery. He has no known allergies. Which of the following antibiotics is the most appropriate choice for this? It gave 4 choices. My next question, can you tell me which is the answer? Why is it the answer? And why the other 3 detractors are wrong? And it gave the answer. Now, as a teacher, I can't tell you how many hours I have sat preparing multiple choice questions, because JIPMER had its own entrance exam, PG entrance exam, and all of us had to give some 20 or 30 questions every year. They used to pay us 20 rupees a question, and I used to take at least 2 hours to make one question. It's really very complicated to get good MCQs, because I had a very, very tough boss, and he will say, don't ask questions which say except, this is the correct answer except, this is the best thing except, or, but, and things like that. So it used to really take a very long time. And when I saw this, I was thinking, wow, how many hours I have spent doing this. So the point is, now at Geetham, I'm sure it's happening in your place also, we are trying to get our students become more accustomed to this, because this is going to be the way you are going to get a PG seat or not. So your teachers can easily set it up. You don't even have to think. Just go and see whether it matches their whatever we have taught, whether it matches with their curriculum or not. That's it, okay? So I'm just giving you, so once I got this, I started playing around. I made it prepare a theory question paper and, you know, all kinds of things. And it really did better than me, I would say, okay? So it's there. Now, for postgraduates, now postgraduate teaching is also another thing. So nowadays, many of our postgraduates, what they do is, this is what I heard from some of the PG teachers in JIPMER, they're using this, what is that, Sky Space. So when you give them a journal club, they put this paper through this Sky Space, that breaks it down for them, and then they come and present as if it's their own. So the problem here becomes, we are trying to teach students, or we are trying to teach postgraduates to be critically assess a paper, a journal paper. That's our idea. They should be able to critically assess. But they are getting somebody else to do it. And when they come and present, it's no longer their thought. The thought process is of somebody else's. That one has used all what information it has to give them. So the point here I want to make is, they are going to use it, whether you like it or not. If I ask my postgraduates, have you done it? Certainly they are not going to have the courage to tell me that they have done it. But they would be doing it. So how your problem as an educator is, how do we still get them to learn how to critically evaluate, number one. Number two, will that be actually necessary? In another 3 years' time, with the kind of information which is coming up, that no longer becomes a very important, let me say, skill set to have. Because you have other things doing it for you, that no longer becomes an important skill set. So we need to wrap our brains across what may probably, at this point of time, I personally think having, being able to critically evaluate a paper, to be able to, use your clinical decision-making skills based on evidence is very, very important. But there will come a time, very, very close future, where that will no longer be necessary. There will be things which are doing it for you. So this thing of training them may also not be necessary. So this can be easily used for PG teaching and PGs themselves. So it's not just us, but postgraduates will use it for revision. They are using it to simplify, to paraphrase, and so on. I had an ophthalmology professor tell me that he used to get his postgraduates to condense the ophthalmology chapters. For example, if it is glaucoma, he'll say get it condensed by ChatGPT. So that will condense it into 3 or 4 pages, and he says before the exam you just read these 3 or 4 pages, it has all the important points. So it's become that simple. Now my thing is, it's okay if you have read the full chapter at least once or twice. But without reading the full chapter, now you are reading only an abridged version. So your knowledge is limited to that. And to me at this moment, that's not a very good thing. So we are already familiar during COVID times, we have been introduced to all this, Mitra and something in Italy and all that. So these things are already there. We get medicines which are delivered and things like that. So these are already there. Now we are all, how many of you, I just asked the students, how many of you are familiar with ChatGPT? How many of you have used it? And the girls are not even, only the boys, huh? Girls also, good, okay. So ChatGPT, I think somewhere in October, early October or end of September, they brought in another thing. They brought in vision to it. So what they said is you can add visual images to ChatGPT. Of course, it's not available on the 3.5 version. It's only for the premium version. So it has new capabilities now. And what they say is these new capabilities, and it's not just, I'm just using it because I've played around with this. There are lots of other things there in the market, okay? I am not trying to promote ChatGPT by anything, this thing. So it helps in the learning process. So when you present a diagram, it can break down the diagram and tell you what are the parts. It can explain the diagram to you, okay? That's what they say it can do. So I am looking at it. This is my take on it. So supposing you put, it's a tutor at any level. So if you are a first year student, you want to put a picture of a cubital fossa, and you ask, I want to know what are these things, brachial artery and median cubital vein and things, cephalic vein and all that. It will tell you what they are. So what ChatGPT did was, one of those people, they put a picture of a cell, and he asked, I want to know the parts of the cell. So it gave the different parts and explained. So he said, this is too complicated for me. Break it down to make it more simpler. And it did. It said, imagine a cell is like a city, and the nucleus is like the capital of the city, and the mitochondria is like your power grid. So it made it so simple, and if you want it simpler, you say, I want it simpler. So look at the immense possibilities learners can use, and teachers, we can tell our students, use that to get yourself, learn it at a lower level, and then you can come on to the higher level. So it is giving out bite-sized information. The second thing is, it helps now to understand complex messages. So what the user did is, he put a very complex image and asked it to explain, and it did. And I'll put one image. This image, I think many of us are familiar, where when we teach equality versus equity, in ethics, when we teach equality versus equity. So when you put this image, it immediately will interpret it. So it also thinks in that terms. What does this image have to say? Okay, it's of course getting the information from the web. So it's able to interpret the meaning of an image. So in medical education, what can you do? You simply put a complex image and ask it to explain as a learner. And what it was able to do is, somebody put up from the Gladiator, they put one shot of Russell Crowe, and they asked, which movie is it? What was he saying during this clip? It immediately told what movie, who's the actor, what was he saying. Okay? So you need to look at how we can use these things. I would use it for surgical videos. I would tell students, you upload a surgical video, stop it at any time, ask the student, you test yourself. You identify, you write it down, you test whether that is the correct thing. So it's very, very simple to use it to quiz students, to enhance, allow them to learn on their own. So one of the things which is the takeaway is, when we are using artificial intelligence, students will not spend their time playing PUBG or Roblox or whatever it is. They probably will be spending time using this, because it's more like a game. So another thing is, one user, what he did, he put this thing on his whiteboard, where he had made a sort of some diagrams to draw. He wanted to make a code, write a code. And with this diagram, ChatGPT wrote the code, and he could run it. So if I were you, I would give a series of diagrams and say, I want you to make an algorithm. It makes mind maps. Okay? It will give you a fishbone diagram if you give some points. So it has huge capabilities already inbuilt. Now, another thing which they have started is, one person took a photograph of this parking signs, which are very complex in the West, and asked, can I park now? It immediately said, yes, you can park. Okay, so now so people are using it for everyday work, every day-to-day thing. So this is how somebody's, I think their annual diary looks like. So if you want to ask, students want to ask, when I want to start studying 1 week before the exam, when should I start studying? It will immediately tell when you should start studying, send it to your calendar. So that 1 week before your test, it will tell you you're having a test on such and such a day, you start studying. So we need to look at how we can use the new capabilities of these, and these are coming up at an astounding rate. It's not that it was, see, as I knew ChatGPT, we were just discussing it and all that, and suddenly I am seeing this in no time. So a huge number of things are there, including uses in laboratories, where they use it to, we have an entire, how they teach people to walk and things like that. So you already know these applications, And so therefore it's an amazing thing, and it's an amazing time in which we are in. So already they have started a course in which there is a 5-year program in the University of Texas where they are teaching both medicine as well as artificial intelligence. So they will get 2 degrees. They will get an MD as well as a Master of Science in Artificial Intelligence. So these courses have started. It's just about a matter of time before already I think IIT Kharagpur and IIT Guwahati already having medical colleges. So in no time they are going to start, probably they will start these courses. That's my take on this. So what are the issues of concern? Yesterday we had a very good talk about the issues of concern, ethical and things like that. So privacy of data, so I'm not going to go into that too much, but all these things happen. And one of the things is about this transparency, which also was spoken about by Animesh, because when they make this artificial intelligence, their algorithms is like a black box. You really can't see inside it. And so it becomes very difficult when things go wrong. So you need to have this, there has to be transparencies, bias, that was also explained yesterday, security, training, and standardization. So these are some of the issues of concern which has been brought about in that task force report also. So it's been taken care, it's being, what shall I say, addressed in some way, may not be fully, but we need to keep this in mind. So our role as educators is to ensure that students realize the versatility, keeping in mind the concerns, and that's very important. If you think that when you take an, let's say you're taking an ECG, and the ECG machine is saying this is a normal ECG rhythm, and actually for some reason it has missed the ST depression, or some QRS complex is not, if it has missed and you are not seeing it, that is wrong, because there are many times the machine can go wrong. You need to keep that in mind, and that's the concern which I think most of us have about using artificial intelligence, especially for diagnosis, when sometimes machines can make mistakes. That is what we need to this thing. So this we spoke about yesterday. So this incident actually occurred in 2015, and for some reason now it is coming up in all our WhatsApp groups and things like that. Now the issue was, as it was told yesterday, this guy wasn't properly trained, and he was so full of himself that he thought nothing can go wrong. But when something went wrong, they couldn't do anything. When you see robotic surgery, there are also some deaths. That doesn't mean to say it should be stopped. From that time when the study was published to now, there have been huge amount of tweakings which have gone on with the system. Systems have become safer. They have lots of backup plans and things like that. But the important thing is that we need to understand that these are machines. So look at some of the things. There are broken bits of robot or tools falling inside the patient, 14.7%. Electrical sparking. Unintended movements, 2 patients died and 52 injuries. So things can go wrong. But that doesn't mean we should throw the baby with the bathwater kind of a thing. We need to address this, and certainly the systems will become safer and safer as time goes on. So again, the problem with AI is who is responsible. Is it the developer, the treating doctor, or the patient? So when something goes wrong, that's when something hits the fan, okay? Till then everyone is saying, oh, you come to us, we have the latest technology and all that. It's only when something goes wrong you don't know whom to, because people are looking to blame someone. So what are the risks of applying AI in healthcare? One is over reliance. Lack of situational awareness when things are going wrong. When we switched to a hospital information system, and I can tell you in AIIMS Bhubaneswar, till then we were doing everything manually, and then we said, no, it has to be through computers, and this is all 18th century business and all that. Very often electricity would fail. Backup will take some time to come. And there will be like 1,000 patients who are standing there crowding everyone, shouting. there is chaos, and the poor girls who are sitting in those cubicles who are trying to, give people, admit people or give them their OPD slip, get stuck, because by the time systems reboot, it takes time. So we have problems with simple issues with outside. They don't think that it is this thing. So if it ceases to operate, we need to have a safety net. And AI can make mistakes because it continuously learns from data. So if somebody is feeding wrong data, it should be feedback driven. And I'll tell you why. This is probably true especially for those of us who are looking at medicines. Because if you tell person, how do you get information, unbiased information, we look for it independently. We don't look at the drug producer, the drug manufacturer to give us information, right? But this unbiased information, if it is fed into the net by the drug company, we will be thinking that is good quality information. So we need to be very careful about that. So it continuously learns from the data. If wrong data is being fed, then it will take that. So we may not be able to capture the complexity of decision making using AI. So we need to keep this in mind when we are using it. So one of the things we can use, this again came up yesterday, you can leverage social media platforms. We can use VR and AR. I think a lot of medical colleges, especially in Andhra Pradesh, have wonderful labs which they are using this, and I'm so happy to see that is happening. We can create simulations. We have already spoken about that. Use this wisely and understand the value of blockchain technology, especially to keep some of the data you have made careful, especially about when you are giving tests and having university exams and things like that. So we need to learn how to use them and adapt them for our purposes. So how medical educators can use AI? Engage learners in a more concrete manner. As I said, yesterday we heard Chetna talk about this also. Offering hands-on training in a virtual setting. We have these immersive experiences where people are going into rooms which can be changed to any you can be in a community health center, you can be in a, quaternary care center. So you have these experiences which you can give your trainees. And of course, using this for research, whether we like it or not, they have already started using it. And then navigating the potential challenges. So this, I think, is the most challenging thing for all of us. How do we navigate the challenges? As medical educators, we need to keep up to date with this. So I'll just finish by saying, in anything we have these early adopters. No? People would jump and go and take this. So this already must have happened for all these AI technologies. Then there is one gap between somebody early majority who want to adopt it and the late majority. Some are never going to do it. So we need to make sure that most of the medical educators are in this 34%. That is the challenge right now. So of course there are technical limitations, as I told you, to adopting this, especially in a place like India. And we also need to overcome this, because otherwise the maximum potential will never be taken. So we can't keep saying that, we are having one old system, we don't have Wi-Fi, we don't have internet connectivity. We need to have these things. This has become a take. So it is up to us as medical educators to convince our management that these things are, this would be minimal requirement for medical colleges. So we need to make sure that these technical limitations are taken care of. So I'm concluding by saying that it has the potential to enhance the learning experience by improving diagnostic accuracy and also allowing teachers to focus on teaching. But we also need to look at the ethical concerns about protecting privacy and so on, which we spoke about in great length yesterday as well as today. And we need to keep in mind the technical limitations while we train students. We do need patience, because at the end of it, students are going to talk to patients. So if you put them in an air-conditioned room only to talk to computers, that's not going to happen. So we need to give them an all-round training experience. Don't forget, AI is not the only option. It is just an additional option which is available to us. So the task force said that people of India should have a national vision, which should be an open attitude towards judiciously using AI for healthcare. And I would include healthcare because we are a part of the healthcare educators. It should include a part of the training. And of course, expertise and experience of educators who serve as role models, they are invaluable. If you ask anyone, can you tell me one person who has been your role model? Each of us can. Not one, we'll have many people who are our role models. And so therefore, our role as teachers will remain. So our role, the role of AI should be to enhance rather than replace the roles of teachers and mentors. So that's what we need to keep in mind when we are using this. So technology won't replace teachers, but teachers who use technology will probably be replaced by teachers who don't use technology. This is going to happen whether we like it or not. So I'll just end with a quote. Technology will never replace great teachers, but in the hands of great teachers, technology will be transformational. Thank you very much.
Thank you very much, Madam Geetanjali. You very succinctly described to us the potential of AI with the right measure of caution. Any questions or comments from the audience? Quick, about 2 minutes, otherwise we'll close this session.
Ma'am, very good morning, ma'am. I have a question like, in undergraduate teaching or postgraduate teaching, when they're searching for the source of information by using AI, whether it is authenticated source, how would we can, that like whether it is of authenticated source or not?
So this is a problem which we have. We don't know because AI is picking up from everything. It might be authentic, it might be a non-authentic source also. We have no way of knowing. So the only way you can tell is after you get the information, you need to check also. So right now we don't know whether it is authentic or non-authentic. And I'll give you an example. In 1997, just after the MCI changed the curriculum, by 1998 we had made a series of practical, problems where we taught the students, undergraduate students in JIPMA, how to get authentic information about medicines, where to get authentic information of medicines. Because otherwise what was happening, most of the clinicians were getting information from the drug representative. So we wanted to teach our students, how do you get authentic information about, let's say, adverse drug reactions, or let's say about pharmacokinetics. So that time the internet was not really great. So we used to tell them, we used to give them British National Formulary, we used to give them some different textbooks and say, for this, look at this, this will be the authentic information. For this, look at this. They were all physical. So you need to teach them. So there will be a point where you will need to teach them, okay, you have got this information using AI, how do you check? So that is up to us to teach. So that at the moment there is no way we can tell.
Good morning, madam.
Yeah.
I have a question.
Yes.
Madam, actually in 3.5 version, as you mentioned in 4.0, the upgradation of the data is limited in 3.5 version until September 2021. Is it the same way in the 4 version, madam, like you are using?
No, I'm not using 4. I have not paid up for 4. I'm only using 3.5. So let me tell you, I don't know anything about ChatGPT except what I was figuring out for myself during that weekend, last weekend. That's all. So, but with that, in that few hours I spent, even in that I could get so much of information. That's what I want to tell you. See, if you spend a little bit of time as teachers, you all can really do wonders,
Thank you.
Yeah, but I'm not the good person to ask about it. I really don't know.
Thank you.
Ma'am, thank you. Ma'am, here, ma'am, chairperson.
Yeah, sorry.
Can I ask one question? Sorry.
Yeah.
Ma'am, you have spoken about multiple opportunities or ways in which we can use AI. One of them is grading and assessment. I just wanted to know what's your take on when we would like to, can we rely on ChatGPT or AI tool to grade a short answer or a long answer? Because MCQs is fine. Anyway, we have been doing it.
Ma'am,
But
I have
can-
not tried. I have not tried. But let me tell you, from the way it is so intuitive, I don't think it will be difficult. So all that you need to do is you please ask a question, put this answer and ask, is it correct? You need to play around with this. Right now, I haven't tried this. Has anyone tried? Yeah.
There's already a paper which is published. I think I made a reference the other day in workshop. So it's already been tried and they are using it for grading like essay type or something. But again, we have to train it and we have to put in the information that we want and then it will specifically look for. So you can do some trial this thing, feed it with some, some answers and then it will start. And then if you're okay with it, you can, but as ma'am said, it's just a matter of time. Very quickly we will see that it's being applied for it.
So you
Thank
can't
you.
go as examiner anywhere.
I think we'll go with this. I think we will still have place.
Yes.
Yeah, I mean, as Dr. Animesh said, let us say you're in a short or long question, you can type the keywords that were essential to make the answer appropriate.
Yes, yes.
And probably you can go back and see if they're present or they're not. That way you can save your time and you can flip on pages much easily.
Yes, it all depends on the prompts which you are giving.
Yeah.
For ChatGPT, it depends
Yeah,
on the
yeah.
prompts.
But
and
for
they
again-
say if you are courteous, it gives you better answers.
And not only the question setter should also have that in mind. That is the issue. Someone else sets the question and I answer them. I correct them. So that makes a difference.
So the problem will be there will be too many failures. Then you see. I don't know, but it would be a wonderful exercise to do. I think we should, with 250 students, why not? If we can use it, we should be able to use it.
Thank you, ma'am.
That was really a great presentation, ma'am. Now, after yesterday's and today's your presentation and all, I'm getting that curiosity. Take 1 week leave and sit with ChatGPT and do something, and let me enjoy my time with technology. It's so interesting, and very well you have said, especially the drawbacks that we need to learn a lot. So it's very, very interesting. Thank you so much for the wonderful presentation, ma'am. And as a mark of respect, please sit down. Dr. Ambedkar, sir, please come on to the dais. So Dr. Ambedkar sir is he's the most senior person in our college. He worked as a superintendent, now he is the director. First. Sir.
Clinical clerkship, learner doctor method, implementation and challenges. A very interesting topic to be taken by Dr. Ravi Venkatachalam sir, Principal, Government Medical College, Srikakulam. I would now request Dr. Lakshmi Lalita ma'am, Principal, GEMS, and Dr. PSN Raju, Professor of Physiology from AMC, to chair the sessions. I request our principal ma'am to introduce Chalam sir to us.
No need of them. Can I introduce myself?
So that is the modesty of Dr. Chalam sir. We fondly call him Chalam sir, and I should say he is the father of medical education in Andhra. He is the one who started the department, and he is very much interested, and he used to push all of us. He used to motivate all of us, and I think, sir, you have to agree with this. You cannot deny. And now presently he is working as the principal of Government Medical College, Srikakulam. And whatever sir takes up, he'll deeply get involved into that. That is the big commitment he has for everything. So Dr. Chalam sir, we are very lucky to have you here. Please go on with the deliberation.
Thank you, Lakshmi Lalita. I may tell Madam Gitanjali that my first introduction to medical education happened in Jipmer actually. I came to NTCC way back in '92 when Dr. Sethuram and Dr. D.K. Srinivasa were there. So that was when we started a similar center in Vizag. And that grew up to become the regional center in Vizag. So that's how my whole thing happened. So this session of the doctor, the student doctor method of training, which was actually mentioned yesterday by Dr. P.V. Chalam. That's a session just been given to me. Before that, I'd just like to put one thought into you. Please think over. How do you think our training differs from the training of nurses or dental surgeons or physiotherapists? Can think over. From day one, how we train, how they train. If you look at the nurses, from day one they come to the hospital. They call the pre-PTS nursing students. From day one they do bed making and whatever the lesser tasks. And as they go the 2 years, 3 years, they go to higher tasks like injections and treatment and all that. Whereas for us, for 2 years, for 1.5 to 2 years, we're in the classroom dissecting, doing frog experiments and whatever. And for till 2 years, you won't be able to hang a chat around your thing and go. So that's how it differs. And the nurse or the dentist or the physiotherapist, the moment he finishes his degree, he's ready to practice. Where we are so hesitant. Maybe the olden days doctors used to go and set up practice, but even they used to work for 6 months as some senior doctor and go ahead. Whereas now, they won't dare to practice with the MBBS degree. It's not that the MBBS degree is not enough, but they are not so confident. Why? Because we go into the actual real life only in house agency. So that is the main drawback. In fact, I think way back about 5-10 years ago when we had a discussion, one radical idea came that our training should be like nurses. Like let them go to the hospital from day one. Okay, first year they'll go only from 9 to 12 or something, but slowly they'll do, like nurses, in the entire 3 years, they do evening duties, night duties, they have their classes also. So that is how, hopefully that may come, that'll be a right way of training. That in fact encapsulates the concept of what we are discussing today, the student doctor method of training. So what we'll do is we'll have see what it is, what the NMC says about it, its benefits. There's not much of Indian data. I could find only one paper on that. And a little data of we did a cardiology clerkship and how to implement it and challenges and way out if possible. So this is what I was telling you, that how our training differs from the nurses and all that. And that is one reason I think why the early clinical exposure concept has been rightly brought out now, though a little late, by the NMC. And that is the spirit with which we should take it and implement it, not just implement on paper, but we should take it in the right way. Okay. And so if you look at the physician and surgeon, somebody who does MD medicine or MS surgery, when do they actually gain the maximum knowledge? I think for a physician, it will be during the MD period, because most of the physicians' knowledge is their recent advance. Anything after their MD is recent advance for them, because that is the time when they learn maximum. But surgeon is not like that. After MS, he has to work for 2 or 3 years. That is when his maximum, his capacity building occurs. So this is one thing we have to keep in mind, that if you want to train the problem-solving skills, it's okay doing it in a classroom, and like interpreting lab data or investigations. But if you want to do the actual procedural skills, it does need hands-on training. And that's the reason why you need that the student go into the hospital right from day one. Okay. So this is also known as clerkship, student learner method. That means the student is involved as a doctor. I mean, though not to the same extent as the consultant, but they also involved to some extent to doing some tasks which need a lower level of competency in the management of the patient. So that's why they're more confident when they finish at the end of the 4.5 years. So the other term for it is clerkship. There's a subtle difference between clerkship and internship and observership. So, yeah. So if you look at our conventional training in clinical skills, what happens is, first of all, till we pass anatomy physiology, we don't go into the clinical side. And once we go there, our period is restricted between 9 and 12. And one student will take a case, and then they'll wait for the faculty to come. And they'll come at me, they finish their ward rounds or whatever work, and then start the class at 11 o'clock or something, 11:30. And by 12, they have to leave you because you have to go back to class at 1 o'clock. And places where they are far away, like Hyderabad, you have Osmania Medical College in one place and your eye hospital in one place. So you have to leave much earlier. So you have hardly 45 minutes left for the case discussion, or half an hour. You start with history. Most often it stops at history, or maybe past history somewhere. At the most, it goes to general examination. Maximum, it will go to total examination. It never goes into the management part at all. That's what happened, I think, for all of us. Okay. And whereas in this is not, that's a conventional method, but that doesn't help really. You'll only know how to take a history, and again, it's all most of cognitive training. Tell me all the causes of jaundice. Tell me the cause of loud first heart sound, cause of edema. So that's how it happens. It doesn't go into the actual handling of the patient. So as I told you, the subtle difference between clerkship and internship and observership, is when you observe things. It's usually done where you don't have a license to practice. Like people go to USA, you only get an observership. You can't do anything there. Okay, you observe them and take notes and participate in the discussions. The clerkship versus the internship, we all know is after you pass MBBS, is the mandatory part before you can go practice medicine or enter a PG degree. So that's after you enter your theoretical knowledge. Whereas clerkship is before you finish your MBBS, you can participate in the hospital work, patient care, to a certain extent supervised only. Okay, only certain things you will do, but you will be participating in the discussions, the examination, what they do, and you are supervised by somebody. So that is the subtle difference between these three terms. So what are the benefits of having a clerkship? I think by now all of you will agree that definitely is much more beneficial than what we are currently doing, like teaching the student in the various postings which they have and discussing a case and all that. And so the main thing is, why I am not confident of setting up my practice, because I don't know how to manage the patient. I may know the approach, I may know how to interpret the thing, I may know use AI to diagnose and all that, but the actual management and how to talk to the patient and how to, what drug to write, what are the subtle things, which patient, which I should write, what caution. I mean, there's so many things when you actually go into the actual treatment of the patient, which you only gain with experience. And that is what, as I said, nurses are getting from day one, but we are not allowing it for the medical students at any time in the house agency. Because house agency, what happens? He has to go and take the blood sample, go and get the investigations. His whole time is, often the house agency's complaint is, sir, we are made to do ward by tasks. We have to get reports, take the patient, get an ultrasound done before we go for surgery. Now, if you had people going to the wards right from first year. These can be done by first year. Like, like what happens in ultrasound, the radiologist is there, but PG, when the final year student will go on, my house agent will go and tell, sir, this case, madam told she needs urgent cesarean, please get ultrasound or echo done or something, and that's what he gets it done. The same thing can be done by the first year or second year. So if you have, multiple levels of students working in the ward, when they come to the final year house agents, they'll be doing the real things like, taking the sample or interpreting it and writing a treatment protocol and discussing with the PG or assistant and making notes. But so that is how I believe the actual student doctor training should happen. So that is how they learn the continuity of care. And if the patient, most of our discussions or even the learning, what we learn in the MBBS is a single point thing. We only see the patient one day when he may be early stroke or recovered stroke, but you don't know what happens throughout the entire thing. Like many people many of even the medicine PGs may not have, not many houses may not have seen a palatal weakness, or I would say even a 12th nerve weakness, but almost all of the stroke patients for the first 1 or 2 days will have a palatal weakness and tongue weakness, even though they are bilaterally represented and this should not happen because they are bilateral. It takes 1 or 2 days for the neuronal shock to come over. So if you're in the AMCU acute medical care unit on day 1, you can see that hypoglossal weakness and palatal weakness. But students never go there because they're not allowed into the acute medical care. They have to go into the ward only. By the time the hemiplegia recovered and they only have the standard hemiplegia, plantar extensor and all that. So they get the continuity of care. They can see how the changes are, how the signs are evolving, how to make out improvement or deterioration. So they'll know the actual practical care of the patient follow-up. And of course, with them the discharge, it gives them a good rapport actually. Patients are happy. See, when who's the most popular doctor in the entire ward? Not the chief. He'll happily go with the tie and feel very proudly going. But the actual person who's wanted away is a PG. Because the patients and the attendant know that the actual PG will write the notes, put in the case and, handle. So he and the nurse, they're the key person in the ward. So they'll give a good impact on patient care and there'll be a lot of good rapport. And other thing is, as I said, in the class, what happens is one student takes the case and he'll answer the questions and of course the others will be listening. But here when you're doing a student doctor type of training, you'll follow the rounds. So the professor or faculty who will be doing the rounds will ask you some question, why you thought of this, and you'll ask some questions. So it's better one-to-one interaction. And of course, I said it creates confidence and they'll know, but there's so many issues. It's not just diagnosis and management. There are so many subtle nuances in patient care. There's social, cultural, ethical, which are all there actually in the competency. They can't be taught in a lecture hall. So that you'll only know there when patient will come, sir, tomorrow is Amavasya, I don't want surgery. Then he'll say, no, my operation day is tomorrow. Then he'll try to convince him. All this will happen if he follows him. Okay. And of course, they'll know good communication, affective skills. So the MNC says, I think I'll skip through. I'm glad that the NMC has brought out this thing. Of course, I'm sorry for that, but it's there in GMER. Basically, what it says is this. The student will be part of the treating team. So, now we allot students to units. So what the NMC advises is, like suppose I'm a first unit student. On Monday is my admission day. First unit is Monday. So Monday, I'll stay with the unit. In fact, if you see many units, the entire unit is on duty on Monday. In first unit, all the PGs, all the house agents are on duty. So the students also will continue duty. They'll go to the class between 1 and 4, but again 4 o'clock they go back to the casualty, see what the patient admitted, shadow the PG or house agent, what they learn. Depending on which level, they're the first year, second year, third year, they'll learn whatever level skills they have to learn and follow that. Okay, and their beds are assigned to them. And the next day, Tuesday, what happens now is the PG will present the case. So if I'm in a female ward, I'm ready. The previous night, I'm quickly send the sample, get the investigations, whatever, give them treatment. Next day, I present it. That's what happens in all wards. The PG or the house agent will present it. So here, what will happen is, this is one form of grand rounds, you can call it. Some of us would have seen this grand rounds where the professor will do it and each case is presented. So this is actually a very good opportunity to do that. So the professor can do the grand rounds on Tuesday, first student professor. So when you go to bed 1, the first year student, of course, they learn about the hospital environment, disease, its socio-cultural context, and they'll watch and observe, that's all. But the second year student, that's what I mean to say is the phase 2. So he will present the history of the patient. because that he'd be trained by then. So he'll tell this patient came with fever from 3 days with chills and rigors, and from yesterday he had headache, vomiting, and he's drowsy from yesterday. So there the house surgeon or PG may some corroborate or something like that. So then the professor will discuss something, what do you think of it, and then. So the physical examination is done by that same second year student because he's finished his physical examination history. Then the third phase student, that is the person who's finished his microbiology and pathology posting. So he'll tell, sir, the investigations have come, the blood investigation, TC is high, and he may say that lumbar puncture was done, CSF is showing some poor length, and something he'll tell. Then the final year student will tell what treatment was given or what treatment posed. So what happens is, all the 3 level students are there. They told their particular level of whatever they're supposed to tell, but all are learning. So the second year student is also learning that, okay, you have to give ceftriaxone injection for pyogenic meningitis. The final year student is again, reinforcing or reviving, the thing is causes of fever with chills and rigors or short fever and all that. So that's how learning should happen also. Okay. So actually, the well used is a very good thing. And so this is what they're supposed to do, and they have to write a logbook about all this. And they have to do the rounds on this Tuesday and at least one another day. Why? Because I should know whether this pyogenic meningitis patient died or he survived or did he get any complication. So that's how I follow him. Of course, this is still broken because, see, I'm not saying every day. Ideally, I would have liked that you go every day for at least 10 days or 2 weeks. Not every day, you can just go in the evening, in the 9 to 12. See, we all know that the real teaching happens only 1 hour, the actual case presentation. So 9 to 11 is just spent in taking the case, so-called thing. That can be done in the evening. How do PG's classes happen? PGs don't waste the time in the morning to take. PG also have a case discussion in clinical side. They don't waste the 9 to 11. They go the previous day evening, they sit with them for 1 hour, take the case, and next day they read it. This is what should happen for UGs also. At least for 1 or 2 weeks. So you get a feel of the real things which is happening. So maybe not in the entire 6 weeks, but at least 1 or 2 weeks. They can. Gynec people have the internship, internee posting. That can be replicated in all the major specialties like medicine, surgery also. That's how they learn the labor and all that. So the same thing for an entire 6 weeks. 2 weeks you can stay there, and this is what you can do. Okay. So this is what I said. Phase 1 is just to orient them and early clinical exposure and the understand about illness. Phase 2, the history and physical examination. Phase 3 is diagnosis and any procedure. And phase 4 is treatment and decision making. But of course, all will be listening to the entire thing. So what is the evidence? I didn't find many publications in India. Maybe because now it started, some of you can take this and present papers in next APMEA conference. So there's one paper which they did, actually they were doing diabetic retinopathy in a community clinic. So they took them, the students for that, and did a student trainer thing, and they took a feedback. And the students felt, they answered that both their clinical skills and their communication skills improved, and they found it was meaningful learning. And they thought, so this will be more permanent. See now, once the student does this practically, he won't forget it, he or she. Tomorrow when he goes, he'll know about meningitis case, he will know what to give. So that's how it will help in permanent learning. And of course, hands-on experience makes it better. And they learn from mistake also. Okay, one student learns. So our experience, I said much before it came in the NMC, in cardiology we were doing a clerkship for the last 4 or 5 years, both in Vizag and in Kakinada I was working, and Srikakulam for a short time. So we had a good response, and we presented actually here in APMEA. Here unfortunately we lost to a better paper, but when I present in cardiology, because this is new for them. Cardiologists are used to stents and papers on, stent thrombosis and, all hi-fi things. So when I presented very diffidently. But so I was surprised, in fact, when they gave the prize. I said, it's very embarrassing because what will the Cardiac Society think? They said, no, we don't mind, we want such papers. So we took the feedback from the students, and I'm happy that it was quoted by actually one faculty member in the US Basic workshop as an example of the clerkship. And we take people we do it in the summer vacation and the Dasara vacation. People scold me, they say not allowing them to have vacation. But we ask those who are coming to Vizag for vacation, you come to us. So they come between 9 and 12 or 9 and 1. And they have to do 2 night duties in the 10 days. And they shadow the PG and the technician. They're supposed to learn how to take an ECG from the technician and do 2 night duties. And we set some simple goals like, how to diagnose MI in ECG and what is the treatment of hypertension, heart failure. And that's all. Very few. And CPR is one more thing. So this is 1 year study which we did. We had 32 students, and 16 in Vizag and 16 in Kakinada. And yeah, this is what we did. And they went to the echo room and cath lab. They were very fascinated to see the echo room and cath lab and all that, because they correlate with anatomy, and all that. So they didn't mind we asked them, did you mind losing? They didn't mind losing the summer vacation. It was optional, purely voluntary. And this was quite a good improvement in the score in the pre and post test. And they were all not necessarily final year. They were all third years and fourth years and final years also. And they learned all these things. Like I told them, we'll teach them a few common things which are necessary in cardiology. And there was also some quite surprising, as expected, there's some non-scholastic learning outcomes also. They learned how to do teamwork and how to communicate with patients. Actually, and one patient did CPR in the ward before we could go. He's very thrilled because the patient lived and he got discharged. So he was very happy about it. So that is our thing. And yeah, they wanted other departments also to do it. So what are the challenges? So as Dr. P.V. Chalam was telling yesterday, first of all, this is a new method. Not new actually, but if you do it in a proper way, like you make your first year student, second year student present the history, and the third year student present the finding, the investigation, and final year presenting the treatment. It is a new thing, but we can do it. It's not nothing great. As I said, we've been doing it in grand rounds. We only have to just see that every student participates. So, but as Madam was saying, people resist change. But this is, I think, something easy to change. The thing is, we don't have a separate time for this. But as I said, we can easily accommodate in the, post-admission day, 2-3 days, or have a 2-week internee posting, let them stay in the ward in the department for 2 weeks. Okay, and of course, faculty shortage, resistance change. The other thing I forgot to write there was, the other main thing we have to keep in mind when we're having 3 levels of students is, they get a feeling. And suppose I ask the final year, what is the manual, he doesn't know. He'll get very upset that he'll feel, or he couldn't answer the question. So that is one thing you have to keep in mind. We should not, that is a very sensitive issue. So seniors won't like being asked questions which answers they don't know in front of juniors. So what I suggest, if something is there, you say, you tell me, or you check up Google and tell me. There's nothing amazing. I quite often do it. Or you ask an entire, any of the 5 bench can answer, and verify and tell, because this is a common learning. So that is what we have, because when you're doing teaching for a graded student, you have to be careful of that issue. Okay. So the way forward is just, I think, train the faculty and motivate them. Otherwise, be strict. Okay. So this is what, same thing I thought which you can do. Yeah, thank you very much. And of course, the logbook and reflection is important, because that's the main way how you assess they learn well. Thank you very much. I'll be happy if someone shares more experience than what I've done, because I've been out of medicine for a long time.
Sir, I have my summarize which is.
Yes. Thank you, Ravi Venkatachalam, sir. The student doctor's method of learning, or the learner's doctor's method of learning, is a fantastic idea. And it's been since years doctors are craving to start this program from the first year for the students for a better learning. And thanks for sharing all the aspects here, sir. And your experimental type of learning is really wonderful in this field. Thank you, sir, for that. It's the first idea behind this is training the faculty in the faculty development program regarding this student doctor method of learning. Is a very important aspect, and in return, the doctors who have been trained, the faculty who have been trained, now trains the student how to implement the program. That's wonderful, and thank you for guiding us all through this aspect, sir. Thank you very much. That's a wonderful one.
Sir, I just want to share my experience before somebody wants to talk. Just want to share my experience. So we have very strictly designed this student doctor program. So we have given beds to the students, allotted, right from second year till final year we have allotted beds. They have to follow the case which is on the bed right from the admission till the discharge, whatever may be the case. You don't touch the second year students cannot touch the patient, because in a private medical college it's very difficult. So they don't touch, but they'll follow the rounds, they'll talk to the PG, they will learn, they will write down everything in the logbook. We ask them to maintain the portfolio books also. And I know in initially there was lots of, so they were saying we have lots of work, why again this headache, teaching for 1 hour is easier than following all this. But now people have fallen into the group, everybody is cooperating, the faculty are also doing wonderfully well, especially when I post them in the evenings for casualty and OBG, students are wonderfully doing and they're really enjoying the time. There are few who would escape, that's always there, but most of them are enjoying their postings and all. They're learning very well. Not only this, they don't know what is a RALS tube, what are the markings on that, how does it look, whether it's different for the child and the adult, nothing they know. So by the time they come to final year, they should get acquainted with all this. So that's how we have planned, and the departments also have given a schedule. So we are going as per the schedule. This year it's going on very, very well. But I don't say that it's 10% successful, but more than 60% it has become successful. So I think my students are, most of my students are enjoying very well.
Very good.
So that's my experience. Thank you.
Thank you, ma'am. Any from the audience, any faculty want to share anything? Yes, ma'am, please.
I think it's working. Thank you. So I just want to share a small anecdote. I did my NTTC training somewhere in 1990. So that time, one of my colleagues, Dr. Dinkar Pai, I don't know, some of you might be knowing him. He's into simulation. So his project for NTTC was clerkship. So in JIPMER, he had to do it. So he started introducing it somewhere in 1991. So from 1991, it's happening only in the Department of Surgery. Okay. And it's one of the success stories, because it's very this thing, and I know personally, I know my daughter also went through it, and she used to be really very happy that they could do it and all that. But the other thing which they used to do is from 1975, when we were students, we were always allocated as, some 2 beds in the medicine, in gynae, like that, which we had to follow up from the time they were admitted till this thing and write up. So this is nothing new. Only thing is it has now been revived, I think. And there are great learnings to happen. But also we need to be cautious, because students tend to copy. So 10 years down the line, the same thing which was written in the record books 10 years down would be copied. But I feel that there is a lot to follow this. Thank you.
Thank you, ma'am. Any others?
Sir.
Yes.
Yeah. Sir, in Cuba, already they are following the system since long back. For the first 2 or 3 years, they send them to the clinics. Then they start teaching all the other things. They are following since long back. That's why it's most successful system.
In this, they can be allowed according to the thing, but they will not only observe. Any early clinical exposure, no, sir. So
Yes.
that is the thing, and this family adoption is there from day one.
So I definitely like very interesting initiatives from Dr. Venkatachalam sir and Dr. Lalita ma'am at GEMS. So at Rangaraya Medical College, this student-patient follow-up was being done, or this internship during UG period, it was done in the Department of Pediatrics. So I think lots of times it is the initiatives of faculty. So it's not like the thing. So whatever NMC is done is what was done in few institutes, they want to now make it wider reach and make good practices adopted in other places. So I'm very happy to see that it can be done in different places. Like surgery, I haven't heard earlier. So now after, it can be taken up in surgery also. And family adoption program, definitely, that is what, when we're talking about ECE is not always in wards. So when Dr. Chalam sir also presented yesterday, he said it could be at the hospital, in the community. So when the children go to the families and see a family where there is a person with hypertension. So my request to all the faculty here, the first year faculty, please insist that the student buys a BP apparatus. Because they can monitor, screen a person, opportunistic screening, the importance of it they can do in family adoption program. They can start counseling with more confidence based on the readings. So that sort of a exposure can happen in the family, through their learning even without passing the subject. Family adoption program gives a great opportunity, sir, to improve their communication skills, to understand, again, as you said, ethical issues. We are not asking them to make a diagnosis. We are telling them already known cases, how they are, whether under control or not. Such things they can also tell. That's all. Thank you, sir.
Thank you, Rev. Venkatachalam sir, for that wonderful presentation. Round of applause for him. Thank you, sir.
Thank you, sir. Sir, I want to speak one thing. This internet posting is when we were students. It was 3 months. We used to stay in the department day and night. And when there is a case, we used to see. Then I came to know this is not a new thing. Even the surgery and medicine also, there was internet posting when there is a British people. Slowly, the internet posting was not strictly implemented. In all medical colleges, the internet posting, they are coming for 1 hour. They are not staying in the nights. They are only one week or 10 days, only they are doing. But if they are staying in the department, they can see all emergencies and other things. In all, not only gynec, obstetrics, in medicine and surgery also. So try to let us, if there is will, there is a way.
నేను మైక్రోసాఫ్ట్లో చేసింది అందులో వస్తుంది కదా పవర్ పాయింట్ నేను మారిపోద్ది వస్తుంది మైక్రోసాఫ్ట్ 7 కాపీ చేయద్దు కానీ అందులో పెట్టద్దు అదే అయిందా తెలియదు నెక్స్ట్
We have been listening to a lot of sessions, so we just thought a slight deviation. There's a surprise quiz for the faculty now with prizes, gifts also. The session will be conducted by Dr. Rajshekhar. Sir has designed this game quiz, so whoever answers first will get a prize. Yes, everybody can participate. No, ma'am can't participate. Question paper is leaked for ma'am.
ఇంకా అక్కడ ప్రాజెక్ట్ అవ్వలేదు ఇక్కడ అవ్వలేదా
Okay, good morning everyone. So I will be conducting this Pictionary game. I will be focusing some of the images. From those images, you need to derive some words or letters which are related to medical education. Whoever knows the answer, please raise your hand, and if the answer is correct, we'll give you a Dairy Milk chocolate. Sir, duplicate. I am not yet started. Okay, let's start. This is the first one. Whoever knows the answer, please raise your hand. Please raise your hand. Yes.
IMG.
Graduate. That person has already answered, sir. So, TJ Srinivas sir has answered it. Yes.
ACME, sir.
Yes. Okay, next question. Please, those whoever knows the answer, please raise your hand. Don't answer it. Yes, that's right.
APMEDUCON.
No, sir.
EDUCON, sorry.
No. Clue is there in the picture itself. Yes. Mike, please here. Sir.
Adult learning, something.
Sir. No, sir.
Sir, ADME.
Audio video.
No, ma'am.
ADME.
You are almost close.
ADME.
No, sir.
UME. UME, sir. ADME, UME.
No, sir.
APMEA, APM, A is A, phone P.
No, ma'am. Next slide is answer is there in the next slide, sir.
Multiple choice.
Okay, I'm revealing the answer. AD opposite. AD after that opposite is BC. Before Christ. This is BCME. AD after death opposite is BC, sir. AD and BC.
Oh.
Someone has answered.
Reinforcement.
Yes, sir has answered.
Reinforcement.
Sir has answered here. Sir has.
Thank you so much.
Yes.
CBME.
Ma'am has answered. Yes, someone has answered here.
Curriculum.
Yes, sir has answered.
Foundation course.
I think we need to give chocolates for everyone. This is foundation course. Yes, last one. Yes. Sir, chapter. That's it, sir. Thank you.
Senior Resource Faculty, NMC RCMET, Honorary Secretary APMEA, Professor and Head of Department of Anatomy from Government Medical College Srikakulam. I would now request Dr. Kalyan Chakravarti, Professor and Head of Department of Anesthesia GEMS, and Dr. Leela Ma'am, Professor and Head of Department of Biochemistry from AMC, to chair the session.
Good morning, everyone. Dr. Venkatram Prasad sir is Professor in Anatomy and is Honorary Secretary of APMEA. He is Senior Resource Faculty, Regional Center Medical Education Technology Cell, AMC, and he is recipient of 2 gold medals for Best Presentation and Innovating Teaching Methods. I request sir to start off the lecture. Sir, please. Take the mic. Yeah, sure, sir.
So very good morning to all of you and all the esteemed members who are sitting in the front row and all my colleagues in the middle and all the students who are sitting in the last rows. So first of all, I thank Dr. Rajshekhar sir for that quiz which has conducted in between. Otherwise, I was a bit apprehensive to come onto the stage because I heard of pre-lunch sessions. I heard that pre-lunch sessions are very difficult to deal with because there's a lot of gastric stimulation. But again, when I thought of a post-lunch session, they were saying there's a lot of drowsiness, people will sleep and then they won't listen to your class. So I just wanted to avoid these two and was very happy that session was given at around 10:30 a.m. by Lalita madam. But in the meantime, to add to the misery, 2 eminent speakers who have been trained at NTT, they gave their lectures just before me. So one Geetanjali madam and another Venkatachalam sir, who is my mentor and guide. So with 2 presentations like that before, and now getting onto stage for the 3rd one, it was very difficult. And all my apprehensions were cleared by Dr. Rajshekhar sir. He created a small gap now, so that now people might have forgotten those 2 presentations by Geetanjali ma'am and Venkatachalam sir. Right, sir? So this is one topic again. We'll be taking you through this the emerging trends in medical education. This is mostly only a sensitization thing, and this is the most crowded slide which I have prepared till now, because a lot of things are coming up. I didn't know where to share all this for the first slide, and these are the so many things I had to put in the slide so that we can understand what is coming ahead. So this medical education component, it started way back before 1910. We had Sushruta and we had other eminent surgeons from the other countries as well, where knowledge was distributed by apprenticeship. Apprenticeship was the mode where knowledge used to be catered to. Later on, Flexner was the one who introduced the later things, and he put knowledge as an important component, and that knowledge was started being shared in the form of books. And he divided them into biological sciences and clinical sciences, and they put it into two phases. One is a preclinical phase and a paraclinical phase. In preclinical phase, biological sciences were taught, and in the clinical phase, clinical sciences were taught. So gradually, as the curriculum started growing up, then they put something which is known as a curriculum. As the knowledge was increasing and increasing, they said we'll have a curriculum and we'll finish it off time-bound. And then what happened is the information load started increasing and increasing. And then we had the traditional teaching came into play. So we had a curriculum and we had a didactic lectures with one lecturer on one side and all the students listening to them, and we had didactic lectures started. Still knowledge started increasing and increasing, and then bundles of books started coming into our medical education. Then what they did is, they divided it into disciplines now. Anatomy, physiology, medicine, surgery, gynec. So then disciplines came. And after disciplines came, this curriculum was again expanded, and this curricular expansion, we made it into what you call it as a fragmented curriculum. So curriculum was fragmented as we had disciplines, separate disciplines which are being taught, and this curriculum was a fragmented curriculum. And then actually the society which is standing here, they were not happy with this output which we are giving, and we had students who were not competent in their competencies when they went into the stakeholder, that is the society there. But at the same time, it had one advantage in the past, that this humanities component, which we'd be having a lecture in the afternoon by Dr. Manuswini. So this humanities component and respect, everything, command over the society, that was maintained when we had a traditional teaching sort of thing. Then the thought process came into vogue. Now, they just wanted to make improvements in this curriculum so that outputs were increased. That is, the quality output graduate was formed. The same thing, we were thinking on the same thing again and again, but it didn't make any difference there. Then what we did is, the outcome-oriented medication, they thought of having an outcome-based medical education. And in 1993, a World Summit was held in 1993, where the global standards of medical education came into play. And from 1993 onwards, competency-based medical education started. This was the time which we are implementing today. It was started off way back in 1993, and the CBM era started from that time. And they were thinking of having lectures which were there. They were shifted on to small group teaching. And then we had simulation labs, competency-based teaching, and all those things started coming into play now. And at the same time, there was an integration of clinical sciences and basic sciences as well. So the output which started coming, that is the student who, after the competency-based medical education was turning out, the society was very happy with him. So then the competency-based medical education was introduced globally, and now we'll be having global standards in competency-based medical education. Till now we have reached here. India has reached a phase where we are doing competency-based medical education since the past 5 years. Now, why this lecture now? Because there are further trends which are coming up into medical education. One, the most important thing is explosion of scientific information. Lot of scientific information is coming up these days. Previously, Davidson medicine book used to come every 5 years, but now it's being updated. Science is being updated every now and then. Every week you find different knowledge things coming out. Then there are a lot of changes in this healthcare system as well. Adult learning theories, on which we have a lot of classes are being held, and experiential learning is also taking suit first. And demographic patterns of patients as well as learners is also changing, and technological change is the most important thing now, which is the future trend coming up now. So if technology is changing, then what has it got to do with medical education? That's my $1 million question now. Innovative technologies, they result in change in societal expectations. First we had an X-ray, and now we have an MRI. Previously we used to take an X-ray, a patient was happy, but now he only tells us, you take an MRI, I'll be happy now. So the society changes, also societal expectations also change with technological changes. These changes, they also result in changes in healthcare management, and the physician roles also keep changing. Now a changed physician now, in order to make up a changed physician, we need to change our teaching learning methods, and that's where education, technology in medical education comes into play. There is a quote which says, if you want to change medicine, you have to change those who teach medicine. That's the most important thing right now. So we have technologies now which are entering into medical education. The future changes which are going to come up, we have a lot of studies on this. I went through a lot of studies, and these are the future changes which are likely to come up. So one is, the importance to teachers is being upgraded now. So whenever placement or appointment of teachers is there, and this will be taken up as the top priority by medical schools in future. So we'll have to gear up because we'll have to upgrade ourselves, as a lot of things are happening in artificial intelligence and all. We need to upgrade ourselves so as to reach that bar, so that we also get into teacher placements now. Research in medical education till now was done by other people, and then we are reading that research now. In future, the medical teachers in the particular medical schools, they have to do the research themselves, and then they have to present papers, and then they have to see that the medical education improves in their respective institutions. So any educational program, if it is done with excellence, the medical school gains excellence. So with this, the role of the teacher is changing right now. Previously, the teacher's role was as an information provider. We used to take all the, whatever knowledge was present in the book, then take it onto the screen, put it on the PowerPoint, and then deliver it to the students. Now, the role of the teacher has to change in future, and from an information provider, he'll have to change his role into an information coach. So coach's thing is different now. So the basic reason for this is, a study shows that medical knowledge doubles every 18 months in these years now. So we need to ease the student to cope up with this massive cognitive load, which is coming up every 18 months, it's doubling. And in order to adapt, there should be a change in curriculum, and change in lectures, and changing learning opportunities, for which a teacher has to get adapted. Because a teaching learning is done mostly by the teachers who are sitting there in front of me right now. So because medical education is a dynamic process now, as the society needs changes, then our physician has to change, and at the same time, medical education has to change. The role of the teacher, when you're talking about, there is no change in this learning pyramid, that remains the same. Mastery of the core knowledge also is the same. Only the delivering the content changes there. So you have to change your role from a sage on the stage, like giving one-sided lectures, and you have to go sit by the side of the student and then become a guide by the side. So there are, when it comes to teaching and learning, there are two important persons here. One is the teacher and the other one is the learner. Now we focus our sights onto the learner now. So previously the student was a consumer. We used to deliver, he used to receive. But now the things have changed now. The things are going to change, and we have the student as a partner now. So he'll be partnering in the educational program. So what are the things he's be doing? Like we have curriculum planning. When we are planning a curriculum for an institution, the student is also a part of that. That is already happening in our institutions. We have a curriculum committee in which a final year student is also there in the curriculum committee. So already things have started changing, and some things which are likely to happen where student involvement is there. And in the delivery of the educational program, the student role also comes in. In assessment programs also, we have to take the opinions of the students. And then peer teaching is one. As yesterday, PV Chalam sir was saying that peer teaching, teaching improves retention. No? So peer teaching is also will be included in the future programs. And another most important thing which will be astonished is during selection process for student admission also, students' role is, the seniors' role will be there. Because it's not happening here. We have a rank system where students are selected, but in other countries, the opinion of the seniors also are taken into account. So if you want to go to a residency program somewhere in US, so then you need to have a recommendation letter from your seniors as well. So involvement of students in the selection process also, that will also be coming up. And during creating learning resources, again the student role will be there in future. And assessment exercises for adaptive learning, and that will also be there in future, where the student will be involved. So many involvements by the students. And last but not the least, during staff appointments also, the students' opinion will be taken in future. So this is an alarm bell for faculty and a rejoicing thing for the students as well, because they'll be selecting the faculty who are going to enter into their college. So this is the future changes which are likely to come up, and we have to brace up with that, and we have to accept and adopt. So when you talk of another thing, the students which we have, which is coming up is, we call it as POLA. That is a personal online learning assistant. Like if you happen to open up something, one assistant pops up. No, I'm here, I'm so-and-so, okay, what is your question and all. So like that, we have personal online assistant will be given to each student, and they'll assist the student learning. That is, the student can present a paper there, or he can present a question or an answer there to the POLA and ask him how the thing happened. So it will give an answer. So your answer is not correct, your diagram is not correct, labeling is not correct, and then again he'll improve upon himself and then again present it again. So this way, personal online assistants will be given to each and every student. So this will promote self-directed learning. So self-directed learning is again a very important component, and GEMS has selected a very good topic for a workshop, and that has happened on the first day. So digital learning study guides for individual learning, and then and another thing which we have to we come across in future is adaptive learning. So what exactly adaptive learning is? If you just happen to look at this adaptive learning, it is a personalized education and an individual learning method. So each individual is different. So when we talk about learning methodologies, we have visual learners, we have auditory learners, we have kinesthetic learners, we have slow learners, we have fast learners as well. So adapting to their time and adapting to their own learning style is what is known as personalized or individualized learning. So here, the students, they have a personalized plan in which they select their learning methodology, and at the same time, they select, fast learners can go fast and slow learners can go slow. So here, time is not, time is variable, but in the end, what they have to do is, the standards have to be reached. The standards are fixed, time is variable, and you have a personalized learning along with the POLA. So this is what is going to come up for students, and we as educators, again, we have to be aware that this is what is going to come up now. So for having an adaptive learning, we need to have an adaptive curriculum. This all things, this is a chain reaction when it comes to a teaching and learning methodology. So what is an adaptive curriculum? So adaptive curriculum is a personalized to the individual student's needs, as I was telling you, and in terms of pace, duration, and learning approaches. He can adapt his own learning approach and own pace, and at the same time, own duration of learning. So if you just take all these things, and then we have to have an adaptive curriculum for each and every student. So this is an independent learning program where the student learns at his own pace and time, and testing his own understanding. At the same time, he can learn it at a variable pace, and we have to have a curriculum for that. There's a difference between this authentic curriculum and an adaptive curriculum. And the authentic curriculum is, if you want to design a program, suppose if you want to have a program, a normal delivery, and basically the skills and the knowledge component which are required by the student, if they are reached, we call it as an authentic curriculum. So authentic curriculum has to be there, and we'll be having an adaptive curriculum as well, and mostly favoring the students, because the teaching which is to come in the future, it's mostly a student-oriented method now. The most important thing which is happening right now, and a few changes which are likely to come up, is integrated learning in basic sciences now. So basic sciences to clinical sciences. Already we have alignment and integration programs are happening. So we have vertical integration and we have horizontal integration as well. But we are yet to look at a spiral integration now, which is likely to come up. So once we are versed with this horizontal integration and vertical integration, then in future we'll be looking at a spiral integration. For this we have a SPICES model. All of you are aware of that, I know. And where you'll be merging and integration will be taking along in all planes. But one thing which is going to differ is, again, yesterday we have seen this integration ladder, and till now we are reaching this point where sharing and correlation is happening, and we need to go up a few steps, a few steps up when climbing this Hardens ladder in future now. So when it comes to integration of basic and clinical sciences, this will be integrated into this spiral curriculum which we are talking about. And spiral curriculum is, for the students, you'll have all practical things, knowledge, skills, everything will be combined here, and it will be going up like this, and ultimately you'll reach that competency or proficiency in that competency. The advantage of this thing is, so the student can go back and come in again, and he can just see whether he's still here, he's learning a normal delivery, and you have anatomy, again he's forgotten, again he can come back, revise that, and go up now. So if you just have to have a curriculum of this sort, so that integration of basic sciences to clinical sciences happens now. This is what we are doing right now, up to a certain extent when it comes to alignment and integration. But what we will be looking at in the future is undergraduate medical education and postgraduate medical education have to be integrated. And the third thing is postgraduate education to practitioner. Once you finish off your education, and you'll be going with the CME programs or continuous medical education programs. So all these things have to be linked up in future when you are making up a curriculum. So that's where the future of medical education is likely to change. And a curriculum design should be in such a way from the first year onwards, and we have to see to it that the end result, that is continuing medical education programs, is also linked with that. So as of now, what is happening is the PG teachers and UG teachers are common. So I teach postgraduates, I teach undergraduates as well. So I have a knowledge about both of them. But we have separated it now. We have axed it, and there is no amalgamation or there is no seamless continuity which has to be there when it comes to a handing over of this. So what is going to happen in the future is we have to see that a smooth handoff of this undergraduate medical education to postgraduate medical education happens, and from there it has to be passed on to the practitioner where continuous medical education programs will be going on. So this is what is likely to happen in the future, and for this again we need to brace up, because accepting a change, going forward, maintaining the change, these are very important things. So another thing, which is supposed to be there, but we are not right now doing, is curriculum mapping. A curriculum has to be mapped from the beginning to a post-graduation thing, which I was talking about, and this has to be known to the student. So once you see the student, and then we have an outcome. Outcome is a Indian medical graduate, let us presume. Then we have a learning opportunities that come in between. So these learning opportunities, if they have to be utilized, there are some things which we have to look at and where our role comes in. So designing of courses, designing of modules which change the learning opportunities and for a better outcome. And assessment methods also, they play a very important role when we are coming to an outcome that the student reaches this particular slot. Here, faculty responsibilities are also designated, and again, this is where we chip in when we come into medical education. That's more important for us now. So curriculum mapping, as I've told you, this is the spiral curriculum. So this is a medical education, a student or an educating person should not think this is the end of my journey. It's a continuous journey which is going on till your death, and you'll have to be a lifelong learner. And this educational journey, we have to judge our progression of our journey, and we have to assess our understandings and assessments as we go along with this journey. So this is the importance of that curriculum mapping now. Now I have a slide here. So this, when it comes to technologies, this is one of the slides which I just put in the forefront, because he says, nurse, get to the internet, go to surgery.com, scroll down, click on the "Are you really lost?" app, and then we'll go further with surgery. So this is, if technology starts overtaking us, this is what is going to happen now. But at the same time, learning technology is very important for us, because globalization of technology, it has transformed every sphere of life, including all economic spheres, and all spheres have been changed, and the same thing will come on to medical education as well. So we need to have an effective and efficient usage of these technologies to bring about a change in the educational process. So these are some things which are likely to come up now. One, artificial reality, virtual reality, augmented reality, and all those things now, because all these things are connected to artificial intelligence. Already we have seen a part of it being dealt by Dr. Gitanjali Madam in the morning itself. And we have something which is known as a POCUS, so which is being used, that is point of care ultrasound. Ultrasound scan, you just can connect to your mobile. You just have to download the app, connect it to your mobile, and then you can do a scan there, and in the mobile you can see your scan. So this is one of the latest developments which is being used all over the world, and we have other whole lens also. So whole lenses, we are looking at a patient, like we have 25 students, and a surgeon is teaching something there, and all 25 students cannot view the same student, because a lecture is being taken, and at the same time everyone doesn't have a clear view of the same patient. So we have HoloLenses. If you just put that HoloLens, and the medical educator is teaching that class, and at the same time all the students are visualizing the same thing. This is what happens when you are using a HoloLens. Embarrassment to the patient is avoided, and all the students, here a per rectal examination is being demonstrated, and see the embarrassment the patient is facing here. And at the same time, some don't want to go near and some cannot see properly, some are interested. So if you happen to use a HoloLens, they can sit in the other part of the room and watch this procedure which is happening. So we have to embrace technology as it comes by, and then we have to make efficient use of it. It's not that we just can't shun it away and saying that it can't enter into our medical education process now. So, and last, when we come to the assessment thing, assessment will also be in future. It will be a program-based assessment, and evidence from different sources will be taken when you're assessing a student. That's mostly akin to 360-degree evaluation, which we are doing right now. And during this assessment, all these three things are covered. That is, one is formative assessment, and then summative assessment, and test-enhanced learning. All these will be covered in the future parts of medical education now. And one more thing is internal collaboration and external collaboration. So here we institutes, we are just like a well. My institute is only concerned with my own self, and we are not going to look at the other institutes, what is happening, and we don't want to partner with the other institutions. This is what the thing right now is happening now. In future, they want to have national internal collaborations. That is, within the institution, we have all the departments have to collaborate in between themselves so as to deliver a medical education program. And secondly, we'll have to have external collaborations as well. These collaborations go with external faculties, external communities, and nationally with other institutes, because All India Institute of Medical Sciences is already planning to have lectures with the best teachers, which will be delivered to all the students. So there a lot of concerns are there regarding that, but I don't say so. But still, we have to have external collaborations with other institutions, which will be delivered in future now. So here, by this, we can share curriculum, we can share teachers, we can share the expertise, and we can share learning resources and learning expertises as well. So this is this is one of the things which I have taken out from the internet. So now RG UHS students can access classes by best teachers. This is a national thing, It is already now being percolated into our medical education thing, which I was talking about. Now, another thing is, globally we are being recognized by the WFME. We have a World Federation for Medical Education, which has recognized us, and they say, I don't know how far it's true, but they say now medical doctors from India can go and practice there. I don't think it's possible, but still that's what the news is coming out in it. So this medical education thing, the future, it is very hazy and it's very puzzly thing which is happening here. But whatever thing is happening, we need to brace up for the future, which is going to come ahead. And this lecture was mostly a sensitization thing, so that once the seeds are dropped here in this program, the trees will start growing, and maybe it may take 10 years. And whenever this medical education comes in, then we'll have to brace up for that. So the thing what I want to tell you here is, it is we, the medical educators, who shape the future physician, who's adapt to the societal needs. So we need to change, we need to adapt, and then we have to be braced up for what is coming ahead of us now. So this is the thing which I wanted to present is, we have to brace up for the future challenges ahead. And I thank all of you for this patient listening. And these are the resources which we have gone through for picking up all these innovative methods for the future, which is going to strike us in future, in the coming future years. Thank you.
Any questions from the audience? Any questions?
Ram Prasad, itu. So with all these modalities, is it India, there is a good medical education?
Ma'am?
With all these methodology and modalities implementation, is in India that is the good for medical education?
Ma'am, Basically, we are targeting at an Indian medical graduate who has to reach the global standards. And globalization of medical education is already there. Now, if you have to reach that global standards, we have to follow what's happening there, and then we have to make a change. So these studies which have been done, they show that our results are good. So that's why they have been adapting this, and mostly they have started pushing it forward since the time of COVID. You know, when they had COVID, that was the time where this competencies, lack of competencies, and lack of thing was felt by the society, and the society is the basic stakeholder. And changing needs of the society is what transforms a physician and what transforms medical education in turn.
So just to add a few words, sir, regarding you were asking about Indian way of education, who are graduated from India and they went abroad to clear the USML and all. So they are settled as a very good physician. Indian doctors are supposed to be the best doctors, and they were preferred by the Westerners. So we can say that the seeds laid here are good enough, but definitely we need modification, because from the past 100 years there was no modification in the medical education. So definitely we should support that our medical system is improving a lot.
Sir, basically the IQ of Indian doctors is very high.
Yes, sir.
And second thing is they are very hardworking when compared to
Yes, that's
the counterparts across the globe. That's what I found out. But if you just happen to go through the USMLE questions, like, so each question is just like treating a patient, you know.
Yes, sir.
You just please if you just happen to go through the question, one question if you happen to answer, it's just like treating a patient, you know. So the same thing happens in that step 1, step 2, and step 3. I've been across all of them. You know. That's
yes,
why.
So any question from the audience? Thank you, Ramprasad sir. Thank you.
So thank you, sir.
Thank you, sir. May I now request Dr. Ramarao Garu, Professor of Obstetrics and Gynecology and Academic Director of GEMS Medical College, to please come on to the dais to present a memento to Dr. Ramprasad, along with the chairpersons.
Ma'am, before this, I just want to thank GEMS Medical College and at the same time Lalita Madam for giving me this opportunity to be on stage in front of such august audience. Thank you, ma'am.
Thank you, sir. We'll be breaking for tea. Those who want to go and have a break, they can have tea. But simultaneously, there's a short session which will be going on here. This is for the Faculty Innovation Medal. There are 2 presenters. One is Dr. Devi Madhavi Madam, and the other one is Dr. PSN Raju. So I request Dr. Lakshmi Lalita Ma'am and Dr. Satyajit Patnaik sir to judge the session when the talks are going, and whoever is interested can stay back and listen to the presentations. Others can proceed to tea. We'll start the next session after the presentations.
the duodenum as a suit. Now the answer for this is the salivary gland and the pancreas, which belong to both different subjects, different groups as such. Other example is taking this factor which factor helps absorb vitamin B12, suits of the stomach and the ileum, and the answer is intrinsic factor, which he throws as a trump card, now as a joker, which he seems to be. Right, for this we are taking an introduction, a trial method was run to the students with different cards. So each of the card has marks on it. For example, the first card which was served by one of the students, now taking 4 cards into consideration, as such, the 8 and 2 are 1 team members, and 3 and 4 are 1 other team members. Each of the card has number of points on it. So for example, the first person serves 3 card, what and where the pyloric sphincter located. Now it belongs to the stomach area. Next, the second person will have to serve this from the stomach. Whichever he has in the amount of cards, he should bring out that stomach part of it and bring out which cells secrete stomach. Later on, the next person will throw a card, what are the gastric hormones which are secreted. Now answers won't be given yet. The next person serves the highest is 8. Which organ atrophy causes pernicious anemia and how does it? So that is a very tough question. Among all of these, the toughest question being number 8. So he gets 8 marks. Whoever last person has the highest, he served it highest. So if he answers all of these marks, all of these questions, that team gets full marks amounts 8 plus 4 plus 3 plus 2. They get full marks out of this. This is how this runs. For example, a second example which can given be 2 marks answer. This is which cell secretes stomach. Okay, in the stomach. Okay, next one is what and where are the pyloric sphincter located. 3 marks. For example, next one is 8 marks. Next one, somebody by large throws a joker or a trump card. Now this is a joker or a trump card because it belongs to 2 systems. Okay, so now intrinsic factor is the person who throws it has an upper hand above all of these. If he answers all of them, he collects all the points. If at all he does not answer that properly, any of these questions, he loses the mark and gets a negative mark out of it. Now this is used as a module to test among the students. Using this card method, now we are trying to get a subject out of him, use an assessment tool for the subject or a type of reinforcement which is done for the student, and this is as such a trump card or a joker which we use it for stomach and ileum together. Now the aim of it to study the feasibility and acceptability of the medical trump cards as an innovative card for a learning tool. Now the activity, as we said, for different organs, oral cavities, stomach, duodenum and the ileum, and 4 teams are divided as such, and the activity was played among the students as displayed earlier. These, and the final result of it is we took a Google Forms for the students. Out of the members or class members who have played, we have got 54 responses. Did you understand the game? Out of which 51 said yes, we have understood the game out of the 54 who have participated in the game. And will you play the game again? All of them were happy and they were ready to do it again, once again, because it was a learning objective. How interesting was it? 11 said very, very interesting. Somewhat interesting was 40, and not much of interest was there was among the 2 members. And there is how useful was it? 20 of them said it's very useful, and the others said somewhat useful was among 33, and not answered was 1 of them. Now the positive outcomes of this to help them remember and recall. Learned teamwork is what they do together, and also learn new points, entertaining and interesting. As such, negative points, some did not understand, got bored for the game, and all did not play, and some got chaos and confusion regarding this. So conclusion, medical trump cards is an innovative card game which is feasible because of the answers given by the students, and also interesting and useful for the students, and it can be engaged as a learning tool for assessment or reinforcement among the students. Thank you very much.
Sir, how much time did it take, sir?
It took all of 1 hour, madam. Just 60 minutes is what the time we
For a total of?
Yes.
for a total of how many students?
For the, we have taken partly 65 students for the game, madam, because they were students who were present in the class during it. Since the total of 150 students had to attend the class, only 65 attended. We tried using this an alternative method to reinforce things rather than conducting a class. The subject was, they have completed this theoretical class. So what I thought was this will be a reinforce for them and they learn things better, they revise things better. That's what we thought. It will be an objective to help to assess things and reinforce.
So
Yes.
can we know how this knowledge improved or not?
Yes, definitely the students have told us this gave us a boost to increase our knowledge, or the second round when they played, they gave the better answers. That's what they have come out with. When they played the second round of the game, most of them were giving answers. That itself showed that they were trying to learn things from the older ones.
But how much sure can we be that they got the same questions as the first round in the second round also?
Most of them were a list of certain number of questions from this total GIT track, what we have taken there. Since they have completed that, after that we have conducted the test. So all of the questions were rated differently. So once they have played the game, others were audience, the next team were asked to come and sit. So they answered better. Next team who have come to play answered better rather than the first team who have answered and couldn't understand. Next team understood better. They were doing the best out of it.
So
How do you-
Sorry, sir.
How
is
do you-
that by mere observation or?
Yes, madam.
That
It is mere observation and a Google feedback form which was passed to the students and results were analyzed after that, madam.
How do you want to use this method, as a TL method or an assessment, formative
One thing,
assessment?
as a reinforcement method 1.1, as a feedback method about our teaching, as a student's self-directed learning is also one of the module which I can use this. For example, I give them a topic on nephrology or renal physiology. I'll ask them to come well prepared at home. Now I design questions either by myself or some of the students were given the task of prepared questions. So they'll give all the questions to me and I'll start this. I'll be just an observer and they'll play the game. This is what the new curriculum said. Be a facilitator or a guide rather than starting teaching on every possible bit. That's what I use this technique with the help of my mentor.
What time you have conducted this?
After each of the topic, madam.
In the classroom?
Yeah, in the theory classrooms. When normally 150 should be present, that day we noted that only 65 students were present in the class. So I could not use the class for a next theory class, which is a new topic to them. So I thought a revision of that topic which was completed can be enforced.
Sir, the role of facilitator is just to prepare those cards.
One thing, prepared cards is done either by the students or the facilitator.
Okay.
But under the guide, after the questions are prepared, now facilitator clearly checks the questions. Is it marking 1 is a simple question versus mark number 8 or 10, is it a complex question? Depending on, it goes through the facilitator who is going to score all that.
Okay.
Appropriate or not.
Yeah, thank you.
Yes.
How many faculty helped you in this, sir?
It's just 2 faculty, madam, which could do it.
Like in the
The one was observing things, other was conducting the program, madam.
when it was going on, only
Yes, ma'am.
you were there.
Only one faculty is sitting as observer, other faculty is conducting the program.
Thank you. How many times you have done it, Dr. Raju?
It's already been done thrice, madam. Yes, madam. Thank you very much. I thank my mentor, Dr. Ravi Venkatachalam sir, for taking up this project along with me. Thank you, sir. Thank you.
Good morning to the respected judges, dignitaries of the days. So I'm here to just present a best practice of Rangaraya Medical College. This is a team effort of the departments of multiple departments of Rangaraya Medical College, and I'm here to present on their behalf as the Vice Principal Academic. So promoting UG medical research through RSRS, an innovative approach in medical education. As we all know, medical education has been associated with rigorous academic coursework, practical clinical training, and the acquisition of clinical skills. However, we all also recognize that research has been called for in the recent days as a skill to be developed. And we have seen how the students, though they are interested in research, because of lack of proper guidance, they are not able to do research. So here, this was an experience of my college, which I'd like to share in how a student body has been able to promote research. So I have joined Rangaraya Medical College as in 2022. And at that time, there was no organized structure for promoting research in the undergraduates. And before we go into this, the background still includes why research in UG. So for you, you do not need to be told, but for the students' benefit, research enhances critical thinking and problem solving, for bridging the theory and clinical practice, and for fostering a culture of lifelong learning and encouraging innovation in scientific discovery, preparing future physicians for an evolving healthcare landscape. So keeping this in mind, so we have established, it was, mind you, a student initiative. Some of them approached us and said, we want to start research. And with my experience of establishing a research cell at Andhra Medical College, we have started and established Rangaraya Student Research Society in June 2022. The objectives were framed to provide a platform for promoting faculty and student interactions, to identify areas of research, to orient medical students about research opportunities, to guide students about dissemination of research findings through conferences and publications, to promote scientific temper and evidence medicine, and to produce future physician scientists. These were the objectives with which RSRS was initiated. And let me say, it was a very fulfilling experience. So with our initiation in June, we had a conference. We started a UG conference called EREVNA in 2022. And later, we also conducted the sensitizations, and we encouraged the students. And I'm happy to say that 39 of our research projects were selected for the UG SRS 2022 by University of Health Sciences. And 4 projects for ICMR STS 22 were selected. Also, seeing the enthusiasm amongst the children, a college level UG SRS was also initiated by the principal, Rangaraya Medical College. 50 of students attended various medical college conferences across the state and presented their research work. EREVNA 2022, the first annual UG conference by any government medical college in Andhra Pradesh, was conducted last year. And we had more than 350 medical students attending the conference from 5 different states, and total of 11 workshops and 2 guest lectures and scientific competitions were held. So this was the achievement, started with, again, as I say, involvement of the students. And also we had the involvement of the old Ramkosa, that is the Rangaraya Medical College. Old students also came forward to support the program. And this is the continuation of our journey, the RSRS version 2. So we had every year membership was there. So the secretary was from last year. They're all always from the final year part 2. And the team consists of the volunteers, consists of members from part 1 and so on. So we have a secretary a student secretary. The convener for the conference is the faculty. It was me for the last 2 years, and we involved the faculty in conducting the activities. So AREVNA 2023 was conducted in again this year in July. So we saw an improvement over last year. We had 530 participants overall, and we included new innovations like debates, and we had research papers, and also we had posters. So again, as we said, conferences give opportunities for sharing of thoughts and things. We had 21 participants for topics such as innovations using technology in medicine, and sometimes they come up with such beautiful ideas. One of the students presented a poster where she says, like myopes have a difficulty in traveling during night time on two-wheelers. So she was suggesting use of different visors which are having glasses in them, so that they would not be disturbed by the dust and so on which falls during the daytime. Such nice, interesting topics they presented during the thing. So also the faculty involvement increased, seeing the enthusiasm of the students, and we had several workshops, and these are the number of participants for the different workshops that were conducted. So we had the forensic department doing a crime scene analysis, 1 minute full talk from the Department of Anatomy, where they were given, they were asked to pick up a chit, and whatever came, whether it could be a bone, it could be the topic is written on the paper, and then they had to talk for 1 minute. And then we did a research methodology workshop for the students from the Department of Community Medicine, and Know Your Fitness was the workshop from physiology, and applied pharmacology, and so on and so on. So even the students had an exposure to the subspecialties. We had the plastic surgery, the neurosurgery, and so on also participating in the program. So I would say that together, so as I said, co-learning also happens. So we learn team, like this program of RSRS and the UG conferences have helped to promote the qualities that we are looking at for an Indian medical graduate. So better clinical skills they learn because of the workshops, and then leadership qualities, they have been enhanced. Both team spirit was promoted, and also the communication skills. So they were learning how to reach out to various colleges within the country and the state, and so on. So overall, I would say it was a great experience, and I would present it here not as an innovation but as a best practice. Thank you so much for giving me the opportunity.
Questions? Any questions?
The ICMR projects and all.
Yes.
Do they take a part in this, or
Yes,
this
yes.
is totally?
So the student, so what happens is this RSRS, the student society is there, and so we have some group of 6 or 8 faculty as their mentors. So whenever the there is an announcement of any research competition, like for example ICMR STS or the university SRS, this is again put in the group, shared in the group. Then the student volunteers again inform this, and the final years, there is again a core group in the RSRS, the totally committed ones. They divide the batch of the 4 years amongst themselves. 2 or 3 of them again go, and then they encourage the students to participate. And later, once they help them to choose the topics also. Sometimes I find that the faculty are not always available, or sometimes there is a little amount of hesitancy on part of the students to approach the faculty directly. So this RSRS is a conduit between, is a bridge, you could say, between the faculty and the rest of the students. So they would approach them, and they in turn would approach us, and we would be facilitating it. Also, in many of the, now the projects, they ask us about the institution ethics committee approvals. So these students help us to make sure that the paperwork is done, and also facilitate the availability of the faculty for the students when the principal, sometimes, lots of times the students are discouraged because of the time they spend in waiting for meeting their staff or for getting the approvals from the principal and so on. So all that is also taken care of by this RSRS, apart from doing the technical work, that is informing about the various conferences and also guiding them and facilitating them to do it. So it is a great chance for peer learning which happens there through RSRS.
Madam, what about the grants?
Grants?
Grants. That is financial aspect.
Yes, yes, sir. So as we said, the college supports them. So when we had the first conference, we have the funds were raised through membership, first of all, for the conference. But for small programs like the orientations and other things, the college meets the expenditure from the College Development Society. So again, it was memberships, students have to pay for the conference, let me say. The experience was, there was a basic price for registration which was 500 rupees. And then for workshops, again, they were made to pay a nominal fee of around 200 or 300 rupees. So and each student was allowed to do, my experience with the RSRS version 2. So we had, it was a 3-day workshop. So 2 days were for the workshops. The final day was for the quizzes, the debates and the posters. So for each event there was a nominal, for debates and all, it was just 10 rupees or 20 rupees was the nomination fee. And the college also gave. Old Students Association said they will support it, but fortunately we didn't need to ask them. So this is the thing.
How could the students pull time out of their busy curriculum schedule to help this RSRS? Because we see many students opting out for these extracurricular and getting absented, and only 50 to 30% present in the real class.
Yeah, so again, ma'am, so what we did was, whatever orientations happen, they happen only after 4 in the evening. So we tell the students that no chance, whatever is happening, it has to be, we want interested people. It's not for everybody. We are not, this RSRS registrations, if you see, is 5:30, and which includes our students who are interested in attending the workshops. So we say that attendance for all your regular classes is mandatory only during your free times, but for the 15 days before the conference, they did work day and night. Like for example, in the last 1 week, we asked them to submit the report of the volunteers who were participating, and for them we had to give attendance for 3 days. So that was the thing, but otherwise most of their work was, and you all know the students are night birds. So they don't mind. They come and maybe they attend the class, but they're working in the evenings. So we had. So I would again say, for the faculty, it would be a little difficult to accept, but there is that 5% of students who do not require faculty support. So we are fortunate to have such people. Chalam sir also knows there was this one student at Rangaraya Medical College called Tarun Suvari. I'll tell you the pros and cons also of such people. So he was, he had a great initiative. So this RSRS was his idea. He said, ma'am, let me come, before me, there was no organized structure, but he approached me and said, and I encouraged him. But by then, during COVID itself, he as an undergraduate had publications and also made several presentations. He's finally a part 2 student now, and of course stellar in his academic performances. He's already been granted ICMR projects twice. He's won prizes at OSMICON, at other national conferences, at AIMS Mangalgiri. So such brilliant students are again sometimes serve as role models for the others. So it's not always, should not be only faculty who are encouraging the students. The peer learning and peer role modeling helps a lot. So that's how we are doing it. That's it. Thank you.
Many students applied for this. No, you told ICMR and UGSRS there is increase in the numbers. How could you do that? What was the drive for the students?
Honestly saying, ICMR STS last year, applications wise also, last year there were more when RSRS started. And UGSRS, we had 49 approved, 39 were approved last year. Almost everything that we supplied. That was because that was new. RSRS was new. Everybody had that energy to make it work. That was one reason. Another time, the timing of the program. So whenever the students have more time, when it's not very close to academic, end exams, evaluations, and so on. So that was an advantage for us. So
what
faculty,
we can do?
Faculty, the faculty also, support to faculty is needed.
No, we, instead of waiting for them to come, how we can make them come to us for research, like to take up these projects and all. Usually what we do is when they come, we guide them. Instead, how to drive them, we should only bring them to.
Ma'am, I personally think research is not something that you can drive them to do it. It has to come from them. So we would fail if suppose it has happened. So one of the students, he said he wanted to do some research. ICMR, topic was selected for a forensic medicine topic, which included collecting blood samples from fetal autopsies. And they had to do it 4 times in a day. And the student started. He did 20 or 30. And then he said, I'm dropping out. He couldn't sustain it. So what I think is we need to judicially balance to approach where you're likely to get the projects done. For the faculty, very often, again, I see one suggestion is that you, can I continue? So I would say keep some projects ready. Not always wait for announcement of ICMR STS or UGSRS. If we have a project ready, when a student comes, it's easy for us to give. So it has not happened that we had to call students. The students come to us and we are not able to find guides for them. It's inverse for us. So we are also maintaining a bank of faculty who are interested in research. So we tie them up. So that's how we do. Thank you.
Thank you, ma'am.
Thank you.
Thank you. We'll go to our regular sessions back. Now we'll have a session on communication skills, teaching and assessment. Dr. Lavanya KM, she's Professor of Department of Community Medicine, ACME and FAMER Fellow, Faculty FAMER Regional Institute from GSL Medical College, Rajahmundry. I request Dr. Madhavulu, Professor and Head of the Department of Pharmacology from Geetham, and Dr. U. Vivekananda, Professor and Head of Department of Ophthalmology from Ashram, to chair the session, please.
Good afternoon, everybody. It is our privilege to introduce Dr. Lavanya KM, Madam. She is presently working as professor in the Department of Community Medicine at GSL Medical College, Rajahmundry. She has published 32 articles in national and international journals, reviewer and editorial board member in some journals. She has pursued her MD Community Medicine from Osmania Medical College, Hyderabad. She has been trained in RBCW. She has completed her ACME from St. John's Medical College, Bangalore, and she's a FIMER fellow from CMC Ludhiana. She's presently a resource faculty for FIMER fellowship at FIMER Regional Institute Ludhiana. She is pursuing her PhD in health professions education. She's a member of APMEA, AHP, Academy of Health Profession Educations, Simulation Health Society, and Indian Association of Preventive and Social Medicines, Indian Public Health Associations, Epidemiological Foundations of India. Over to you, madam. Thank you.
Thank you so much, sir. Am I audible? Hello. Thank you very much for the introduction, sir. Today I am going to speak on communication skills teaching and assessment. Why did I choose this topic for this conference is because most of us must be teaching communication skills in classes because now it is included in the ADCOM. However, most of us also agree that we may not have a structured module for teaching. So I thought it would be better that all of us should become aware of how to teach and assess communication skills. So what is this? What is communication skill? It is the ability, communication skills is the ability to convey or share ideas and feelings effectively. So it involves listening and speaking as well as reading and writing. So when do you say that the communication is effective? Any answers, please? When can we say that the communication has been effective? Yes, please.
When there is a change in behavior for whom we have to the person whom we have communicated about the things, there is reciprocation.
Yes, ma'am. So when there is a change in behavior, so before that there is something which should happen. Before a change in behavior, there should be something which should happen to call it effective. So the change in behavior is the learning which comes later on. But before that, to call communication to be effective, it is when I say something which I should be able to say what I exactly wanted to say. And the listener should be able
understand, ma'am.
And the listener should be able to understand what exactly I wanted to deliver. So then only we can call the communication is effective. That is, I should be able to say what exactly I wanted to say. I should be able to convey that message correctly, and the listener should pick up the same message, what I wanted him to understand. Then only the communication can be effective. So once the communication becomes effective, the next stage comes the learning and change in behavior. There are different forms of communication. All these things are known things. This is just for reinforcement, like the oral communication or verbal communication. Verbal communication, again, it should be the spoken word as well as listening. So every good communicator should also be a good listener. Verbal communication can be in the form of speech or presentation, discussion, gossiping, public speaking or debate, anything which involves words which are said. The next is the graphic communication, that is the written form or the writing, and the art form, which involves academic writing, revision or editing, medical writing, and all types of arts also, that is the poetry, painting, posters. They are also a form of graphic communication. And apart from these two, we have non-verbal communications or the symbolic communication, that is the signs, gestures and the pantomimes. Kinesics, that is the body signals. Haptics, touch signals. Proxemics, that is the space signals. Chronemics, time signals. appearance, dress signals, iconics, that is the object signals, and paralinguistic, that is the complementary meaning which is obtained from the person or the body language. The next is the styles of communication. So apart from forms of communication, styles of communication is also important. Like each one of us must be having different styles of communication, like the analytical style, where a person focuses on facts and logic, acts only when the payoff is clear, and he is careful not to commit too quickly. That is, he takes some time to think about it and then only he acts. That is the analytical communication. Driver is another style of communication where the person focuses on results, takes charge, he makes quick decisions, and he likes challenges. So it is like impulsive driver communication. Expressive communication, which involves emotions, that is creating excitement and involvement by his communication, sharing ideas, dreams, and enthusiasm, then motivating, inspiring, and persuading. Amiable is the style of communication where the person cooperates to gain agreement with his team members, with others, provides support, and communicates trust and confidence among people. These are different styles of communication, but these are not watertight compartments, and many of us may be having multiple styles as well. Also, it is situational. So sometimes we may be analytical, and sometimes the communication may be amiable or expressive. So it varies depending on several factors. What is the importance of communication skills for a doctor? Even this, many of us know, doctors, we need communication skills in our day-to-day practice, day-to-day life, in several occasions, like being a counselor or being a consultant, as an administrator, or being a good leader, educator, motivator, when you provide health education to people, when you counsel the patients, or when you convince them, when you take informed consent, several occasions. So everything involves communication skills. What is the importance of effective communication skills? What happens if you are able to if you are able to impart good communication skills? There is a change in knowledge, change in behavior, to get action, to ensure understanding, then to persuade, to get and give information to people. So ultimate aim is to bring about some change in behavior. Now coming to the topic as such, communicative competence. It is a synthesis of knowledge of basic grammatic principles. So grammar is important, knowledge of how language is used in social setting, the social communication, then how knowledge of utterance and communicative functions can be combined with principles of discourse. That is, so all this definition brings us to 4 competences, that is linguistic competence, socio-linguistic competence, discourse competence, and strategic competence, which are all the components of effective communicative competence. So what is this linguistic competence? As the name says, linguistic is the knowledge of language code, that is the grammar, vocabulary, and the conventions of its written representation. So how we should speak, the grammar and the vocabulary part is the linguistic competence. Socio-linguistic competence is knowledge of the socio-cultural rules of use while communicating, knowing how to use and respond to language appropriately. And in this, we should not forget to keep in mind the taboos of the culture where you are communicating. So cultural aspects should be given importance when we are communicating in the context. Like supposing I am talking to the tribal population, what kind of communication should I follow? So give importance to their culture also. That is socio-linguistic competence. Discourse competence is knowledge of how to produce and comprehend oral and written text. That is how to combine language structure. So how to organize your words, your phrases, your sentences to prepare some articles, or say newspaper article, or say a poetry. Not everyone can do it. So that is discourse competence. Organizing words, phrases and sentences to make some articles or some poetry or some written communication. The next is the strategic competence. This is the ability to recognize and repair communication. So if there is any breakdown during communication, how do we repair that? That is strategic competence. So for example, if while speaking, while communicating, suddenly you forget some word, so how do you make up for it? So that is, say you can do a paraphrasing, you can use a paraphrase. So that is strategic competence. Say, or if there is any barrier in communication, how do you overcome it? That is strategic competence. Now coming to teaching learning methods, how to teach communication skills. There are a spectrum of teaching learning methods for various domains of competencies. So like the lectures, interactive lecture, symposium, small group, large group methods, demonstration, so many things. For communication skills, we can use lecture, role play, workshop, standardized patients, videotaped examples, peer teaching, etc. So one of the systematic reviews has shown that out of 89 schools they investigated, they found that small group discussions or seminars were the most common method used for teaching communication skills, followed by lectures, then student interviews with simulated patients, then observation of faculty with real patients, then student interview with real patients, and so on. So all these methods have been used. But someone may ask me, why go for lecture for communication skills? Why not just go for a role play or something like that? But it is noteworthy that for any skill component, if we should teach any skills, it is important that the student should first learn the cognitive part. They should learn the cognitive part, then only they will be able to apply the skill part, so that they understand the application, so that they can learn the skills better. These teaching learning methods should be tailored to the cone of experience. So what does it mean? So cone of experience, this you can see in this pyramid. The broad base shows that we should use direct purposeful experiences, and the apex shows that we can go for text or verbal symbols. So you can see that the degree of abstractness increases as we go upwards towards the pyramid. So what does that mean? That is, depending on the cone of experience, our teaching learning method should be tailored. That is, for example, if you're teaching a phase 1 student, phase 1 undergraduate student who doesn't have much exposure to communication, we can go for direct purposeful experiences. Like the abstraction is low. Like you give them some self-explanatory material, or you just give them some words which are easily understood. And as we progress, as they get to know, as they get to learn more and more, the abstractness can be increased. So you can just give them some text or verbal symbols, pictures, visual symbols, and they will be able to understand that by that also. But for phase 1 student, if you directly give the visual symbol or the verbal symbols, they may not be able to completely understand correctly. So that is tailoring the teaching learning methods with the cone of experiences. But what is helpful and what do students prefer? This is what we faculty think, that this is how we should teach. But what are the students' experiences? What do they prefer? Several studies have shown this. Like one of the studies conducted by Evans et al. In his study, it was found that medical students, most of them, felt that workshops along with lectures lead to greater gains rather than lecture only. And in another study, Rees, Sheard and McPherson 2004, they found that medical students preferred experiential methods over class lectures for communication skills. experiential methods like role playing with SPs, that is standardized patients, interviewing real patients, which are experiential in fact. Yet another study, it was found that the use of benchmarks for effective communication along with videotaped SPs, that is standardized patients, is helpful for training and evaluation of communication skills. A word about standardized patient training. Can I have some input about standardized patient and simulated patient? Is there any difference between a standardized patient and? Okay.
To be a patient.
Okay.
But simulation is some kind of artificial thing which is already there.
Simulated patient and standardized patient. Any inputs, please?
Standardized patient is a real patient, but you modify him to suit because he may not be a typical case. So you train him to tell accordingly the history or whatever it is.
Yes, sir.
The simulated patient is a normal person.
Yes, sir. Thank you very much, sir. So standardized patient was once a patient and we modify him or we train him to enact like a patient, like a typical patient, how we want. But simulated patient is not a patient. He may never be a patient. He was not a patient earlier, but he is, we can call him an actor. He is an actor whom we train like a patient. So here, for standardized patient training, how we can do it is, we can recruit some of the, say, I did it for one of my projects where we trained our MSWs to act like patients. During COVID era, when we didn't have clinical exposure for our students, we trained the MSWs in the department to act like clinical patients. So that is simulated patient. So we can recruit and train them by the departmental staff, and we should provide simplified instructions and scenarios to them so that they go through the scenarios and they prepare themselves. Then we can do a 15 minutes telephonic training. Then we call them for independent preparation on site for 1 to 2 hours. Later on, 1 hour training again on site just before the workshop. And then we can also assess them, we can validate them, and finally we can use them for training. So what are the best practices in teaching communication skills? Experiential learning can be used, that is demonstration of best practices in communication skills. We can demonstrate, like for example, in our classes what we do is, we faculty do it first, we demonstrate how to communicate. Like we have used various checklists, we demonstrate how to communicate in different scenarios, and that passes a message to the students how to do it. So demonstration of best practice, observation and feedback, students can observe, then we can observe when the students are performing it, we can provide them feedback. Ongoing training and reinforcement. So training should be longitudinal, it should not be like just train them once and it's over. It is not so. So that is the essence of ADCOM module also, that's how it is designed. It should start from year 1 and it should continue till the end. So it should be a longitudinal training, and reinforcement at regular intervals should happen. Fostering self-awareness, self-reflection and self-assessment is important. So all these things, this self-reflection, self-assessment are all possible. I'll be telling it in assessment part. So these are some of the sessions we conducted. How do we define this consensus statements and blueprints for, how do we define the content for what to teach in communication skills? We have several consensus statements and blueprints available to know what content has to be included in our training or in our teaching, like the Toronto consensus statement, Kalamazoo consensus statement, then Basel consensus statement, and Swiss catalog of learning objectives. These are only several examples I have given, but there are many more available which tell us what contents can be included in the teaching learning method for communication skills. So whatever be the consensus statement or the blueprints we are using, but all these have certain elements in common. That is building a good rapport, then agenda setting, information management, active listening, that is exploring patient's perspective, then feelings of empathy, exploration, then reaching a common ground. So whenever we plan a teaching learning method for communication skills, or if we design a module, these things have to be included. So these are the common elements which we have obtained from all these consensus statements. The problem with teaching is we don't have a uniform curriculum or uniform structure to teach communication skills among various institutes in the country. So there is a lot of variability in teaching, variability in the methods, in curricular time, in the position where, in which phase what is being taught, then the depth of materials, how much deep, like how much of communication skills should be taught and at which phase. It depends on several resources like time, availability of staff, infrastructure, finances, institutional esteem for communication skills. So if the need is there, it is taught. Otherwise, it is not taught. So several factors influence teaching of communication skills. Next part is assessment of communication skills. The Kalamazoo 2 report said that there are at least 5 ways to assess interpersonal and communication skills, like rating of direct observation of interaction with real patients by maybe mini CEX, that is mini clinical evaluation exercise, or a checklist of specific behaviors, or global rating of the performance. The second one may be rating of simulated situations with standardized patients, like the OSCE or single simulated encounters, or rating of video and audio tape interactions, that is the video audio review, checklist, linguistic based analysis. So this is like the students will record their video with when they are communicating with the patient, or maybe even with the family member or a simulated patient, and that can also be rated. Patient's questionnaire or survey, that is the best assessor is the patient because he is the ultimate beneficiary. So patient questionnaire or survey can be used. Examination of knowledge, then procedural knowledge, scripts, perceptions, attitudes, etc. So it is necessary to know the cognitive level of the student as well. So for that we can use such exercises like MCQs, empathy and emotional intelligence scale, or script concordance test. So all these things can be used. Maturity of clinical communication skills, teaching and assessment. So even when we use assessment, just like the cone of experience, how we tailor our methods to the cone of experience, even assessment should be tailored as the maturity increases. So for example, in early years, we can use single standalone courses, followed by, as the learner progresses, we can go for fully integrated or multi-method assessment, what we can call as 360-degree assessment. So initially, we can assess for individual components, and as we progress over the longitudinal curriculum, it can be a fully integrated assessment. Sample assessment methods include, for knowledge, this is a known thing, like for knowledge we go for MCQs, or for higher levels, higher cognitive domain, we can use short answer questions or scenario based questions, long answer questions. Then for procedural skills or this communication skills, we can use OSCE or standardized patients, simulated patients. For DUS component, which is mostly the workplace based assessment, we can use mini CEX, DOPS, 360-degree evaluation, portfolios. So out of this assessment toolbox, we can use several assessment methods for communication skills, like when the student is interacting with patient, or it could be a real patient or a standardized patient, when he is interacting, at the same time when we assess the clinical skills, we can also assess for communication skills. So it is mostly shows how component that is being assessed. So this is a known thing. Now we have several rating scales for communication skills, but how to choose or develop an appropriate instrument. We ourselves can also develop an instrument or a checklist for assessment of communication skills. First thing is we should know what are the constructs to be measured, that is the objectives and content of teaching and assessment. So what else will be tested during the station? So what are the things you want to test in each station in an OSCE? Who will be the examiner, whether it is an observed station or unobserved station, and who will be the observer. Checklist for rating scales, that is we can have a Likert scale. Then the psychometrics, that is we need to take care of the reliability and validity of the instrument. So there's another guide, that is a Calgary-Cambridge guide, which also guides us to include the contents and to design a teaching module for communication skills. So to summarize, there are certain tips for teaching and assessment of communication skills, like involve multiple disciplines, involve all the stakeholders, keep it regular and continuous, that is it should be a longitudinal program, use different methods, not only one method, use different methods for teaching as well as for assessment, make it standardized, module based. Supposing we want to start communication skills teaching in our place, how do we do it? First is need assessment, assess what is the need, then find out what are the objectives, build communities, that is the communities which have similar interest, build communities, train the people in the community. Why we should train? Though they may be knowing, still training is important so that uniformity is maintained. All of us should be at the same level when we impart teaching or assessment. Prepare modules, then pilot run, modify and finalize the module, implement the module and evaluate the module. So after evaluation, if you feel that there are some modifications which have to be made, we can modify and further finalize the module. So how did we do it? We also developed a communication skills module in our institute for the Department of Orthopedics for postgraduate students. So in this module, these are the steps we also followed. Like we had a core committee. We trained all the people in the committee. Then we decided what should be the objectives for the postgraduates to learn communication skills. What are the various objectives? Then we decided what teaching learning methods we will use, how do we assess, how much time is required. So we developed a module and we could do it successfully. The outcome is good and we are passing it on to next batches also, and maybe we will involve other departments also. So thank you.
Thank you, Dr. Lavanya Garu, for your effective communication and lecturing on these communication skills and teaching and assessment methods. You have very beautifully summarized and communicated the importance of communication, various forms and styles of communication, the need for the communication skills for an Indian medical graduate, and you know that the cone of experiences and the standardized patients, simulated patients, experiential learning, the effective, patient communication methods, and all these points, including the assessment toolbox and various rating scales. Ma'am, I know that in majority of the classes, we have no questions asked. In Viva, no answers will be told. So this is what our expectations and our experiences in majority of the times. So we know the importance of all these communication skills. What are the methods you are following in your institution, like to improve particularly of student community?
Yes, sir. So first thing is, sir, let them communicate freely.
No, that's what. Usually what happens, if you ask a question, they'll say, let me give an example. You tell me the molecular mechanism of propranolol, definitely they'll say no. They'll be keep quiet. Then you will ask, what is a propranolol? For that also, they'll keep quiet. Then you will ask that whether propranolol is an antihypertensive drug or whether it belongs to CVS, that also they'll keep quiet. Only thing is, this is a kind of a self-viva. The examiner is asking the question and he is also telling the answer, but only thing is the student has to say yes or no. So this kind of scenario is going out. So the point is here, what are the other methods we can inculcate to improve the communications? No, this is of medical education related question.
Sir, for your question, the answer is like the student may not know the answer also. So that's why he may not be answering.
No, the point is, whenever I went as an examiner to, I know that Manipal, other higher institutions, it doesn't mean that they're on par with subject, they're good with us. It doesn't mean that. They have a better communication skills. So with that communication skills, they impress the examiner, so that these kind of things will definitely help in a student life. So this is my opinion, ma'am. Thank you. Sir, any questions?
Thank you.
Now the questions will be open for the forum, I think. Any questions from the forum? Yeah. No questions. Thank you. Thank you so much. I thank all the organizers for giving this opportunity, Dr. Lakshmi Lalita ma'am and Dr. Havila and other organizing team.
Thank you, ma'am. I would request the chairpersons to please give a memento to Dr. Lavanya. Thank you, ma'am. Before the panel discussion, we have another small talk by Dr. Manaswini Das. She is the MU coordinator of the regional center at convener and professor of professor of microbiology and convener of NMC Regional Center, Ashram Eluru. I also call upon Dr. Lalita Hanmantu, Professor of Pharmacology from Government Medical College, Srikakulam, and Dr. Ramani, Ma'am, Professor of Surgery and MU Coordinator, GMC Vijayanagaram, to please chair the sessions. Hand mic, yes, ma'am. You can take. You want a collar mic or a hand mic? Yeah, ma'am.
Thank you so much, Havila ma'am. Yeah.
Good morning, respected delegates. Today we have a very interesting topic, humanities in medical education, which is often missing and which has been an hidden curriculum. Now it is opened by the CBME. We have Dr. Manashwini Das, Professor of Microbiology. I'm fortunate to introduce her today. She has done her graduation from MKCG Medical College, Berhampur, Odisha, and post-graduation from Ashram, Eluru, and she has done her SRship from SGPGI, Lucknow. Now she is working presently as Professor of Microbiology and convener of Regional Center at Ashram, and she is currently pursuing her FEMA at CMC Ludhiana. She has also done her NTTC from JIPMA in 2015 and ACME from St. John's from 2017. She has several research papers for her credit, and she is also pre-accreditation entry-level assessor for NABH. She is also awarded prestigious Professor Ponduri Venkataramana Rao Gold Medal by NTR UHS for securing highest marks in microbiology in 2011. She is also been certified with Certificate of Merit from District Collector of Eluru in 2021 for services rendered during COVID pandemic. Now I request Manaswini Das to please present her talk. Thank you.
Thank you so much, ma'am, for the kind introduction. A very good afternoon to the respected chairpersons and the august audience. I know everybody will be a little bit apprehensive that I may not take more time, but I assure you that I won't. And I am following up on the talks given by very eminent people who have been, all of them have been my teachers. So it will be difficult to follow up, but yet, because this humanities topic is such an ocean, I'll just skim through and hopefully it'll be imbibed in some way. Like Lavanya madam said, baby steps. So hopefully we can take baby steps there. So the first question comes is why humanities and why now? So we have here the human kinship part, whether so many topics, so many things have been discussed on AI that we often have that apprehension. Are we losing? Are we losing that human touch? Are we losing that human kinship? Are we losing that bond, that interconnection that we have with each other? So humanities deals with that and much more. Humanities is basically arts and literature. It can be poetry, it can be drawing, it can be a sketch, it can be anything. So which is completely related to whatever humans do to overcome so many things. And then medical humanities is study of all that in medicine. And it is not the same as humanism, which is basically a philosophy, and it is not the same as humanitarianism, which is basically a charitable endeavor. So can I have the slides back, please? Okay. So we can continue with that. I think many of us might have heard of the mathematician, a very well-known mathematician known as Kurt Gödel. So he was an Austrian mathematician who developed a completely different theory. That was the incompleteness theorem. So all of us believe we are all scientists. We believe that yes, we do research. We do a lot of statistics. We do a lot of analysis. But are we, whatever we are doing, are they all proven? So this person, Kurt Gödel, what he said was, there is an incompleteness theorem, to which all the mathematicians started shouting, no, mathematics means it has to be proven, it can be proven. But how it can be incomplete? But sometimes within a reasonable mathematical system, there can be so many things which cannot be proven. They are true, but they cannot be proven. Similarly, we have to think about the humanities. There are so many things which are so vague, so foggy, but yet with our own humanity, we can solve them. So there is a very famous quote by the Sufi poet Rumi. I went inside my heart to see how it was. Something there makes me hear the whole world weeping. So once we glance inside our own hearts, not even into the hearts of others, we can feel those tears, we can feel that angst, we can feel that pain. All of us have gone through that. And yet, we just need to look into our own hearts to understand what the other is feeling. So in this particular this session, I'll just cover a little bit of the history, the concepts, the different focus areas, teaching and learning methodologies. Many of them have been covered by speakers before me, so I'll try to avoid those. Certain ideas, only ideas, about implementation and assessment. So there was a very famous person whom we all know, whom we all love, even though we might not have met him. So medicine is an art and not a trade. So humanitas and misericordia, these are the words of a a person who was very famous then in the 1st century AD, Scribonius Largus. So humanitas basically means love of humanity. Misericordia is full of mercy. We have to be full of mercy when we are a doctor. So history, philosophy, literature, these are all integral to the Department of Humanities in the Penn State College from the 1960s. So they have been incorporated in certain places, yet they have been very discreet, very sporadic. So there is a title also, PhD or DPhil, that is philosophy, a doctor, but most of these courses are unstandardized, many of them are voluntary, and most of them are isolated. So I came across a very interesting paper which was published in National Medical Journal of India by Vidya Viswanath. So there was a very famous Carnatic musician by the name of Dr. Padmini. So she was a very famous musician, and once she donated her body, this student of hers, the students of hers, they wrote that this is an ode to a teacher who was, who is. In this paper, once we go through, we'll see that the angst of that student who feels with the beauty that she used to play the Beena, with that same beauty, please be merciful to her cadaver, do learn from her, even her veins, even her nerves will play that sweet music of knowledge to you. So this is how we can incorporate many, many things. And first is, why do we need to incorporate? Should there be a need at all? Is there a purpose at all? When we are very young, we can see so many youngsters here. When they are very young, they have an idealization. We grow up with the thoughts of Buddha. We grow up with the thoughts of Rama. We think that they're ideal, they're the best. And all of that protection comes from our parents, from our friends, from our family, from our relatives. And then once we come to medical college, we start the journey with a lot of excitement. And then slowly we understand that yes, if I have to complete this, I have to be very clinical. I have to know a lot of knowledge. I have to have that clinical competence. I have to be very skillful with my hands. And then comes the phase of traumatic de-idealization. We are traumatized, we are stressed, we are burnt out. We simply want to complete our work. That patient, that case, you finish it fast. That is what we want. So in that phase, when there is an absence of caring, mostly from our own teachers, from our own peers, from our own friends, from our own seniors, that dedication, that enthusiasm is slowly lost. So there are different attributes of a good doctor, but all of those stem not only from science. We all love the sciences. Science can give you understanding, a method, and the evidence-based medicine that we are so fond of. But at the same time, there are arts, there are the humanities, which can give you your ethics, your adaptability, your broad perspective, your being non-judgmental to different people. So all of that will contribute in giving you an interpretation, an insight, and your technical judgment along with your humane judgment will make you give your clinical judgment. So both of them are equally necessary for being a good doctor. Patient care has to be the primary concern. We are dealing with patients. That is what we have to understand. Our ethics, our moral principles, our communication, our learning skills, our empathy. All of us know what's the difference between sympathy and empathy. We go to that place, we feel the pain, we understand the pain, and then even if we feel it, we have to be able to cope with ambiguity, with change, with complexity. So there are so many different focus areas, like communication. Madam just told that there are so many different facets. It's so beautiful. It's so complicated, and yet at the same time, we are doing it every day. And that is unconsciously. We are going through all the steps. We are engaging, we are empathizing, educating, enlisting. All the clinical consultants are doing it, but they are doing it spontaneously. We don't, yes, step 1, I have completed doing this. Step 2, I have greeted. So all those we don't do because that thing is integrated with our clinical and all the learning that we do even in the classroom, because that is what the teachers have been showing us. And that comes to a spontaneous behavior in the student. So all these trainings have to be multi-session. We cannot simply go in one session and we tell them that this is how it should be done, and then the student learns it. It has to be multi-session, it has to be multidisciplinary, and there has to be multiple methods. There have to be different opportunities for demonstrating, for discussion, reflection, practice, and ultimately feedback. So professionalism, all of us know, they lean on so many pillars. Even though the base is clinical competence, yet we have to have ethical and legal understanding. We have to have cultural competence, the difference between cultures. We have to understand that. We have to have all these pillars, the humanism, the accountability, the altruism. Altruism is selflessness. Selflessly you help somebody. Somebody's car has broken down. You simply push it. You don't think of whether that person will be able to help you back or not. So in professionalism, there are different aspects. Like in an institute, most of the institutes I have seen, here also it is displayed in gems very beautifully, that all these aspects are already displayed. They are made sure. Each person who joins nowadays in institutes, most of them are trained people. And that is when they get hired. So that is how this grows. And this is a longitudinal program where there are professional role models. All of us have had role models. I can see many of my role models are sitting here in this room. So there are different aspects like mentorship, early clinical exposure, and now professional reflexivity, like Madam so beautifully presented yesterday. Beautiful reflections written by her own students. So that is how that person becomes professionally competent. So cinema education, I think Madam has given the example of Shankar Dada MBBS. So we can have other movies, we can have movie clips, we can have trigger films, we can have clips from The Doctor. A very old movie is there, The Doctor. There a doctor, he comes in, he is sick, and another doctor just sees him, and then she is very professional. We will think she is very competent. But she simply diagnoses that's a terminal illness, and then she gives him the diagnosis, you go. So that is how it happens. So all of these can be used as triggers to help them think, to help them reflect on what has happened. There are movies like Anand. There are movies like Patch Adams. So how can the person who is a doctor, they can be very empathetic. They can relate to the patient. They can use humor. In dark times, we need humor to overcome that sort of thing. So it is a very strong medium because it is aesthetic. We have audio-visual images. So once we see and once we hear, and all of that is incorporated in the student's mind, and then that is imprinted, and that stimulates your group discussion and all these trigger questions. The main thing is we are not to simply show a movie there. We are not going to simply show them a movie. Then it becomes cinema instead of cinema education. So that is when our trigger questions, our discussion questions, all of the group discussions that go on, and then they come to a conclusion, and then they tell that this is what should happen. And instead of that, there are so many gray areas. So how to overcome them? So these challenges, like in-depth reviews, the popularity, sometimes the popularity of the movie sometimes intervenes. The hero is such a beautiful hero, heroine is so pretty, we are all lost in that movie. No. We have to think about the theme, the notes, the discussions that follow, and not to let emotions overvalue the real message. There are so many role plays that all of us might be doing as teachers, because these are all experiential learning experiences. All the three domains, the cognitive, the psychomotor, the affective, all can come into play. We can have interviews. A student interviewing another student. One is a student doctor, one is a student patient. So that is how they do. And then the entire class pays attention, they come to discussions and come to a conclusion. So all these are structured. They can be completely or incompletely scripted. Many of the times we forget about scripts. We simply tell them that you do this, you do that. So what happens is often without ground rules, that role play goes in another direction. So that is what we are not going to allow, because it has to be structured, and we have to make sure that we take feedback on how to improve upon. Those scripts we can use for another batch. But we have to make sure that the discussions go in the right direction. So the student doctor, the student patient, and ultimately the SPECT actors. They are not simply spectators. They are SPECT actors. We'll come to SPECT actors in some time. So there can be roll cards and so many ground rules where the learning objectives are completely clear. We are not going to fumble about what I'm going to teach in that class. I simply wake up at 8 o'clock and then go take a class at 9 o'clock. I make them do a role play. My work is over. Everybody enjoyed. They clapped a lot. The girls were laughing a lot. There was a lot of hooting. That is not the role play, which should be the thing in the class. So a reflection in and on action can be done in role plays, and it is a part of even our formative assessments. Suppose a case of diabetes comes, how do they deal with it? So all of these can help us when role plays are not resource intensive. We can do it anywhere. We can do it in the clinics, in our discussion rooms. We can do it in our own theory classes. We can do, because these are highly feasible, and we can reuse the same script. And learning is really fun. Students enjoy, the teacher enjoys, and then all the reflection, feedback, and assessment for learning can occur, provided we have to make sure that there are certain ground rules. So there are so many different aspects also, like theater. All of us have heard of theater, beautifully played theaters, and we feel that emotion that actor has played so beautifully. But then there is another type of theater. There can be propaganda theaters also. Well, we go and propagate that, yes, this is the thing. We have to do family planning. We go to villages and we tell them. But this type of theater is one which helps all the students to think and then come up with solutions. That is theater of the oppressed, or theater of the living. It has so many different types, like the forum theater. There what happens is the teacher basically becomes a facilitator. All of us now agree that we are all facilitators. That facilitator calls himself or herself a joker, and then they have so many fun games, so many fun exercises where deeper reflection by the participants can be done. We can see on the YouTube also the New York Society Theater of the Oppressed. So there is a homeless man, and his child has been taken away from him. That's such a vague topic, and he is suffering. And after being played, there are the SPECT actors. Many of them might have gone through the same thing. They have come there to watch. But because they also have been oppressed, among our students, one student might have been oppressed by somebody else, maybe in their school life. So then they replace one of the actors, they play it differently. They can come up with another solution to that same problem, or they may not come to a solution also. But yet, that is helping the students think, to understand these vague topics. So this theater of the oppressed was brought out by a very good educationist. He was Augusto Boal. So what he did is, we are not simply citizens who are only claiming our rights. So it is not simply a revolutionary theater. What we do is, it is only a rehearsal for the revolution. So what he said, and what has helped is, we have seen very beautiful articles are also there by Dr. Purnima Barua and Satyendra Singh. So they have done 1 month workshop for theater of the oppressed, and what they found is, this was done in a local language also, in Assamese, and then the joker also facilitates in Assamese, and then what they come up with is a lot of great ideas. So in this article, they have written is, resolution may not come on that day itself. So what we have been doing since these past 3 days, on this day we may not reach to any solution. But once we go back, we reflect, we think that, okay, this thing I can do in my own session, that thing I learned in that particular session, in that particular conference. So we are better equipped to handle those situations. So there are so many case studies. All of us have been doing case studies. So we think, oh, it's just a clinical case. A 56-year-old man presented with so and so and so. But there can be differences in case studies also. These case studies can be real or hypothetical cases. They can be narratives. They can be narratives from the patient. They can be narratives by the doctor. They can be poems. They can be a theater. They can be a movie. They can be literature, art, music, drawing, anything. And what we do is we prepare the questions and prompts before, we provide the resources to the students before, we create the teams, and then once the new case is given, we make sure that the learning objectives are attained by the students, and then the formal or informal assessment of the case is done by the students, discussion is done, closure is also done, but with the feedback and modifications, we can again go back to that cycle. So it will be very helpful only if we make sure of time management, and discussions, reflection should be proper on that, and these can be made in small groups as panel discussions, as hybrid models, in self-directed learning as we have been learning since past 2 days. So this can be open-ended. And we have to facilitate and do a trial run before. We simply can't get up and go and then do a very nice case study on a very beautiful literature thing written. So the patient and doctor narratives, the disease, the symptoms, all of these can be longitudinal also. With integration, all of us have come across longitudinal case giving. So once we give a linker, so all of that goes through phases, and all these will help not only in reflection and discussion, it will also help the students develop teamwork and leadership skills. Formative assessments also can be done with these sort of case studies. There is a very beautiful writing long back in 1988 in JAMA. There was one gynecology resident. He writes that he was very tired, he was having a very tiring day. He just went into the gynec ward, he was called upon, and the patient is having so much pain. He just sees one case file of the patient, and then he goes in, he sees that the patient is in so much pain. She's a teenager, and then what he does is, her mother is very, very worried. So what he does, he takes the loaded syringe of morphine which the sister has kept, he goes and he pushes it in. And then what he writes is, the patient is now relieved. The patient is now relieved of the pain. The mother is relieved of whatever tension she was going through. And what he writes is, it's over, Debbie. It's an anonymous author, but after that, reviews came in. So in the review, what they have written is, it's not over, doctor. He has not gone to any panel. He has not asked any of his seniors. He's a gynecology resident. He sees one patient in pain. He knows that it's a terminal illness, and he simply helps her along the path. And he thinks he has helped everybody. The mother is relieved. Everybody is happy. The nurse is happy. The doctor is happy. The resident is happy. Everybody is happy. It doesn't work like that. It can be a case of second-degree murder. So these sort of cases we can introduce to students, where they learn about ethical principles, where they learn about end-of-life care. They can learn about so many different things in that one piece of literature. It's hardly one page. There is another very beautiful writing, naturally, because it's by Leo Tolstoy. It is the death of Ivan Ilyich. So that is in so many different parts. But to summarize, there is one person known as Ivan Ilyich. He's a barrister. He dies. He had a very big position in the court. And then it starts with one of his colleagues. That colleague is thinking, I have to go. I have to go and I have to attend. I have to attend to that dead body. I have to stand for a minute beside him. And then it has the narrative of the wife. The wife is thinking of the insurance money. There is a young child, a young boy. He is very angry. He is very suspicious of everybody. There is a young daughter. There is a young son-in-law. And finally, there is the part where the person himself, Ivan Ilyich, when he was diagnosed, before he was diagnosed, how he was. He was so ambitious. He was so full of life. He wanted to become very, very successful. He wanted the highest of standards. He has done nothing wrong in life. But once he was diagnosed with a terminal illness, what sort of thoughts go through his mind? And then finally, when he has that pain, and while death relieves him of that pain, all of those are described in that one story. So if we give parts of these stories or parts of these literature which are timeless, the students can understand the viewpoints from different angles. So there can be comics which can be used, forum theatre as we have discussed, poetry to evoke empathy.
And all of us know about role modeling, right? So there was the most famous role model, that was Drona of Ekalavya. Once he saw that dog full of arrows in his mouth. And I have not taught all these things to Arjuna or his contemporaries. So who has done that? So that was done by a person who has role modeled without knowing. So ultimately, that role model becomes sort of venomous, and then he tells to cut off finger and whatever. So role models have always been there. A person might not have known, but they have been taken as a role model. So influencers are there. Suppose we like, yes, that sort of dress, that sort of thing is what we like. So naturally, we tend to emulate. Similarly, our students also tend to emulate that thing. So that is what can help the students in understanding in the eye of the beholder or in the mind of a visionary. A role model always exists. So these can help in academic, intellectual, as well as professional identities. So creative writing has been covered in detail by Devi Madhavi madam quite beautifully. So I'll just constrain it to only different parts, like what is the concept? Whether it is illustrative, whether there are any probing questions to your creative writing, it can be a poem. It can be a flowchart. It can be an image. It can be a photograph of something that a student has taken. So what is the genre? So whether it is a prose, whether it is poetry, what type of narration is it? The point of view of the author, or whether it is in the second person, or whether it is grandiose, or whether it is self-pity is taking over. What is the diction? What is the time where it takes place? What is the plot? So whether it is serious or not, and what sort of images or emotions that sort of creative writing is evoking in us. And then are there any gaps or left out text in that particular writing, whether he can develop further on it, and finally, what is the author trying to convey? So artwork, comics, and cartoons have been used since long. When we were children, we have all seen Tom and Jerry, and yes, we always remember. Maybe till old age, we will always remember. I think most of us know that painting, beautiful painting by Sir Luke. So what he has made is, the painting is termed The Doctor. There is a very sick child, and there is a doctor who is looking worrisome, and he's sitting, and in the background, the parents almost fade into the background. So while the doctor watches on, with empathy, and a lot of empathy in his eyes, and we feel that once we see that painting. So because artwork has always been there, since the day that we have seen so many drawings done on the walls, even in Ajanta and Ellora, what sort of thoughts these artwork, how they evoke so many images, because they are aesthetic, they are thematic, they are comprehensible, and different sorts of terms like patient autonomy, challenges, all of them can be brought into that sort of thing, because there are now online digital apps. Different comics can be created online. Once you script that thing, the comics, you simply don't start drawing from the beginning. This is for the students. So once you have a sort of script in mind, then what you do is you just make that script run, and then you put in the drawings. This can be helped to take assessment of critical reflection also. So this artwork was particularly there in BMJ. It was once published. So while coming to implementation, this is a force field analysis of what are the things that actually help us. So there are so many things that can help us. All our faculty development programs. All of us are here. We have spared all our time, our energy. We have come, and then we are learning. Because all of these will ultimately help us in developing ourselves as well as mainly our students. The ATCOM, it has so many competencies. All through the years, in all phases, we can have so many competencies that are directly related to our medical humanities. It is only up to us how to imbibe that. I remember in the time of COVID, we just had a topic of bioethics. So what the topic I told the students to present, and what they did is they came up with such beautiful ideas. They came up with a glasnost. They came up with experimentation with humans. So all of these things are already there in the students. It is just us who just prompt them to bring out the creativity that is already there. Because humans, by nature, they are creative. Community medicine exposure, like the family adoption program, which happens from the first year itself. So all of that helps the students to connect with others and develop a field. All the clinical postings, the student doctor, which has been beautifully described by Chalam sir, all of them are helpful factors which help us to develop medical humanities. But there can be resistance to change. There can be lack of uniformity, infrastructure, and most importantly, time. We feel there is a constraint of time. But what we can do is, already whatever we are doing, our ATCOM sessions, we have our hours, we can incorporate small bits and pieces, the baby steps, as ma'am told. So all of those can be done slowly, yet steadily. We can steadily progress and then develop. So assessment can have so many different facets, but because these are soft skills, subjective assessment is required. Now, all of us we were trained that objectivity should be there. It should not vary from me to him to her. But now subjective assessment has taken up a higher role. In all of our higher education, we have to write reflections. Why? Because the point of view of a person like ma'am or a person like sir will always vary. So that subjectivity can be a wrong thing in someone's eyes, but it can be a very good thing also. Suppose it is creative. Suppose it's bringing out a different facet which we never thought of. So that will bring out all the subjectivity which can be there, can be harnessed to our advantage. So it can be a part of ongoing programmatic assessment, because if it's discrete, then the students will act very sweet in front of the parents, in front of the patient. So they'll act very sweet if we have a separate station for that. We should incorporate that as a part of our regular assessment so that they incorporate it spontaneously into their own. So directly, we have to observe, and it can be a part of formative assessment. Multi-source feedback is important. Like all of us have been discussing about 360-degree assessment. The nurse tells, the attendant tells, how did the doctor do? So all of that can be used, can be harnessed. These critical incident reports that ma'am had mentioned yesterday. So there can be a critical incident. How did it go? Why did it happen? All those details can be put into that report. All these case-based discussions that we thought about, and student portfolios, all of them can help us. There are many checklists, there are many scales which can help. The professionalism mini evaluation exercise, it can have so many scales in which whether did he greet that doctor, whether he talked properly, whether he thought of that person as a human, and whether he treated humanly or not. So the Jefferson scale of empathy, from so many different topics, they brought out 24 points in which they thought that empathy can be expressed. The Kalamazoo statement, which ma'am expressed, and the altruism scale for adults, like did you help one stranger with his car? So all of these can be used to self-score also. Many of them can be used for self-scoring, and then finally realizing whether we are incorporating humanities or not. So to conclude, knowledge and skills have to be integrated with attitude and communication. All of that we know, but how do we do it? We do it in bits and pieces, in small steps, and then, because it is multifaceted, we will bring out a humanistic physician of first contact. He will be humanistic, he or she will empathize, will feel the tears that are there in the other. All these are an amalgamation of science and art. They are longitudinal, they are interactive, and they have assessment to have any relevance. So because these will help in role modeling and guidance, which has to be very, very patient. We have to be patient, we have to help them in order to develop that. And sometimes we have to be patient enough not to make them lose that. Most of the times, because they are youngsters, they are starry-eyed, they come and then they slowly start losing. We can help them maintain and then grow. So these are my references. And to conclude, this is a picture from the James Webb telescope, recently published in the journal Nature. So what they found is 10 galaxies in the universe are interconnected in a cosmic web. There are cosmic filaments, if we can feel that, through black holes. They are all interconnected with each other. And the other picture is from Avatar, the Tree of Souls, in which all the animals, the plants, everybody, even the voices of ancestors can be heard just by connecting there. All of us here are ultimately connected. We are having a web, and that web is always working unless we stop it from our side. So we can feel the angst of others, we can feel the pain of others only if we deem to make ourselves realize that. We just need to look into our hearts. I thank the organizers for giving this wonderful opportunity and all the audience pre-lunch for listening so patiently. Thank you so much.
Thank you, ma'am, for this wonderful talk.
Thank you, ma'am.
I think everybody has felt a lot of connection to you and to this rarely dealt upon topic.
I can only bow to that. I can only bow to that. Thank you so much.
Ma'am, it was an eye-opener because of the addition of so many new elements, like we could use narrative approach in
Yes,
case
ma'am.
studies
Yes,
and
ma'am.
theater of oppressed,
Yes,
and the wonderful way in which literature can be used to help the students inculcate different coping mechanisms.
Yes,
ma'am, thank you very much. We are very honored to have listened to your talk, and I hope this brings about, and this is a start of a rehearsal
Yes,
for
definitely.
revolution to deal with this humanities in medical education for a better, well-rounded personality in our medical students and ourselves.
Thank you so much, ma'am. I thank you so much.
Any questions from the august audience here regarding this topic?
Good afternoon, madam. Do you think humanities should be a topic, like a separate subject?
Definitely, sir. Actually, there are separate subjects in several universities. Pardon, sir?
In the medical education.
Yes, sir. These were all related to medical education. These are not actually what has happened in Europe and US and Canada and all since long back. I just showed that in the Penn University. They have been having this as a separate subject. Some modules are voluntary, some modules are compulsory. Once the students just grow up and then they become interns and they go to orientation programs. So that is sometimes compulsory also, and sometimes it can be voluntary. The thing is, anthropology, sociology, many parts are actually taught in community medicine. They're actually taught. But we have to realize that whatever we are teaching, suppose we are teaching about a case study, we are talking about a case of HIV. Are we talking about what that patient has gone through, what that wife has gone through, what the small kids have gone through? So all of that will bring the humanistic element into already what we are teaching as medicine.
Thank you.
Thank you so much, sir.
Thank you so much, ma'am, for that session.
Thank you.
May I now call upon our chairpersons to present a memento to Dr. Manaswin. To make the post-lunch session active and interactive, we have shifted the panel discussion of DRP post-lunch so that the physiological causes will not hinder. So we'll break for lunch now, half an hour lunch break, and we'll come back and then have the DRP discussion, please. It's very interesting, so please come. The panelists are very enthusiastic, so please come for the DRP discussion. Half an hour lunch break, please. Please finish off your lunch and come inside. Don't wait for somebody to call. If you are coming inside and sitting, then we can start the session.
Guests and my fellow
scholars of medical education. So I stand here today very delighted to invite you for or welcome you to this discussion, panel discussion. We have gathered just to have some engage our minds into some thought-provoking exchange of ideas related to the topic, what Madam said, District Residency Program, also known as DRP in short. So I will give a little bit introduction about DRP. It was announced by the National Medical Commission in 2020, and it was made mandatory from the 2022 batch of postgraduates. And it was an ambitious project which the NMC focused on the community-centric approach. That's why the project had mandatory 3 months residency program in any district hospitals, before they finished their tenure of 3 years of residency. So this panel discussion is a platform to discuss the shortcomings, the ideas, any shortcomings, with the experts, and they will be doing the thought, sharing their insights. They will be challenging the notions, the pros and cons of everything of this particular DRP. Basically our aim is to gain maximum knowledge or foster maximum knowledge or in-depth knowledge of what DRP is, how it is functioning, how it is affecting the healthcare system of our community. So without further ado, let's start on the journey. And with any journey is incomplete without any proper guidance and guides. So I would like to invite the panelists, the guides, the thought leaders of this session on the dais one by one. So starting with, I'll call upon Dr. Venkatachalam sir. He is a cardiologist by profession, and he is presently the principal of RIMS Government Medical College or Government Medical College, Srikakulam. Next I call upon Dr. Padmaraju sir. He is an ophthalmologist by profession. He is a former medical superintendent of GEMS, and presently he is a professor of ophthalmology department. Then I call upon Dr. Jyoti Padmaja madam. She is a microbiologist by a profession, and she is a former principal of our institute, GEMS, as well as Geetams.
Good afternoon, everybody.
Next, I call upon Dr. P.J. Srinivas sir. He is a community physician by profession. He is presently the associate professor in Department of Community Medicine in AMC, reputed AMC College, as well as he is also the conveners of Research Center in Medical Education Training in Andhra Medical College. And last but not the least, I would call upon Dr. P. Srinivasalu sir. He is additional medical superintendent of GEMS, and he is a forensic medicine expert by profession. So welcome everyone. It's an honor to have you people here. So with your permission, I would like to start the session. What up? So with your permission, I would like to start the session, ma'am, sir. So my first question to Dr. Jyoti Padmaja madam is, according to you, what do you think that what impact the program has or had on the healthcare services as in the rural communities since its inception? Because it is a baby project, it just started. So according to you, what is your take on that, madam?
So thank you for having invited me to this panel discussion.
Initially, I would like to make a correction that this program has been implemented from the 2021 batch.
Okay.
So they said that it should be done by the postgraduates who are in the 3rd, 4th or 5th semesters. So now the 21 batch, which is in their 2nd year, they are currently undergoing this program.
Okay, ma'am.
That's one thing. So actually there was a lot of debate when this program was about to be implemented. There was a meeting with all the colleges, I think all the deans and principals, they had participated. So everybody requested the PG MEP that the program should not be for 3 months and it can be reduced to 1 month or 1.5 months. But of course they listened to everybody and finally of course they can take the decision. So it was ultimately decided that it was 3 months and we had to implement it. So a circular was released which said that this has to be implemented not only by the government colleges but by all private colleges as well as the colleges under deemed universities. And then they also gave a clarification that the hospital should not have less than 100 beds and it should be flexible and so many things. They said that accommodation should be provided to the residents and then security should be provided, transport should be provided, so many things were there. So when we look at the name of that program, the district residency program, so was the program's main intention based on training the residents or was it to improve the health care of the rural population? Is something to be debated. So the rural population maybe will benefit because there are more of doctors who are being trained in particular specialties. So maybe it is increasing the volume, that is the number of the doctors who are attending those hospitals and maybe the quality also.
Okay, ma'am.
But I think it has more of, looking at the real life situation, I think there are more of pitfalls rather than, maybe it was embarked, I don't say hastily, but maybe everything was not thought of and several changes happened even after declaring what all they told. There were so many other things that couldn't be fulfilled. And then the initial breakup of the residents into the various areas also got changed eventually.
Yes, ma'am. Okay, so thank you, ma'am, for the insight. Now my next question is to Dr. Padmaraju, sir. Okay, how does the district residency program impact in the skill development and clinical experience of medical postgraduates compared to the traditional medical education what we are having right now?
I'll just make a few sentences
Sir.
upon the twin principles upon which the DRP program was introduced by the central authorities.
Okay.
One is simply 3 words: learning whilst serving.
Learning while serving.
Yeah. So, learn what the community requires. Direct the actions towards the needs of the society. Okay. So, that is the first principle upon which this DRP program was initiated. The second principle was that the doctors should have an experience of what the ground reality is at the district level.
Okay.
So these are the 2 principles upon which the DRP program was introduced. It had few objectives. Well, I don't think, there is a time constraint.
Yeah.
So the question is whether the clinical experience, clinical acumen, the skills of the postgraduate students, how is the DRP affecting these 2 things? Okay. Was it not? So I feel that in the district hospital, the number of cases, then the assortments or the variegated presentations, they are much more than in the teaching hospital.
In the teaching hospitals, yeah.
So I think that way the postgraduate student stands to gain. The second thing is, in the teaching hospital, the complete set of faculty, right from the professor to the SR, is available. And what I see in the OP department is that they come, they have a doubt, they get it clarified, they take instructions from the professor or associate or whoever it is, then go away. But in the district hospital, it's a standalone situation. Now he has to depend upon himself, then take in account the assessment of the science, then the symptomatology, assimilate everything, think about what could be the diagnosis, again argumentatively consider the differential diagnosis, initiate therapy, and also assess as to what happened to his therapy at the review point.
One question here. But there is a specialist there in the district hospital.
I know.
So he's also faculty. Like, there will be ophthalmologist there.
Yeah.
There will be a surgeon. So he can take their, so just like you are giving here, he can take from them.
Yes.
He's not alone on his own.
Yeah, I will come to that point. What I was thinking was, apart from the person who is qualified person who is in the district hospital, he can always have the electronic devices with which he can contact his own professors, his own department. Nowadays, with plenty of these equipment is available, so he can easily do what is appropriate at that point of time. But there are a few disadvantages. If the infrastructure is insufficient, then the posting of this person is going to be not of much use.
Yeah, definitely.
Only, I'll just add one more thing. Madam was saying about the quality improvement as far as the patients are concerned. I'm just adding that aspect of it. That part of it, I'll just give you an ophthalmic example. You see what happens for the cataract patients, they get operated for one eye. Once they are able to see properly, they'll neglect the other eye. Every day in the outpatient department, we come across a case of lens-induced glaucoma. In this LIG, if we are able to intervene with a time constraint of 24 or maximum 48 hours, the vision of the eye will be saved. So our postgraduate students, when they are in the third or the fourth semester, they are trained enough to pick up these cases. So that way, I think the patients, they are going to be of great help to the patients. Then one more thing is, there are several governmental policies, national policies which have been initiated. All of these things, they will be more cognizant. For example, again, I'm giving from my department, National Program for Control of Blindness. Every national program now, either it is the National Health Commission, or any of these national initiatives, they have the structural entity of the district as the starting point, district as the independent body in terms of giving the treatment, assessing the outcomes of the program, so on and so forth. So there also, the government benefits the postgraduate. Now the postgraduate is called as the district residents. Now these people are benefited, everyone is in a win-win situation. So I feel that the DRP, if implemented properly, is an extremely useful concept.
It can work wonders in the community.
Yes.
Sorry, Dr. Bose, one more thing. The infrastructure also, at least in Andhra Pradesh, I believe that the district hospitals are very well equipped now. So I think that should not be, I mean, I have not visited, but that's what I've heard. It should not be a impediment.
You're right. You're right.
At least for the basic surgeries.
It should not be overlooked.
It should not be a obstacle. That's
obstacle.
No, but this is as a way of generalization, is it not?
Yes,
Generalization
for
of the DRP.
Basic equipment for the entire state.
For the entire,
AP,
not only state,
AP
but
it's good.
The country as a whole.
That I agree.
So in that context, I am talking about.
Okay, sir. Now, thank you, sir. Now moving on to the next. Now my next question is Dr. P.J. Srinivas, sir. The question is, since you represent the government, how can the government, healthcare institutions and communities collaborate to support and enhance the effectiveness of this particular program?
So first of all, I thank the organizers for giving me the opportunity to be a part of this panel. and I feel privileged to sit with my teacher, Dr. Jyoti Padmaja Madam, and my mentor in medical education, Dr. Ravi Venkatachalam sir, and other senior faculty over here. So first thing is, NMC has given objectives. So objectives is the postgraduate should understand the scenario at a rural level, how it works, okay, and how the structure, what is the structure, how it functions, what are the administrative issues. All these things are to be learnt by every postgraduate posted in the hospital. So that is one thing. The second one is, it has given certain guidelines that the state governments has to provide the accommodation, transport if possible. If transport is not available, it should be at least some remuneration should be given, additional remuneration to the postgraduate who's serving there. So these norms have been already given in the Gazette of the NMC regarding how to roll it out. So first thing is, what we have to do is, every district, as Madam told, every hospital which is having 100 beds can be eligible to post the postgraduates. So we need to identify all the hospitals which are having that 100 beds, and we need to see that all the hospitals are having, PG should be having equal opportunity to get into whatever facilities available. But the thing what is happening is, some institutes are having good demand. So at a time, 50 postgraduates are posted in a hospital where they are not having adequate work to do. And what is happening is, once these people go there, the regular doctors are just taking it lightly, and burden is on the postgraduates, and they are doing something else. So actually the idea of the NMC or the government is to see that they have to learn their skills. At the same time, they have to learn the other associated issues like the running of the national programs. For example, blindness control program is there, ophthalmology is concerned, or any other program. And they also develop the skills, how to individually handle a scenario. Okay, in a real-time scenario, because he is only there. As Dr. Chalam sir said, everywhere there may not be the specialists available. So there they can have a video conference or something with the faculty in their respective medical college, discuss about the case, and then they can go ahead about it. Or they need to, if need, they need to refer the case appropriately. So in this scenario, because it's the first time this is being run, so what the government did is, they have posted all of them and seen that it's posted, that's all. They didn't observe how many are really posted, and is equitable distribution there or not. That has not been looked into. One advantage the AP state government is given is, you have the chance to get posted in your parent location or town. So that is something to facilitate, so that they can stay with their parents. At the same time, they have some comfortable accommodation. So at least for the coming years, what I feel as per the NMC guidelines is, the government should identify what are the accommodations available, how many can be accommodated, and depending upon that number only should be posted over there. And as there are clinical people, there are pre and paraclinic departments also posted over there. So depending upon the specialty, they have to be interested in that particular job. So what is happening is, orthopedics postgraduate, or it may be an anatomy postgraduate, they are being posted as general duty doctors. So which is not the purpose of the program. So as per their specialty, for example, microbiology, pathologists, they need to take care of the lab and see that how the reports are going on, ensure the quality of the reports are there. So these things should be updated. And one more thing is, the department specialty has to design what the student has to learn during this 3 months period. Why I am telling this is, in my own department, after 3 months when the PGs came to the department, they are lost the track. They were not even answering the simple things which they are very actively answering earlier. So they are completely lost, and they are just working as a general medical officer they are lost connection with the department. So it can be something like, whenever there are seminars, they can join online like. Okay, and they can also discuss cases with the other faculty in the departments. So like that, they need to establish a connect between the PGs and the thing. So one more norm which is given by NMC is, there should be a district nodal officer, a coordinator who should monitor all these things. So they should be monitoring the activities of all the postgraduates. It is not only the attendance aspect. It is the comfort of the students who are going there, identify if at all any lacunae are there, try to rectify them, and also bring them in front of the government. So with all these things, I think in due course of time this will be useful. And definitely Madam was telling whether it is beneficial to the rural community or is it benefit to the student. It is both way, Madam, what I feel, because once they are posted regularly, definitely the specialty services will be available in that particular hospital. So once it goes into the community, definitely there will be a outpatient inflow into the concerned hospitals. At the same time, the postgraduate will be able to handle the situations. Individually, you should take a decision-making skills will be developed definitely, and also that will be useful. And apart from that, programs related to them or any general administrative aspects of a hospital should be learned by every postgraduate is posted there. So one more aspect, last thing is the logbook. So logbook is also designed for the DRP. So you need to frame the DRP according to what is expected of the student during the 3 months. For example, how many short cases, how many long cases, surgical cases he has dealt with, how many referrals are done, and how many have been treated there. So all these things can be put in the logbook, and that will be definitely useful. And at the end of the 3 months, the postgraduate definitely have some feel that he has done some service to the rural or tribal community posted over there, and at the same time, the documentation will definitely reflect upon what work he has done in all the 3 months. So the departments concerned should frame certain guidelines or the norms what the student is supposed to do, and they also try to follow up the students. So once they are left 3 months, you don't leave the student as they are. So there should be some sort of monitoring, call them, say that whether they are, how they are doing it, and what is happening there, and all these things should be there, so that there will be a connect between the departments and the students working in that. So these are some of the things which are observed, and also feedback from the postgraduates already went. Depending upon that, I had some inputs which I am able to speak all these things. Thank you.
Okay. So very nicely explained, sir. Thank you. So my next question is Dr. Srinivasalu, sir. The question is, how does the program align with the broader goals of India's healthcare system and the National Health Mission?
Good morning, one and all. So because a little bit question paper leakage is there, I could write the answer. I could write the answer in a positive and negative way. So I wrote in...
Srinivas, I was telling him,
sir.
He has the full 20 answers he has.
Yes.
I told we should change like flipped classroom, we'll make a flipped panel discussion.
Yes.
We will ask questions and he will tell the answers.
Yes, yes.
He has better answers than me.
Yes. See, I want to be much more practical. Whatever the situation speaks among from the four my elder speakers, I totally agree with them. But there is 36 months of residency program. Out of 36 months, in the first 1 year, suppose if you post him, or second year you post him, I am practically speaking at least in GEMS. In the first 1 year, we don't want to give them much procedures. And if the person is going to the district residency program somewhere outside, where the specialist is not available, what he will do?
Srinivas, as far as at least the Gazette document says that you should not send them to place there is no specialist. We are not sending. Srikakulam we are not sending.
That's why I told very clearly, I will be much more practical. Whatever is present on the paper may not be seen on the ground.
Srikakulam district, I can guarantee that.
I am speaking pan-India, not only
okay.
Srikakulam district. This is a district residency program given by NMC or national body for pan-India. So do you think if pan-India, so many ophthalmologists are available, they are going to put the DRP students there? No. See, before 10 years, I want to speak the truth, before 10 years, particularly in southern states, all the assemblies, they made a law telling that before internship, after internship, during internship, they should go for rural service and then they will do it. So what happened to it? It is nothing but again the reflection of the same, giving in a different name, isn't it, sir? And you are asking for 36 months training in a particular medical college. where the professor, associate professor, assistant professor, equipment, OT, surgeries, all things are there. Now you are kicking him outside the institute. You go and work there. This is not good, personal I feel. You are allowing him a person to go for a post-graduation, get trained, later you send him. Why the government cannot take an initiative of filling up all the posts in the health sector so that the real people who are in need, they will get served? And apart from this, every time we need some Arogya Suraksha schemes. They will kick the doctors to go and serve there. The district residency programs, all this will happen. As additional medical superintendent of GEMS, I will ask one question. I have 650 patients here. All my doctors are being thrown away because of the pressure to outside. What is happening to my patients in the institute? No answer. Maybe because you want to meet the basic needs of the rural health care, you are pushing the MBBS students, basic PG student there. Okay, I accept up to some extent. But you are burdening us also. Nah? See, in the institute also we have some patients and we want to serve them. It is not happening. So I feel personally, maybe up to some extent 10 to 20% or 30% is okay. But not to pull all the postgraduates or interns, you go out and serve. Yeah. I don't remember the name. Even the interns are also being posted, isn't it, madam? So you're asking the interns to go out, you'll ask the postgraduates to go out, you'll ask all to go out, remaining the institute. What will happen to the patients, our patients?
To fill their gaps, we are having the gap here.
Just for the sake of argument, Dr. Srinivas, your ratio of PG seats have been increased now. So 2 years back, you were managing 650 patients with less PGs. Why can't you manage now with 2/3 PGs? No, just for the sake of argument.
Yeah. For the sake of argument only. The basic increase of PG seats has come to serve the patients. So we got more patients, we want more PGs.
No. They've increased to increase the workforce in the country, not to make your patient care better. That's clear in the document.
Sir, one more thing is the PGs can go on rotation. All the PGs need not be posted at a time. So you can plan accordingly depending upon the workload in a department, and then you can post them on a roster basis. So all of them are not forced to be posted at a time, and NMC did not give a guideline to send all of them at a time. So it is your prerogative to decide how effectively or what will be the workload in the respective departments, and accordingly you can plan and send the PGs in a systematic.
Yeah, because the guidelines.
I agree with this.
Guidelines.
But one point we have to consider. I have the ground reality examples. 1/3 sending, 2/3 sending, all this is on paper, I accept it. A department where 70 to 80 patients are there, with just 2 PGs we have, you are asking 1/3 you go out, what the other one will do, sir? It is a burden for us. So I accept only up to some extent this DRP may be useful, but it is doing more harm to the PG students. They are not getting trained enough. The so-called 36 months, CBME curriculum, all these things will speak. Suddenly politics will come, DRP will come. Thank you.
Perhaps as what you suggested, after the PG is over, maybe you can ask them to go for 3 months to the district.
You recruit the specialists in the
You can, yeah. That way I think you'll be serving all aspects.
So one more thing is, there were different ways and means where they were tried to be posted after completion. But there were a lot of resistance from the students because the period of study is very lengthy. So because of that only, they have made this 3 months as a part of the total 3 years course. Okay, so that is embedded in the 36 months, which is already a part. Yeah. So if it goes beyond that, I don't think they will go to accept it.
See, you have some responsibility towards your duty. There is some fixation of duty, some negligence cases are there. Suppose tomorrow a case complication comes and a negligence case has been fixed against the doctor, the PG doctor. Who will take the responsibility?
No, in the DRP,
Yes.
the specialist doctor who is there.
Sir, specialist doctor also not available, sir. What he will do?
Srinivas, see, the government will make rules. The person implement should implement. Now you can't blame the NMC.
I am not blaming, sir. I am not blaming.
Okay.
I am just telling the ground reality what we should understand.
They can object to it. That is not pushed. I won't go there.
Pardon, sir?
They can object to it that they can't be posted there. That's what I'm saying.
That we are unable to do, isn't it? We
You have
cannot
not tried
output
it, no. You have not tried it.
There is always what is called an idealistic situation. That ideal, see, pharmacology, we have an ideal drug, but in reality, we don't have. So that is, see, what Chalam is talking about is the idealism, where, the NMC has thought processed all of these things and then implemented this part.
So PG student has limitations. He cannot take decisions on his own. That's why there is a specialist over there. Under consent of specialist, will be doing it. As I said, our Dr. Padmaraj garu told, they can consult their faculty and discuss the scenario, and they can go ahead. It's not that they can take undue risk and try to treat the patient. So there will be limitations for it. Still, as you said, they are learners. They will be only doing whatever they can do beyond an MBBS graduate with their experience.
Please do join. In fact, I want to suggest Dr. Bose. No. Dr. Bose, let them join.
Anyone wants to comment or any suggestions, please, they are welcome to do.
1 minute only, huh?
There is a time constraint, so please maintain the decorum.
20 seconds.
Yeah, 20 seconds, counting.
Yeah. So whenever you do a procedure on a patient, you are asking for consent of the patient that I am doing this.
Okay.
You are doing it on a postgraduate.
Okay.
There should be a postgraduate body, right? And their consent should be asked before changing that program. Has it been done?
Sir, please, sir. So we will follow that question up later on. Now moving on to the next question and next panelist. Now this question is for Venkatachalam sir. How does the program address the cultural and linguistic diversity in the rural population?
This question leaked also, I am unable to answer.
Okay. No, since you are the head of the institution, that's why I have kept this question for you.
Okay, anyway, what I'm saying, I don't know if the DRP in isolation can address the cultural linguistics, because, for example, if it again takes Srikakulam, if the student is working here or in a place like Tekkali, there's not much of difference in cultural linguistics compared to Srikakulam and that. But I agree, where you talk of a city like Vizag, then of course there'll be a difference when he goes to Paderu.
Okay.
So definitely there'll be a difference in the socio-cultural and maybe not much linguistic, but socio-cultural. There'll be definitely in the background will be different in cities compared to the DRP thing. So there definitely there'll be
like from district to district difference will be there. Like from Srikakulam district, if we are going to say Vizag
I agree, that's what I'm saying.
East Godavari, West Godavari.
So if you're working in Vizag hospital and posted somewhere else, definitely he'll be exposed to something different, which is actually, which is necessary also. Though he's saying that it should be after PG.
Okay.
During PG, if you're exposed to it, you'll know that the presentation and as you said, the background of this patient is totally different in the tertiary care hospital compared to the village level or at secondary level of district hospital.
Okay.
So I think there's nothing wrong. A PG for 3 months out of 36 months goes and is exposed to the type of presentation, and more important, as you said, the socio-cultural background, because if that person comes here, many of the so-called city doctors don't know that aspect. They're oblivious to it. They talk to them, they're totally ignorant of, they don't bother about their finances or whether their beliefs of, Tuesday, new moon, whatever it is, whatever AdCom you tell us. So that definitely, I think it has a role in exposing them when they go to new place. But Madhavi has something to say. Yeah, Madhavi.
Sir, I want to add one point here.
Please.
Can I complete?
Yeah.
So also, when you're talking about it, the northeastern state, I think there is a small exception that the postgraduates who are from the northeast, maybe Srinivas also wanted to make the same point, I'm not sure. So they are allowed to go back because of the linguistic challenges where you have said the cultural and also the requirement in Northeast is there more. So for that one thing, that's one challenge that is being met in a way. We may not be able to meet their linguistic this thing. That's the
like person like me.
At Geetham we had students from Meghalaya. So she was allowed to go. She was allowed to go, and actually one student from Uttarakhand also she was allowed to go by the AMC principal for this hometown posting.
So regarding the cultural and linguistic factors, so our PGs are posted Aruku, Paderu tribal areas. So that is one area which is unexplored or never seen. The scenarios are not seen by the present postgraduates or whoever it may be. So that will be definitely a good exposure for them to learn how it is there, how the health scenario is there, the health seeking behaviors, all these things definitely can be understood by that. But the problem is the students are reluctant to go to those places. And I think 3 months is not a long term, or they do not feel it's a punishment like. Okay. So they try to understand that they can go as a group and enjoy the area and then go ahead with it.
Yeah. Because all definitely depends on the attitude of the student. Because I will give my example personally. I'm not from Andhra. I'm basically from UP. I did my UG from Maharashtra. And when I joined as a postgraduate in GSL, the first barrier which I faced was the language. So my faculty staff was very cooperative. The first instruction which I got from my head of the department is, as soon as possible, you learn the language. He's a non-Telugu, but he can speak much better Telugu. So that is what the basic idea is. It depends on the attitude of the student. So carrying on. We should motivate that as faculty. Yeah, we have to motivate that as faculty. So carrying on. Second round. Next, because only one questions each. So I had kept 2 questions for each faculty. Now I will go back to Jyoti Padmaja madam. The second question, what are the challenges which are faced? I think you have touched this topic in your previous question, but what are the challenges faced by medical graduates and how can this be addressed, if you can elaborate?
So if we call them for a meeting, challenges are many. They will list out a number of them.
Yeah.
So one thing that was being discussed was the lack of a specialist in that particular area.
Definitely.
It is there sometimes, though it is on paper that they should be posted only to a place where specialist is there. There were some instances where the specialist was not available. But what I have seen was some of the postgraduates, they represented to the AMC principal that specialist was not there. He again changed their posting. So within a week or 2, they were changed to another place nearby where the specialist was available. Okay. So it depends upon both the postgraduate reporting back to the officer who had sent them and the person higher up who is going to help them. So that was also there. So among the postgraduates, I found more complaints from the Department of Radio Diagnosis. So they said that in many of the hospitals where they were posted, in some even ultrasound was not there, and they are losing their training period on CT, MRI, etc.
Because infrastructure was not available.
It is not available. It is not available in the district hospitals.
District hospital.
So those were the people who complained most, and maybe people like respiratory medicine, people where the sophisticated equipment and all is not available in the district hospitals. And then of course they were provided accommodation. There is no transport that is provided, and security also is not there. So these were the things. And then apart from that, what they were saying was in some of the hospitals, some, not all, the doctors who are supposed to work there and be on night duty along with the postgraduates, they are not coming to duty. So they are leaving that on these postgraduates. In some.
Even in hospitals also same thing is happening.
Tertiary hospital, you call somebody, they will come, or maybe somebody is there in another ward or something. There it is not like that. They will not respond. So that they had a little fear of that. And some of them were actually saying that in specialties like surgery or gynec particularly, OBG, those who went from private colleges, they can do a lot of normal deliveries and all, which they are not able to do in their own hospital. And coming to the academics, there are big problems maybe. See, all the postgraduates have their own PG teaching schedule, which happens in the afternoon or whenever their clinical work is over. Now these people are at a loss. So some colleges are insisting that they be given the online link or something and they should follow. They may not be able to connect. Truly, that is one thing. And they may say that they are not able to connect. That is another thing. So both those things are happening, and as a result of that, They are losing on all these things. In that way, 3 months is a big period, I feel. It's not small. And they are also supposed to do their dissertation work, so it is hampering. Maybe they have started collecting the data or something, and then there is a stop in between. So that also is another problem they were saying. So all these things are there, and maybe not in AP, but there are some states where if the place of work is very near to the parent hospital, the parent hospital is asking them to come and work here partially and then go to that place of DRP, which is unfair. And they cannot protest because they have to go back to their parent institute ultimately and face the examination. That also is there. So in a way they are suffering a little. I don't say that it is very pleasant and enjoyable. It's not like that. There are difficulties, but maybe as Dr. Srinivas said, it is in the very initial nascent stages, and maybe as it evolves, it must become strong. Otherwise, it will be difficult. So these are all some of the problems that the postgraduates have represented.
Thank you, ma'am. Moving on to the next question. The question is for Dr. Padmaraju, sir. You spoke about the effect it is having as an ophthalmologist for the services. Now, I would like to know your views how the program addresses the healthcare needs of specific specialty apart from your specialty, like surgery, pediatrics, obs, gynae. Any point of views you have, you can share.
Yeah, slightly at a disadvantage because I'm an ophthalmologist. But I think I'll say a few words about the National Health Mission. This is the conglomerate of the national rural and the national urban missions. And the vision of the government is to provide to either the pediatric group or the obstetric group, women, or the vulnerable groups in the society, an equitable, a sustainable, a very affordable and quality health services to all. I think that is the main objective of the health mission. Now, if suppose this or these objectives are to be realized by the government, I don't think at this point of time they have the necessary number of trained people. So I think that is one of the reasons why this DRP has been started. So the people who are posted there, being now called as district residents, they will see the aim is to reduce the infant mortality rate, maternal mortality rate, all of these things. So I think
meet the goals set by the NHM and RH.
So it is to something like a stopgap arrangement by the government to at least partially fulfill the need of the hour. That's probably I can offer. The second thing will be, it is only about the pediatrics and the OBG, is it not?
Surgery, pediatrics means all broad specialties in general.
So the brief stint, I think I was the medical superintendent for a little bit of time. 3 weeks back only I've been relieved. What I have noticed in the casualty is we have a number of admissions which are in the critical state. Now, if suppose in the surgical, particularly the pain abdomen or that is something like a unknown entity, this abdomen, it's anyone's guess, whatever it is. If suppose these people had been recognized earlier in the district hospital or from the place where they are originating, maybe all these lives would have been saved.
Definitely.
So that is this thing which I always felt. Okay. Apart from these few sentences, I don't think I will be able to comment. The other things will be, they are participating in the national programs, either the communicable diseases or the NPCB as what I was talking about, then the hearing laws. So many national programs are there. Now these people can acquaint themselves with whatever is happening by way of planning the execution and then assessing the outcomes. So they themselves can be a little proactive and try to involve themselves in all the activities.
Okay.
Sir,
So I think.
I
that company.
Yeah, please.
Madam is
Difficulty, I forgot they expressed. So we had what was called a peripheral posting. They could go out for their specialty posting to other institutes previously. So now some of the institutes, they are holding back the postgraduates, saying that they can't go for 3 months DRP and again for 1 or 2 months or 3 months to another institute. So they are saying that they are losing out on that, which is a fact.
Yeah, please.
But that's again a mistake of the principal there.
Because I'm facing that. Now, when it comes to DRP, who is the beneficiary? A PG student is a learner and a service provider. So is he a beneficiary in the DRP?
Yes.
Right.
Definitely.
Okay. So then why people are rejecting that? Why the people say no? Why all the PGs just clapped now? If they're being benefited,
Sir, that's what I pointed out, sir.
They should be able to agree to what did the DRP. Okay. Now, I give an example. You know, like when I was young, my mother used to take me to my village. I resisted being used to an urban life. She used to tell, no, you have to come with me, learn what is a rural background, what your grandfather is, what your land is, what electricity failure is. So in that 1-2 months of vacation, I learnt what probably I didn't see in books or never experienced. All right. Now, was it a learning experience from me? I say yes. All right. So now what happens is, like Madam said, in the 3 years, first 6 months goes to submission of dissertation title. Last 6 months go to submission of dissertation. They're left with 2 years. In the 2 years, we have a rotation of super specialty, which is 3 to 6 months. As Madam said, they're losing that period. Right? Second thing is we have a unit rotation. I relieve my PG from my unit. When he comes back, he's no more in my unit. He may change the year and may change the guide. So this 3 months is disturbing for me. So as Sir said, Sir Srinivas Garu, not only institute, as the head of the Department of Surgery, I face real difficulties. But then when I get a feedback from Ramani Madam, she is happy. Without a postgraduate, she was finding difficulty. Now she's able to resume her academics. She's able to train PGs, PGs benefited. But one PG goes to her, other 2 PGs goes to a place where they are probably wasting time, I would say. No infrastructure, no patient work, no accommodation, no transport. So those 2 are the ones who come and complain to me, Sir, yedo cheyandi.
Patients are there.
Well, not to their satisfaction. Yeah.
You can go to your grandmother's place for your satisfaction. They also realize like
So what I mean is that there's so many loopholes, you know, like there's so many logistics problems here that probably it will take time
patients
to
may be
accept.
there, but they may not belong to their specialty, sir. Patients may be there, not belonging to their specialty.
Yeah, they have to. So once they go there, they're basic doctors. In community health centers, once they go there, they're basic doctors.
Yes, basic doctors
They're
who
basic
has
doctors.
to perform even autopsy also.
Yeah.
I know that, sir.
So what happens is, are they being benefited? Some of them is the issue, sir.
Yeah. Okay, so moving on to the next question. It's for Dr. P.J. Srinivasa. What measures are in place to ensure the quality of medical education and training in district hospitals? Since everybody is saying that they are wasting. So what measures, if it is not now, in future, what can you suggest or what can you think that it can happen?
So actually, I answered earlier regarding that. So that the concerned department has to plan an activity, what the student is supposed to do there, and accordingly they can also supervise on and off. Okay, how they are running, whether they are really facing the problem or not, and also, as I said, the connector to the department at online if possible. The signal is not there, we can't help it, but still the academic activities can be, they even in contact with that, and also any critical cases, what can be, there can be a discussion regarding that, and also they can present a case like that, and they can go for further discussion. So it's only the thing, we need to do a homework for it, because at initial stages, it's only just posting has occurred. So what to be done next, we need to plan appropriately, and they can be, that can be definitely useful. One more thing is, every hospital should have some limitation. For example, some hospital may have a good facilities, but at the same time, you cannot post 100 PGs over there.
Yeah.
Okay, that there the manpower really wasted. So accordingly, there should be some limit. For each hospital, there should be so much a number, and accordingly, they should be posted, not beyond that. Okay. And one more thing, other side I'm telling is, some hospitals have unnecessary demand due to which they are being posted and they're misutilizing. I'm sorry to say
Definitely.
this. Okay. So they just going the first day and going the last day and coming out. Not in our district, but in other districts. I have information.
Yeah.
So definitely there should be a district level monitoring to it, so that this will be strengthened in due course of time. I don't say that today it may be a waste, but definitely it will be useful. I will say one more thing in the last. One postgraduate posted in one department, I don't want to mention the department also. Because of workload in the department, they said that faculty are ragging him. They complained to the principal. So what do you say about that? Students really want to learn. So this is some things which they need to balance and plan accordingly. So they can share with the concerned faculty, and if they're really stressed out, definitely that work need to be shared with the others also. So that planning should be there. It's not a sort of a complaint or trying to overburden a student is also not a right way of doing it. That's it. Medical college. And I'm telling about the workforce, work culture. So if you are exposed to so many cases, definitely you will have a lot of experience. That's what PG feels, as you said. But it's the other side. That I want to mention.
Okay, so moving on to the next question is for Dr. P. Srinivasalu, sir. What lessons can be learned from international models of similar program that have been already into existence and some are running very successfully?
So before learning the lesson, I will tell some information from other countries. In India, ASHA workers are there. And in China, community health workers are going. Whereas in Thailand, health volunteers are going for this purpose. Whereas in Brazil, multidisciplinary teams are going. So if you see the three other countries, it is not the doctor or the postgraduate who is going for the field work to do that. So what the mistake done by the postgraduates, leaving the specialist programs and then going to a place where the specialist is not available?
Sir, I defer this, sir. This is a secondary level care centers. Okay. So they will be coming from a primary center which are cases referred, they will be coming over here. So definitely there will be, I don't say that all specialties will be there. At least the routine required specialties will be definitely be there, and definitely it will be a place to learn. The health worker or ASHA worker is a simple paramedical worker who just collects the data or gets some basic information. You can't compare a health worker with a postgraduate training student. Okay, he's already 1.5 years already trained in the concerned department. Definitely is more equipped than an ASHA worker or a health worker.
Yes, I think I agree with PJ. See, Srinivas Garu.
Yes, sir.
District hospital caters to secondary level treatment.
Last question.
So ours is a tertiary care because we belong to the medical college. So as far as secondary care centers, I think what you have said is perhaps not relevant. If it's at the PHC, I can understand.
Well, I agree with you. At the same time, I disagree with you also, sir. 50-50%. Okay. Then what lesson I want to learn from this DRP is better we reduce the time limit to a duration of 1 month, where a specialist is available at least. అక్కడ ఉన్న చోట ఒక 1 month వేసి వానికి కావాల్సింది ఏదో చేయించుకుంటే కొంచెం పర్వాలేదు. అలా కాకుండా ఒక స్పెషలిస్ట్ లేని దగ్గరికి వేరే పని చేయవలసిన దగ్గరికి మన వాళ్ళని పంపించి వాళ్ళ పీరియడ్ని పాడు చేయడం, I feel it is miserable for the postgraduate student. Thank you.
Pause for skipping my last question. Thank you very much.
Okay, sir. So due to time constraints,
and I didn't know the answer. That's the reason. The audience will answer.
Okay. I will open the question to.
What suggestion you have to the government for the program?
Yes, sir.
Okay.
Sir.
I'll open the question.
Okay.
What suggestion you have to the government? Only 30 seconds.
No, sir, not like that. Not for that, sir. I'm the other side of the table. I'm receiving the DRP PGs to the GGH Vijayanagaram. Since it is a nascent college, they thought, since no students have yet come, they thought it is fit to send postgraduate students. We had many students as far as Vijayawada, Pinnamaneni, Siddhartha. They were all very satisfied. Because there's a lot of workload is there, they're very busily operating all the while. Till 4 o'clock in the afternoon, they're operating. But as you said, the academics are missing. They're not coming for classes. Even if I push them to present cases, maybe once in a week it's happening so. So this we have to check. So my suggestion is, at the end of this 3 months that he's posted, he should be able to present a paper or publish a paper, do a project on whatever the cases that are available in more number. Thank you, sir.
Sir, for interns actually.
Sir, only 30 seconds for you.
Okay. First thing is, there are 3 steps, because sir has asked some recommendations. My first recommendation is, ఇష్టం లేని పెళ్లి చేసుకున్నట్టుంది. వాళ్ళకి ఇష్టం లేదు వెళ్ళటం. వాళ్ళకి ఇష్టం ఎప్పుడు వస్తుంది? when they will get interest after post graduation. Why can't you utilize their services after they have finished their examination, as he has suggested? Not only 3 months.
Sir, for this I have an answer.
No, 1 minute please, you will get a chance. Okay, next thing is, you have to sensitize them before we are sending. Number 2 is, there will be some monitoring, as Srinivas has said.
I have an answer for this, sir.
That there should be some monitoring from at the district level, and second monitoring is from the parent department. A facility must be created that a professor must be going to there at least once in a month, 3 months, once in a month if they are going, at least that will be good. తర్వాత ఇంటర్నెట్ కనెక్షన్ మస్ట్ బి ప్రొవైడెడ్, because for attending the clinics. So this another thing is, as and when people are going and inspecting, the deficiencies will be known and will be rectified. Otherwise, it is just like a struggle. So if they have these what madam has told, all these things are rectified if they are posted after MBBS examination. Don't give degree. After the 3 months or 6 months, whatever the government is saying, the government is very clever. They don't want to give stipend at that time. That is another constraint. So government has got their own weaknesses, but for them to work with good interest and dedication, you must see their motive also. Okay, that is.
He covered the answer also, sir. Thank you. Because government literally failed to incentivize the people who are going for rural place. So there should be some incentive so that they will voluntarily go there and work there.
Accepted.
As post-PG, during post-PG when they introduced compulsory rural service, they didn't pay them for 8 months. So nobody will be willing to join such rural service without being paid.
Accepted.
That is
Thank you.
So,
Thank you. A big round of applause to all the panelists and the moderator for conducting a very interactive session. May I now request Dr. Devi Madhavi Madam to please give away the mementos to the panelists and to the moderator, please.
Dr. Bose can give the concluding remarks, because we might have missed out some answers. Please tell the correct answers.
My last question was about recommendations only. So I think both Ramarao sir and Venkachalam sir has covered that. So I don't need anything. I need my comments to be here. So thank you very much for your patient hearing. And I thank everyone, every panelist and my management to giving me this opportunity. Thank you very much.
Thank you, Dr. Bose.
The last but not the least topic, a very, very important topic for all of us, because we have seen the research going on at very high speed and lot of research going on all around. Let's hear what Dr. Swati Purnima ma'am has to say about research and publications in medical education. I now call upon Dr. Jairam sir, Professor of Physiology from NIMRA, Professor and Head of Physiology from NIMRA, and Dr. Satyajit Patnaik sir, Professor of Community Medicine, to chair the session.
So very good evening to one and all. I'm fortunate and honored to introduce you Dr. Swati Purnima madam. She did her primary and secondary education at St. John's Girls Grammar School, Hyderabad, and then MBBS at Siddhartha Medical College, Vijayawada. Later, she has pursued MD Anatomy at Tasmania Medical College, Hyderabad. She also did advanced course in medical education at St. John's Medical College, Bangalore, and presently working as a professor and head of the Department of Anatomy at Dr. Pennamaneni Siddhartha Institute of Medical Sciences, Vijayawada. She is also holding the post of coordinator for medical education unit, and also the coordinator for Students Affairs Council, and also the coordinator of mentorship program. She is also a coordinator for body donation program. She was also an instructor for American Heart Association courses and international trauma life support. She is also an instructor for BCLS and CCLS courses of Indian Resuscitation Council. She is also a life member in national and international anatomical societies. And there's quite a big list. I wish madam, please continue madam, Dr. Swati.
Thank you, sir. Thank you for the sweet introduction of myself. So, good afternoon, dear students. Louder, please. Yeah, that usually motivates all the first year students. So, being an anatomist, it is always students, further students, by the students, okay? Students' democracy. So, coming to the topic today, which I am going to deal. Good afternoon to all the learned persons present here. So, I would like to make it a short presentation on research in medical education. So, let us first define what is research. I want everybody to concentrate on the highlighted, red highlighted words here. Please don't go to definitions. I myself don't understand definitions properly. So, what do you understand here? New knowledge which has to be systematically placed and create or generate new concepts, methodologies and understandings. Just have these 3 points, that's all. What is that we are potentiating here? New knowledge which has to generate new concepts, methodologies and understanding. This is research in part in any field. It is not just medical education, it is research. Everywhere what we are trying to do, we are trying to generate new knowledge. But when you are applying research in medical education, so that the population, to tell you in a very sweet way, the bakras or the scapegoats are you people in medical education. Okay, so what are we doing in medical education? Here we are creating something called a big aim. Okay, so we are all Bahubalis, we are acting on small, what do you say in sweet Telugu? Pichakameda Brahmastan laga, everything we are applying on you. So what are we doing here? We are aiming to advance the knowledge, skills, professionalism of medical students. I will just add another word, medical professionals, by understanding and evaluating educational ecosystems. So I want here any student in the first year, can you tell me what you have defined ecosystem in your biology? Under the hope so you all are from Sri Chaitanya and Narayana and have buttified what is ecosystem. We'll make the session interactive. I'll feel happy if you are interactive. What is ecosystem? You all are 23 batch, right? What is ecosystem? What is your ecosystem right now? AC theater with AC around, lights here, you're in a comfortable position, right? So even for the teachers, we have something called an ecosystem where we deal with something called as curriculum, the timetables, the design of curriculum, the planning of schedules, yes, the assessment processes, teaching, learning, okay? We were never used to all these words, teaching and learning. Now everything is learning, less of teaching. So what we are aiming in medical education is to increase that knowledge in which is being applied to you scapegoats or the bakras. Okay? So ultimately what is research in medical education doing? It is addressing contemporary issues. What are contemporary issues? I felt very bad yesterday in the banquet when all your seniors were dancing for all the old songs. Nobody is interested in latest modern issues. You have something on your internet, no? Lingidi Lingidi, which is very nowadays famous with the Srikakulam accent, and your Teja sir was not at all promoting that. Okay? So not the age-old ones. We want something contemporary, the modern issues and questions in medical education to be answered. We need to answer the design, evaluate and support curricular innovations, assess and reform the cultural underlying the medical education. Okay, so where this research started in medical education. So you can see a pretty girl being dealt by a pretty old man. Okay, pretty good old man. So it started way back in Western countries. You are all impressed by the wild, wild West. Yes or no? You are not impressed by the active, very active and energetic East. Okay, so in 1950s, clubbing up the social sciences like the psychology, the sociology part into the medical field. Okay, the Western world has come up with something called research into medical. They have included all the humanities, like morning we have seen Manaswini madam has introduced something called humanities, the sociology part of it, the physiology part of, philosophy part of it. All these were incorporated into medical sciences. So in these information and the literature was more from the Western side through US. But what we can see is we can't generalize all those findings of the Western. Take around the Europe and US literature does not fit exactly into what is a context in the Indian scenario, right? I don't think so. Whatever is in the developed country is being dumped onto the developing countries. Do you think the scenario fits in there? So we definitely always have a disproportionate evidence of literature. Okay, since morning most of our speakers have told you something related to Flexner's report. Okay, I think this is also important for the undergraduates to also know. Abraham Flexner was one of the person, a pioneer person who had done major modifications in medical education. What he has done, I just want to put up two words here. He has made a tour in 155 medical colleges in US and Canada. And he found out the loopholes which were not actually promoting. So what is that he has already done? He has done a small part of research there. But he never wanted to publish it. So happy for him. He only thought, just think in your mind, but publish something little. But what have we done? After he has done that research on 155 medical schools, he identified that there were many loopholes. What was the major first loophole? Once he has seen that who are the missed out or failures from the medical colleges, he has seen that there was a decrease in number of African American graduates, there was a decrease in female graduates, okay. Not only that, 50% of the medical schools were closed after he has provided this report. That is, the basic need of a graduate, medical graduate, was not being satisfied in this 155 medical school. Just imagine, 50% is almost 75 of the colleges have been closed after he has submitted his report. Okay, so what is the need of the hour? You need to globalize research in medical education. Never ever see that. See, for example, I just want to tell you, USMLE. Earlier in the morning, somebody was speaking about the licensing exams, the WFME accreditation, everything. So, till date, what to my understanding is, NMC was not accredited under World Federation of Medical Education. Recently, it has got accredited, but most of the students felt that we need not write any licensing exams for the foreign countries. No, you have to write. You have to write the foreign examination. NMC has just been recognized. Ani world has recognized that. So now we are in par with global standards. Okay, so we are in par and we have the eligibility to attend or to write the exams, licensing exams, and then go and practice there. So even research in medical education need to be globalized. MEDED, pardon here, wherever I am writing medical education, I have put it up as MEDED. So MEDED research in India is in a nascent stage. Like the baby steps, from morning we were still going on. Yes, I felt this photograph was very apt. Okay, so we are in a nascent stage. Yes, you can see with the number of people attending the conferences related to medical education. What I feel is there need to be more sensitization programs, need to be more motivational programs, need to be more incentivizing programs where they will promote the medical educators. There are somewhere in our heart, though we are all medical professionals, I also appeal all the juniors here, the students here, please in future once you finish your graduation and post graduations, first become members of APMEA please. Okay, that is one point, and please be active in medical education. Next, what is research we have seen? Why? Why do you need to research something? I said who is the scapegoats or the bakras here? The population? Very nice. One of the guys is saying me. Okay. So why are we doing that? Okay. I'll just read up these lines. I felt they were very good. Provision of trustworthy information on medical education problems and their solutions. Okay. Again, who is in this ecosystem? Yes, we teachers, we medical professionals, the stakeholders, you, the students, definitely the parents of all these students, the administration, the admins. Yes, all these are the people where we need to provide a trustworthy information. Next, maintain quality of medical education. Why do we need research? Okay, you need to do research. You have started some program or you are doing some evaluation. You need to provide that information to the general public, right? Whether that worked or not. Next, demonstration of specific ways in which teachers can help students feel a sense of belonging and gain in learning, understanding science of learning, identifying facts, building new knowledge. That was what research is. Then extension of existing knowledge, suggestions to solutions, inventions and innovations, assessing the effect of new methodologies, exploring evaluation of techniques. If all of you have followed the sessions from morning, Dr. Raju have given a good idea, an innovative idea of using trump cards, right? All these are newer ways of innovations in teaching. So we medical educationists, along being professionals and along being medical education teachers, we also want to innovate something new so that the subject, you all know that since yesterday we are seeing the amount of medical knowledge has increased thrice, has increased 75%, has increased 80% thanks to Wikipedia and Google. Everything you are getting on cell. But are you not feeling that it is information overload? So it is always the duty of we teachers or we medical professionals to make that information to be served in a platter where you can easily assimilate it. Next, so this is a bit of a theory. Van der Lewent is one of the pioneers in medical education. What he has done, he has created too many theories which will go above our head. But what I understood from this is research plays an important role in development of education also. So as both of them are directly proportional to each other, okay? So you might have come across this term, directly proportional. One is equaling to the other. So as much as educational research you do, more of educational development. Okay, and there is another expertise model. Don't get overhead or don't get confused by the models here. Always we teachers start here with teaching, right? We are at this stage when we join as teachers or when we join as medical professionals. What do we do then? We develop our education. Yeah, let it be clinical practice, teaching, UG or postgraduate. What is the next step we do? We start coordinating our education, both UG, PG, then after continuous medical education, then manage and implement that education, whatever we are doing, then teaching about education. That is what we are doing now. We teachers are doing now. We are teaching our own teachers, we are teaching our peers and colleagues. So we are going in a step ladder fashion. Ultimately, what is that we are doing? Researching on education. Where are we researching? Again, from the base level, from teaching up till the higher level. Okay, how to conduct the research in medical education. Okay, these are the list of topics. We find this anywhere on Google, and these are some of the list of topics which the Association of American Medical Colleges have put up. So what we need to do is try to identify the topic on which you are about to or going to do a research, which usually interests you, which you feel that the topic is innovative. We'll go to what are all the important logic points there, which will lead you to answer. So few of the topics, sorry for the blurred vision, I have just copied up the slide. So most important, some of the few red dotted topics I'll just put up. Student assessment and evaluation is one of the important topic which is of great importance nowadays. We have too much of discussions there. Then clinical skills training, clinical clerkships, which our Chalam sir was speaking earlier today. Then problem-based learning, community-based training, clinical competence assessments, teaching and clinical sciences. These are some of the topics which we can ponder upon and start doing research. Okay, so I have just simplified few steps. I have simplified them into 10 steps where you can proceed for a research in medical education. So first step is always clearly define a research question. What is that? You have identified a topic. Okay, so you have already identified a topic, for example, on assessment or evaluation. Your exams, your scorings, your marks, and we are trying to evaluate and we have to produce those marks, or we have to see how your performance is, academic performance is. So we are starting up with what is going to work, where we are going to work in this assessment. Assessment is a broader topic. We are narrowing it down to something called as a research question. So what in assessment I am going to do? The next point is bounce your ideas off your colleagues and mentors. Don't sit idly on a full moon day and think of a topic and then think of a research question. Please discuss among yourself. You will have more ideas from a person sitting just behind you or beside you. Nobody is above us. Okay? So discuss your research question and your research topics with your peers. Next, consult the literature. What is literature? Not the poetries and the prose, please. You have something called as medical literature. Okay, once you have thought that you are doing a topic on assessment, you are trying to research something on assessment, please take up the topics on assessment, identify articles, research original articles, start reading those articles. What will happen if you start reading the research? When you are reading too much of it, you like some actor, right? What are you going to do regarding that actor? Nowadays you all are followers of Naveen Polishetty, no? Yes, no? So what you people are doing? Girls, forget about boys, they'll be looking after Anushka. What will girls do? We go to Wikipedia, we see what date he was born, is he married or not, how many brothers and sisters he has, what is his fan page, yes or no? That is searching literature, right? What is that you are going to do after searching literature? You will be waiting for his next movie, right? What is that waiting for the next movie is? Define approaches and methods. Once you have identified the literature, found out what were all the articles related to your topic and your research question, now what are you are going to do? You have to identify how you are going to cook up your study now. Next is solidify your research design. This comes under methods again. There should always be a proper appropriate research design for your methods. Then identify measures and instruments. So you have identified a question. For example, what is the use of? I'll take example of the trump cards today morning. I felt I will use that in my study. Sir, if you allow me. So what was the effect of use of trump cards in anatomy? For example, my subject in anatomy on the academic performance or on a simple slip test of a student in a particular period. Okay, so I want to see the effect of one intervention, that is, let it be trump cards or any other way of adding humor into a class or adding up another teaching learning method into a class, and I want to see the effect, the outcome of it in your performance. Okay, so this will be my research question, and I will check out how my study designs will be after going through different parts of literature there. So now I will collect the data and then analyze the data. After collecting and analyzing data, now I make the sense of my data. Now I need to write it. The most important part is, now I know what is my question is, I know what the methods I have to do. I will collect my data, but now I have to put this whole data in a simplified form where I can present to or I can publish it into. Okay, so now I have to write what I have understood from my research question. I have to answer that, and then I need to write my story here. Then right place to search for, right place to publish, and then write a simple first draft of it. Don't keep it in Almara again. Please show it to your peers first. Have proper review through your peers, and then you can go it for publishing. Okay, so this is a simple method of study designs, which was in a complex way. There is something called Association of Medical Educators of Europe. They usually release issues, AME guides, AME guides. So they have multiple guides. One of the guide number 56, which has beautifully portrayed different types of research methods and research designs. I have picked up this part from there. What they have included in that article is something called as research compass. It is very easy to understand, and if you simplify it, is more easy, and you can apply it in your medical education research also. So what does this compass include? It has divided the research into 4 studies. So the methods are observational studies, translational studies, explorative studies, and experimental studies. I just want to emphasize on this figure again. What are these observational studies doing? What are they? I'll just let you know. What are these observational studies doing? They're predicting something. You are observing something. Your notion is different from my notion, and my notion is different from somebody else sitting in the audience. Okay? So you're just predicting it. Okay? When I put my 2 fingers crossed, some of you might take it negative, some of you might take it positive, some might not bother at all. So what is that? You are predicting in your own way. So this is a simple example. Next is experimental. You all know that. I already told you all are experimental candidates in medical education, right? What is that we are doing in experiment? I am justifying. Suppose I am using this trump cards method and I see that your performance is better. I am justifying my question, right? So this is experimental. Then coming to explorative. The term itself dictates what is explorative. You are exploring some newer things from the data. So what is that you are doing here? You are modeling effect. What does this modeling effect do? You are creating a mold and modeling it according to your understanding and your notions, right? Last but not the least, the latest and most advanced and the trending type of studies are the translational studies. Okay, these are implementing type of studies. We'll just go to each one of it. So exploring, I have made them very simple. Explorative studies are again divided as descriptive, qualitative, and psychometric for the ease of understanding. Descriptive, very simple. Any phenomena, your learning, our teaching, your assessment, our way of understanding, our way of evaluation, everything is described. The simplest method is you are describing what the phenomena has done to the student. Coming to qualitative, this is again a trending one now. Qualitative research and qualitative studies are the trending ones nowadays. What do you do here? For people like me who doesn't know what is 2 plus 2, if you ask me in a fit of the moment, is very happy to do such research. Why? You need not have any statistics in it. So everything is through language. Next is psychometric analysis. What do you do here? You measure the psychology of the student. Psychometric, anyone? Yes, you use certain instruments, okay? You use certain instruments and you see whether the academic performance of a student Okay, the survey, the inputs of a student, all these will come under psychometric analysis. Okay, so I have already said, please keep in your mind that you are as of now the population for all these studies. Okay, so we have already said that explorative studies would be doing something called modeling. They are actually precursors. What do you say? What do you mean by precursors? They are the ones which will give us few more research questions to experiment on them. Okay, and observe on them. So always these are explorative. You are identifying some phenomena, okay, modeling that phenomena in your own sense and creating few more and new more questions there. So 3 types of explorative are descriptive, qualitative and psychometric. So descriptive, these are the simplest form. So I have already said you are describing the phenomena, any initiatives, activities. But see the red mark here, do not qualify much for research publications. What are you doing here? Dr. Swati is presenting a presentation on research and all the undergraduates were sleeping. What type of study is this? Descriptive. Do you think something has come out of it? No, you all never told that it was either boring, not at all appealing, nothing like that. I didn't take any inputs from you. Okay, I was just described. So most of the descriptive studies do not qualify in that way. They just describe the phenomena. Okay, so research questions that relates to conceptual theory. You won't go into much of that framework. So how can we improvise descriptive studies? How do theories of learning and teaching inform the observation of phenomena? That is what I have said. I have just described that you people were sleeping, but I never asked you what were your inputs on my talk or on my presentation. So if I am including that, what was the effect of teaching or what was the effect of a presentation post lunch or after a post discussion where the students were almost sleeping? I need to apply a survey to you, then ask you whether you have understood the topic or whether you have took up the concepts or not. Okay, so a descriptive can be made into a good analytical study. Next, qualitative, we have already asked. This is why, how and what of a study. So there is a theory which is called constructivist paradigm. Okay, this is a part where you need to understand the language, and when you say why, how and what, you are going into a community or you are going into the sample or the population and identifying the phenomena. Identifying the phenomena was in the descriptive. What are you doing here? Here the person or the sample themselves are describing the phenomena. For example, a patient, okay, who has undergone a surgery. He has some feelings, yes or no? He has some feelings towards surgery, how he took up that surgery, what was his feeling towards that surgery. When you go and ask him, then only he is going to tell you, okay? Such type of studies are included under qualitative. Here the individual is approached and his data is collected in the form of interviews or focus groups or in form of case studies. Here you ask open-ended questions. So what was your feeling after a surgery? I collect all those information in the form of language, code that language and then publish it. Next is psychometric measures. These are instruments where you use. The important thing is how do you develop. For example, a questionnaire is one of the psychometric. So we provide you. After a talk, I give you the questionnaire and I ask you to rate me. Okay, these are like the rating scales. Okay, you might have seen after you buy a fridge, washing machine, everything. They will ask you, Madam, our service we are calling from Ding Dong Ding. Hope you are fine that our service was good. Fine. This is all what is called as psychometric analysis sort of thing. So what is most important here is the validity and reliability. Innarama, anyone? What is validity and reliability? Anyone? If you are listening to me, understanding to me, you will reproduce at least 3 terms at the end of the session. Okay, so how valid is this thing? See, valid, the example valid, forget about it. Whatever, here we are asking it as instrument, right? So if the instrument measures what you are intended to measure, that instrument is valid. And in any condition, it is measuring the similar values, you call it as reliability. Okay? For example, small, on a lighter note, identifying your future partner, not in the first year please, after your post-graduation. So you have certain valid points. He should be fair, he should be tall, so and so. So do you tick when he comes to your pelli chupulu? No, you don't do it. But you go for pelli chupulu quite a lot of time. and you find only one. Okay, the one you found out was valid, and all the pelli kodukus who came for pelli chupulu are what? Reliable. Okay. Next, coming to experimental studies, any new interventions, for example, again the trump cards and the our sir yesterday, our Ravikiran sir also have put up something like the skit models in potentiating your understanding and learning of this subject. Any intervention for the medical education in the medical teaching process are experimental studies. These are the gold standard trials. You have come across the COVID vaccine, yes or no? Okay. Do you think all the trials were done? No, we were used like scapegoats and we were being shot on by the COVID vaccine after 1 and 2. Do you know? I am misleading you people. All trials were done for Covaxin and what was the other vaccine? Covishield. Were all the trials done? Yes, very fine. Then good. I don't think so all trials were done. Yes. Of course they were done. See, madam has told very boldly. You people were again in doubt. See how does the social media spoil us? Covaxin pan cheyaledu. Ante you will follow all those things. People will. Okay, so don't follow. That is why what you need to do is literature search. Look into the literature first. Okay, so experimental studies include something called as randomized controlled trials, RCTs and NCTs anu untayama. These are the regular gold standard experiments which are done, or gold standard designs done. Something related called as PICOT, where S includes setting, P is population. All this should suffice, or all these are the criteria to conduct such controlled trial. So you should have a proper setting, proper population, proper investigation, proper controlling group. Yes, proper outcomes and proper time framework. So there are guidelines for each and every study design. Okay, last but not the least, the observational studies. In the observational studies, you have something called cohort and cross-sectional studies. These can also be applied in medical schools, like the same thing. A group of students have been introduced with one method of teaching and the group were not, and vice versa has been done. Okay, these are sort of studies where you have a control group, the one who are exposed to it and the one who are not exposed to it. Then associational studies. What are association studies? Whether adding humor to a class of anatomy, or whether adding few of the MCQs, or whether adding a role play, whether adding skit improvises your academic performance. So you have to see the association between these two. So such studies are under the observational type, which predict are they working or not. Okay, the most important now, the gold standard, not to say gold standard, the trending one is translational research. Small tag here, hashtag to it is bench to bedside. What is the bench for you people in the first year? What is the bench for you people in first year? Classroom bench? Very sad. Who is your first teacher? Cadaver probably. Okay. So for us, from the cadaver table to your patient bedside. Okay. So bench to bedside. What is being done here? Just follow the steps. I'll read out. Basic science discoveries are applied or implied into patient-oriented studies. So both basic sciences, the anatomy, physio, biochemistry, pharmacology, pathology, forensic is added and clubbed with the clinical sciences. Okay. Next, synthesizing knowledge from the clinical studies and producing clinical guidelines. So first you are correlating the basic sciences and the clinical sciences. Then what is that you are doing? You are then creating or producing guidelines. Implementing these guidelines into your future practices. What is bench to bedside? Okay. So what is the role of medical education here? What is our role in this? What are we doing? We now want to include this translational research formally into UG and PG curriculum. Okay. So this will cause something called as integration, a vertical integration in student, so that the student is in par with the clinical subjects. Then strategies for development and implementation. Then classroom. Okay. Okay, sir. Okay, no problem, no problem.
For paucity of time and because ma'am has to go, there are trains to catch. So I would like to announce the medal prizes, and I would like to request our principal ma'am, Dr. Ambedkar sir, Dr. Ravi Venkatachalam sir and Dr. Devi Madhvi madam to please come out to the stage to give away the medals. ఒకటే సార్, మీరు స్పాన్సర్ చేసింది మేడం స్పాన్సర్ చేసి. Yes sir. Ma'am, please come up, ma'am. Paper and poster rendu. First press. Shri C.S. Murthy Memorial Best Faculty Research Paper medal goes to Dr. Lavanya K.M., Professor of Community Medicine, JSL Medical College. This medal is sponsored by Dr. Ravi Venkatachalam sir. Dr. B. Naganna Memorial Medal for Best Faculty Research Poster goes to Dr. Lavanya K.M. This medal is sponsored by Dr. Devi Madhvi madam.
This is in the name of my grandfather, who was a biochemistry professor, the founder professor of Andhra University also, and he was working at Madras Medical College and at AIMS also.
Thank you, ma'am. Thank you. Congratulations, ma'am.
అయ్యో పర్వాలేదు.
Thank the organizing committee for giving me this opportunity. I thank the organizing committee for giving me this opportunity to present my poster as well as my paper, to participate in the sessions and wonderful sessions. This is my feedback. Thank you so much. It was really, I really had a great time. Everybody, I'm thanking.
Yes, sir. Teja, sir. Then I'll
Thank
ask
you
her for
everyone
medals.
for this. Thank you so much.
Thank you, ma'am. Thank you, Swati ma'am, for cooperating. You can continue with it.
అమ్మో మళ్ళీ కంపెనీస్ ఫస్ట్ చేసా. పాయింట్ వెళ్ళిపోన్నారు ఇంకా ఎక్స్పెరిమెంట్ నెక్స్ట్ అబ్జర్వేషన్ ఉంచు ఉంచు. Yeah. Okay, so coming back, only few slides, I'll just finish it up. So observational, we have already seen that there were case control and cohort studies, and included under this group are association studies, which are also called as cross-sectional studies. So translational, I'll just go through what I have reiterated. So you are implementing all the basic sciences into your clinical sciences. From the clinical sciences, you are now generating the guidelines, and these guidelines are now provided for your practice in real life. So this is what we are calling it from bench to bedside. So what is the role of medical education in it? We want to formally include it in under the undergraduate and the postgraduate curriculum. Need to understand the strategies of translational research and see to the development of it. From classroom to competence, improvise classroom to competence in the real life scenario. Okay, so these are some of the medical education publications. So after you have done, understood what is research, identified your topic, you have identified your design, research design, you have collected your data, then you started writing your story, now you have to, now you want to publish it. So what is that you are doing? You are doing is this as a part of your scholarship. Initially, you are just scholars. As teachers, we are scholars. Once we are into the research, we are doing something called scholarly work. After we have done with this, now from the scholarly work, you need to go into the scholarship. When is it becoming scholarship? Once you start publishing in it, good international index journals. So kindly have this difference, please. Scholarly work is, yes, you are a teacher, you are a good professor, you are a good teacher, but what is that you need to do? You have to change your trajectory from this scholarly to the scholarship. So now you need to publish it. So one sad part here is till 2017, our erstwhile MCI did not approve publications in medical education as a paper. We were, the medical education papers were not considered for promotions, but from 2017 onwards, probably that is right, madam, 2017 onwards a gazette has been released where one paper for each individual professor will be accepted as a paper and a research article. Okay, so this is one fresh breath of air for us, and people started producing more of research into the medical education. So these are some of the internationally acclaimed medical education journals. One is the medical teacher, and NMC had, now the present NMC has made that almost all medical colleges should have a medical education unit or a department. It should have specified infrastructure, should have people in it who are working on it, and definitely there should be a research going on underneath the medical education. So this medical education department is now a huge umbrella under which most of the colleges are doing the remaining educational projects in it. So these are some other journals here. So what I have done is, mistakenly or unknowingly, I did not put any concluding slide here, because research is never ending. So I don't want to conclude anything. Please go on doing research. That is most important point. We need not stop here. And I am again reiterating my points and saying it repeatedly. Medical education in India need to develop a lot. You youngsters have everything in your hands. Please bear the torches. Have the fire ignited in you. Read, not to say read. Please embrace medicine with your warm hands and in a very positive way. Don't think in a way that you just want to pass your exams, get your degree, then go to your postgraduate. I think many of you would have already even spoke of your PG seats here again. The UG and the PG combined. Yes or no? Yes? Wholesale ga maatladeskuntu untaru kada. ఇక్కడ యూజీ వచ్చి పీజీలో క్వాలిఫై అయితే ఇక్కడే చదువుతారు, తర్వాత స్పెషాలిటీకి విల్ గో, ఎస్ఆర్కి విల్ కమ్ అగైన్ హియర్, నథింగ్ హ్యాపెన్స్. అంతే, యుల్ గెట్ మ్యారీడ్, దెన్ యూ విల్ హ్యావ్ చిల్డ్రన్, దెన్ అంతే. ప్లీజ్ మేక్ సమ్ డిఫరెన్స్ టు ఆల్ ది యంగ్స్టర్స్. వీ ఆర్ ద పీపుల్ హూ ఆర్ మేకింగ్ డిఫరెన్స్ టు మై అండర్స్టాండింగ్. బట్ ఐ వాంట్ ఆల్ ది యంగ్ పీపుల్ హియర్ అపీలింగ్ యూ టు ఆల్, ప్లీజ్ డోంట్ బీ డార్మెంట్, ఇట్లా నేసెంట్గా పిచ్చి పిచ్చిగా ఉండబాకండి. అదేనా? సో బీ యాక్టివ్. ఓకే, సో ఆల్ ది బెస్ట్ టు ఆల్. థ్యాంక్ యూ ఆల్. So I want you people to know some of the international collaborations. Meek interest unte you can go through this. You have something called as American Association of American Medical Colleges, a good website where you can go in and have some international inputs. Then the Association of Medical Educators of Europe and international medical education, international, you have some of the website where you can identify important topics there. Then you also have something called as BMC, British Medical Council also. These are all important international websites where you can go through it. Okay, do not forget the national collaborators. We are always the tigers. Sorry, is it tiger? Very good, you all are awake. Fine. Okay, so most of we medical educationists, enthusiastic medical educationists are trained in ACME, that is Advanced Course in Medical Education, FIMER. Most of us are members in AHPA, and we are all now the members of APMEA, waiting for you people to come. Okay, thank you all. By the way, I am Dr. Swati, okay, from Pinnamanal Siddhartha Institute of Medical Sciences. Thank you.
Thank you, ma'am. It was very nice and elaborative. Due to paucity of time, Habila madam is telling we will not take any questions from anybody.
No.
One or two questions we can take it.
Yeah, please then.
Very
Madam has
genuine
allowed.
questions, please. Very Thank you, sir. Thank you.
Any questions?
Only genuine questions, please.
Okay, I want to just reiterate one point Madam wrote in the very beginning. Research is about new knowledge. So for UGs and PGs who are there, it's not fake knowledge, new knowledge. So how will you generate new knowledge? How will you avoid fake knowledge? You can knowingly or unknowingly you can generate fake knowledge. Now there is so much of pressure to do research for even for undergraduate. ICMR, STS, YSR, SHS, all these, even colleges are now promoting these things. So in order not to generate fake knowledge, you can unknowingly generate fake knowledge if you don't know the steps. She told you the steps, methodology. So before doing research, you should be very thorough with all those things. Then that unknowing part of generating fake knowledge will be can be taken care of. Then what is knowingly fake knowledge? You know everything, but you want to manipulate the data and you want to show a particular result. Both are very, very harmful to us. Whether knowingly or unknowingly, if you are generating fake knowledge, this is harmful for everybody, for the mankind, for everybody. So research is important and doing it in a correct way is more important. Okay, so that will be my message for all the undergraduate, postgraduates and even junior faculties and all of us who are here. Okay, so thank you, madam. Thank you once again. It was a nice session.
Thank you, sir.
I now request Dr. Jyoti Padmaja Madam to give away the memento to Swati Purnima Ma'am along with the chairpersons. పిల్లలు పెట్టచ్చు. ఆ మ్యూజిక్ వద్దంట మేడంకి పెప్పీ సాంగ్ పెట్టాలంట ఏదన్నా. శుభకరమైన మ్యూజిక్ మేడం, అది డిమోటివేటింగ్ కాదు, శుభకరమైన మ్యూజిక్. మేడం ఫోటోలో మ్యూజిక్ పడదంటలేండి. మేడం మొమెంటోస్ టు ద చైర్పర్సన్స్. సార్ ముందుకు రండి. Prize distribution, sir. We are calling it as prize distribution. ఇట్లా క్లోజ్ చేసేయచ్చా, క్లోజ్ చేయొచ్చా, ఊరికెలా పెట్టేయచ్చు. Thank you, ma'am.
Students, they will never forget. You have linked their pillu to research.
Due to paucity of time, we have cancelled the offline session of gamification in undergraduate curriculum, but shortly we'll be doing it on an online platform so that it reaches a wide audience. The date and time will be posted in the APMEDUCON groups and in the other groups. The CMA will be conducted online. Elaborately, we thought we'll cut short it now if it was offline, but online we'll elaborate it in depth. Okay, now we'll proceed to the prize distribution. You want to take it on? Please. The prize distributions. First, I request our principal ma'am, Dr. Lakshmi Lalta ma'am, our director sir, Dr. Ambedkar sir, Dr. Devi Madhvi ma'am, Dr. Ravi Venkatachalam sir, Dr. P.J. Srinivas, Dr. Ramprasad sir, and Dr. Jyoti Padmaja ma'am to please come onto the dais, and Dr. Supriya Panna ma'am. Supriya Panna ma'am. చెప్పేస్తాను. Dr. Venugopal Raju sir, the President-elect. Jairam sir, Jairam sir. కొత్త వాళ్ళు వేణుగోపాల్ సార్ కదా ఎవరు రాజు టెల్లర్.
అనౌన్స్ చేస్తే బాగుంటుంది.
న్యూ ఎగ్జిక్యూటివ్ అనౌన్స్ చేస్తే బాగుంటుంది.
కదా రామప్రసాద్
ఫోటో తీసావు కదా రాజు, రాజు ఫోటో తీసావు కదా.
We'll make an announcement about the new executive. President is Dr. Venugopal Raju.
Venugopal Raju should remember all the other names.
Sorry, later, madam. The AP Medical Educators Association newly elected president is Dr. Venugopal Raju sir. He is the vice principal of Ashram, professor and head of the Department of Physiology. The secretary.
Your secretary. Swati Purnima is the secretary.
Dr. Swati Purnima is secretary.
And vice president.
Vice president is Dr. Jairam. I am also one of the vice presidents.
Dr. Srihari.
Dr. Srihar Rao sir is the third vice president. Usually association has, for all the new members, there are 3 vice presidents and 3 joint secretaries, 1 treasurer and 1 secretary and 1 president. And Dr. Kiriti from SWIMS Tirupati is 1 joint secretary. Dr. Prabhakar Verma from MIMS is other joint secretary. So 3 joint secretaries, Dr. Purnima, Dr. Kiriti and Dr. Prabhakar Verma. And treasurer is Dr. Lavanya, KM Lavanya.
No, she is secretary.
Yeah, that's what I said. That's what I said. And the honorary secretaries and honorary treasurers remain the same. Honorary treasurer is PSN Raju and honorary secretary is Dr. Ramprasad. Mimmali medal you are sponsoring a medal.
Please, Raju sir and advisor, please come sir. Ren sir. Come Raju, please come.
Dr. Ravi Venkatachalam sir is a life permanent member advisor of the APMEDUCON.
Yeah. And I request Dr. Raju to come here. He's the person behind all the work, financial work we do or any queries we have related to MEDUCON. Dr. Raju.
And I would like to now call Dr. Nagendra Naidu sir, APMC observer, to please come on to the dais. So I'll begin with the prizes. Prizes are in the 3 categories. They are faculty, paper and poster, PG paper and poster, and then we have a student paper and poster, and then we have the last medal, which is the best innovation in medical education. So the first prize is, we have given it to Dr. Lavanya, that is the CS Murthy Memorial Best Faculty Research Paper. That's a medal. We have a second prize for that, Best Faculty Research Paper. Second prize goes to Dr. Ravi Kiran from Nimra. Madam, certificate. Faculty Research Paper. Second prize. Dr. B. Naganna Memorial Medal for Best Faculty Research Poster was awarded to Dr. Lavanya. The second prize goes to Dr. Sai Lahari, Associate Professor of Psychiatry from GEMS Medical College. The next award is Dr. V. Sunita Memorial Medal for Best PG Research Paper. This medal is sponsored by Dr. Supriya Panda ma'am. This award goes to Dr. K. Ravindra from RMC Kakinada. The second prize. The second prize goes to Dr. Rachana, again from RMC Kakinada. Best PG Research Poster. This award, this medal is sponsored by Dr. Balamurli sir, microbiologist presently working in in Gayatri. It is in memory of his father, Perala Lakshman Rao Memorial Best PG Research Poster. This award goes to Dr. C.H. Utpala, again from RMC Kakinada. For Best PG Research Poster goes to Dr. Rupini from GEMS Medical College. She is a postgraduate in community medicine. community medicine PGs. Srimati Sri C. Janaki Memorial Medal for Best Student Research Paper. This medal is sponsored by Dr. Ravi Venkatachalam sir. The first prize, the medal goes to Satvik Kupili from KIMS Samlapuram. Satvik Kupili from KIMS Samlapuram. Second prize goes to Sharat Chandra from GEMS Medical College. The next medal is Shri B.S. Rao Memorial Medal for Best Student Research Poster. This medal is again sponsored by Dr. Devi Madhvi Madam, and it goes to Sai Vivek Ampolu. From RIMS Srikakulam, Government Medical College Srikakulam. You can come and take it on his behalf. Both of them have worked, it seems he is the presenting author, so. Goes to Satvik Kupili. He is not here. Dr. I. Shakuntala Devi Memorial Medal for the Best Innovation in Medical Education. This is for the faculty, sponsored by Dr. I. Jyoti Padmaja ma'am. And this prize goes to Dr. P. Satyanarayan Raju, Professor of Physiology from Andhra Medical College. Yeah. All the other PGs and students and yeah, have you come, Vivek? Just come back. అది మళ్ళీ ఇచ్చి ఆయన తీసుకుని both of you have worked on it, no? So both of you come. This is Vivek Ampolu. B.S. Rao Memorial Medal for Best Student Research Poster, Sai Vivek Ampolu. second prize, yeah. So the Srimati C. Janaki Memorial. Srimati C. Janaki Memorial Medal for Best Student Research Paper goes to Satvik Kupili from KIMS Amlapuram. He also received the second prize for Best Student Research Poster. Both. First prize in paper, second prize in poster. KIMS Amlapuram. చేస్తారా నేను చెప్పేనా
We would like to show our appreciation. So I request our APMC observer, Dr. Nagendra Naidu Garu, to please come onto the dais to receive a small memento.
I request Dr. Ambedkar sir to please come onto the dais to give away the appreciations.
The medals are all made with pure silver with gold coating. So please keep them wrapped in that, the pink colored paper and put them in the box. Otherwise they'll become black with time. Otherwise they'll stay. Madam? They have the boxes. I don't think they're bronze or something. They're pure silver with gold coating. May I steal this opportunity and thank the organizing committee and the college, especially Dr. Lakshmi Lalita and Dr. Havila, on behalf of everyone. Thank you very much for a wonderful conference and the hospitality. Thank you very, very much. Okay.
Thank you, sir.
Undama.
Maybe you'll be more eloquent in your thank you.
Yes, sir, we have others. I would like to, ma'am, we would like to acknowledge and appreciate for the following people for their magnanimous support in all the way possible, in every way possible. We would like to take this moment to thank Dr. K. Padmaraju sir for a very magnanimous support financially. Because sir is not available. Sir has sponsored 1 lakh rupees for this. 1 lakh rupees for this conference. So thank you very much, sir. Thank you very much. We appreciate your support. I would like to acknowledge and thank Doc Tutorials. They have also supported us with all the registration kits and all the laptop bags and all which you are holding. That's all sponsored by Doc Tutorials. And I would like to thank Mr. Advik.
So Doc Tutorials is the PG training program associated with KIMS and a part of GEMS also. Right.
I would like to thank Dr. Balachandra Naidu, sir, Professor and Head of the Department of Biochemistry, for his magnanimous support. Sir, please come on to the dais and receive a small token of our appreciation. He is the one who took care of all our food arrangements. A very big thank you for a very tasty, sumptuous, varied menu, buffet items, and a very grand gala dinner. Thank you, sir.
Management always handles the job.
We would also like to acknowledge Dr. P.J. Naidu, sir, APMC member, Public Relations, IMA President, for his magnanimous support, sir. Okay. We'll hand it over. Thank you very much, sir, for your support. And I would also like to thank Dr. Someshwara Garu, Managing Director, KIMS, KIMS Srikakulam, and laparoscopic surgeon for his magnanimous support. Now I would like to thank Lakman from Vitalia. Are you here? Yeah, can you come and take it on his behalf? They have a stall there, simulation stall, and they have also contributed for the conference. So this is a small token of appreciation for Lukman. And one of the small contributions is also from Abbott Diagnostics, and I would like to appreciate and thank them for their contribution. I would, what was thanks? Any conference will not be complete without giving a proper vote of thanks. I would like to first thank Almighty God for giving us this opportunity and helping us throughout the conference. I would like to thank our Chief Mentor, Chairman, Dr. Bollineni Bhaskarrao sir, our CEO, Mr. Advik, and CEO, Sri Ram Mohan Garu, for helping us and supporting us all the way through the conference. A special thank you to our guest speakers, Dr. P.V. Chalam, Dr. Chetna Desai, Dr. Geeta Anjali, Dr. Nachiket, Dr. Animesh, for accepting our invitation and coming all the way here to deliver the guest lectures. Thank you very much. I would also acknowledge all our other speakers, Dr. Devi Madhvi Madam, Dr. Ravi Venkatachalam Sir, Dr. T. Venugopal Rao Garu, Dr. K.V. Ramprasad Garu, Dr. Lamanya, Dr. Manaswini, Dr. Jyoti Padmaja Ma'am, Dr. P.J. Srinivas Sir, Dr. Srinivasulu Sir, Dr. Padmaraju Sir, and Dr. Swati Purnima Madam, and all the chairpersons and judges who participated and actively in all the deliberations and the sessions. I would also like to thank the APMC observer, Dr. Nagendra Naidu Garu, for being here and patiently signing all the certificates also. Thank you, sir. I would like to acknowledge and thank the AP Medical Educators Association, Dr. Devi Madhvi Madam, Dr. P.J. Srinivas Sir, and Dr. Ramprasad Sir for giving us this opportunity to conduct this conference at GEMS. I would also like to acknowledge and thank Dr. Lakshmi Lalita ma'am, our principal, Dr. Ashok Reddy sir, medical superintendent, Dr. Sudhir sir, he is a senior management, Dr. Ramarao sir, who is a academic vice principal. All of them have thoroughly supported us and guided us all through. I would special thank you, and I request all the MU members to please come on to the dais. I request all the MU members of GEMS Medical College, please come on to the dais, please. All the MU members, please, can you please come on to the dais? I'm only the face of the MU, but all the hard work is done by all of us. All of us have contributed in every possible way. And these are the leaders who have helped in all the stages of the conference. I would like to thank Phase 3 Part 1 students. Phase 3 Part 1 students, can you please all quickly make a run across the stage, please? All the volunteers, they have done a great job at the food, IT, Akash. Yeah, I told them all to come inside. So can you just quickly come onto the stage?
You are getting the maximum number of claps now.
Please, please, please. Fast, fast. They have really done a great job, sir, taking care of the delegate, the guest speakers, right from the airport, picking them up, everything, every single thing they are there. They stayed till 10 o'clock, 11 o'clock in the night, and then came by 6 o'clock in the morning. A big thank you. Can we all have a big round of applause to them, please? They're the backbone for this conference. If they were not there, nothing would have happened. So thank you once again. Thank you, Part 1. Thank you. A big round of applause to all the fresh batch 2023 for patiently sitting and listening to all the sessions, motivating the speakers. Also, most of them addressed you also, right? So you were also part and parcel of the conference. Thank you so much for being here. I hope you have learned something from the sessions. There are few groups whom we cannot do without and thank without. The first one is the administrative staff. I would like to name a few. There are so many, but few. Mr. Suresh, Mr. Ramkumar, Mr. Sitaram. We call affectionately Chinna Naidu and Tall Naidu, Padu Naidu. Taudu, Kantarao, and the other housekeeping staff. Thank you very much for your support. They were also there till 10 in the night. IT people, Shekhar, Naresh, Shiva, and all others for their continuous support. And actually, we have got all the new ones, ma'am, for the conference. We told them all things. This was made only for the conference. Previously, this facility was not there. So, thank you. I would also acknowledge a big thank you to Ravi sir, Murli sir, Nirja ma'am, Pradeep sir, for their continuous support in all the activities. Food committee, I would like to thank Balchandra Naidu sir, Balamurli sir, Praveen sir, Swami, Mr. Swami and Purchase Murali for all their arrangements they have made, for a very grand arrangements they have made. A special thank you to Kumar, Mr. Kumar, for transport and accommodation he has arranged, for arranging everything in a neat way. Thank you, Mr. Kumar. Decoration, Suresh and Raghu, thank you. And the culturals, yesterday's banquet culturals, taken care of by Dr. Priyanka, Dr. Neeraja, thank you very much, and Dr. Ravi. Thank you very much for monitoring and organizing the students and their dances. If I missed anybody, it's purely because of ignorance.
Yeah, we missed. We have to specially congratulate and thank Havila, without whom, yeah. And also Havila, Jyotsna, they have really worked very, very hard. Samatha, all these people, they have worked very, very hard. Asal we lekpate conference ila jarigede kaadu. So we owe you a lot. Thank you so much for really doing it wonderfully well. Thank you so much.
So I know that after the vote of thanks, we usually do not speak, but it's also usually we give a feedback to the conference. So on behalf of the delegates and the APMEA, I think you deserve a big hand of applause once more. Dr. Lalita ma'am, you and your team have done a great job, and the truly, truly, truly interesting and amazing sessions. When I saw the theme, I was not sure how can there be so much in it, but it was a learning experience. Please give them a standing ovation. Rajshekhar, please come up. And the next thing which pops out to me is the arrangements which were made. Such excellent IT support, such a learning environment. Great support from your administration. Thank you on behalf of the thing. And the third thing is the students. I can never say that I have seen such a beautiful arrangements being made, and with such smile and grace, your students. Be it, I'll remember a few names, Vallabha, always here, and Ramya and Charishma. Charita or Charishma? So thank you for doing that, taking that customized care for all of us. Thank you so much.
I'm really sorry. I have to thank Nagarjuna. I'm really sorry, I missed your name, I forgot. He is the backbone of the IT, the head of the IT department. Thank you so much, Nagarjuna. I'm sorry.
You have been a fantastic host. You set a very high benchmark, and we'll take all sweet memories back home. And it will be a challenge for the Tirupati organizers next year to come up to expectations. Thank you very much. We had a very nice time. Have a nice day.
Nagarjuna, Janaganamana. Can we all please stand for Janaganamana, please? Thank you.
जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे